Now we are going to start the general surgery. First of all, we are going to discuss the hospital-acquired infection. So what's the definition of hospital-acquired infection? It's infection occurring within 48 hours of hospital admission or 3 days of discharge or 30 days of an operation. So 48 hours of admission or 3 days of discharge or 30 days of an operation. So how to remember it? The mnemonic is 2-3-30. It is 2-3-30. So 48 hours or 2 days of admission, 3 days of discharge, 30 days of an operation, that is hospital acquired infection. Now tell me, what is the most common hospital acquired infection? It is UTI. And what is the most common hospital acquired infection in surgical patient? That is surgical site infection. So see the types of hospital acquired infection. So first question, what is the most common hospital acquired infection? It is UTI. So UTI, that is most common hospital acquired infection. Second question, what is the most common hospital acquired infection in surgical patient? It is surgical site infection. So this is most common hospital acquired infection in surgical patient. Clear? Most common hospital acquired infection in surgical patient. So overall most common is UTI, followed by surgical site infection, followed by respiratory infection, followed by bacteremia, followed by antibiotic associated diarrhea. So how to remember? The mnemonic is, you can see here, the mnemonic is USSR ban. So it is USSR ban. So mnemonic, it is USSR ban. Clear? So what is the most common hospital acquired infection? You can see UTI. Second most common SS, surgical site infection. R, respiratory infection. B, bacteremia. And N, you can see antibiotic associated diarrhea. Clear? These are the questions. Now another important point. Tell me, what is the most common organism responsible for UTI? E. coli. And you know that in most of the surgical infections, most common organism responsible, that is E. coli. I'm repeating. What is the most common organism responsible for UTI? It is E. coli. And for most of the surgical infections, yes, the most common organism is E. coli. So see the situations or conditions where E. coli is the most common organism responsible for infection. So we discussed that what is the most common hospital acquired infection, that is UTI. So you can see here, this patient is having urinary tract infection, UTI. And what is the most common organism responsible for UTI? You can see E. coli. So the most common organism responsible, that is E. coli. After that, what will happen? You can see the infection reaches to urethra, and after urethra, it reaches prostate. And whenever it is going to reach the prostate, it is going to cause the infection of prostate. So in prostate, it is going to cause acute bacterial prostatitis, chronic bacterial prostatitis, and prostatic abscess. So what's the problem? In prostate, it is going to cause what? Acute bacterial prostatitis. It is going to cause chronic bacterial prostatitis, and what else? Prostatic abscess. Clear? It is going to cause prostatic abscess, right? So for all these three, acute bacterial prostatitis, chronic bacterial prostatitis, and prostatic abscess, you tell me, what is the organism responsible? Obviously E. coli. So for these, what? The organism responsible, it is E. coli. Clear? Okay. Another question, via prostate, you can see here, what happens? The ejaculatory duct, it is going to open close to the prostate. So what happens? The infection via this prostate, it is going to enter epididymis, and from epididymis, it can enter into the testis. So whenever there is involvement of epididymis, it is known as epididymitis. And if there is involvement of testis, it is known as orchitis. And whenever there is involvement of both epididymis plus testis, it is known as epididymoorchitis. So what is this infection? This is acute epididymoorchitis. So you can see here, this infection is, this is acute. This is acute epididymoorchitis. So acute epididymoorchitis in children, in elderly, in children, in elderly, and in homosexuals. Clear? So in children, in elderly, as well as in homosexuals, in all, what's the organism responsible? E. coli. Clear? You can see here. So acute epididymoorchitis in children, in elderly, and in homosexuals, again it is what? E. coli. Now see, some patients are having VUR. What do you mean by VUR? VUR means vesico-ureteric reflux. Clear? If the patient is having VUR, via this vesico-ureteric reflux, what will happen? The infection from the bladder, it is going into ureter, and from the ureter, it is going to reach to the kidney. And when infection reaches the kidney, what's the name of this infection? This is pyelonephritis. So in the kidney, there can be acute pyelonephritis, chronic pyelonephritis, emphysematous pyelonephritis, and sometimes even if there is perinephric abscess. So in all these cases, what is the most common organism responsible? Yes, it is E. coli. So here you can see in the kidney, whenever there is infection, clear? So whenever there is infection in the kidney, acute pyelonephritis, chronic pyelonephritis, emphysematous pyelonephritis, or perinephric abscess, in all these cases, what's the organism responsible? So in all these cases, the organism responsible, that is E. coli. Clear? So you can see in the whole genitourinary tract, for majority of infections, the organism is E. coli. Now see the infections related to hepatobiliary, pancreatic tract and GIT. Suppose the patient is having cholangitis, most common organism E. coli. If patient is having pyogenic liver abscess, where? Worldwide. So pyogenic liver abscess, worldwide. Spontaneous bacterial peritonitis in adults, patients who are having infected pancreatic necrosis or anorectal abscess. In all these cases, what is the most common organism responsible? The most common organism responsible, it is E. coli. So you saw that in majority of surgical infections, the most common organism responsible, that is E. coli. From the last 3-4 years, there are questions related to scoring system for severity of wound infection. And what are the questions we are asking? Southampton wound grading system and asepsis wound score. It's the Southampton wound grading system and asepsis wound score. You have to remember, we are going to discuss both of these. Now see Southampton wound grading system. How to remember? The mnemonic is there. For there are 0 to 5 grades, and how to remember? The mnemonic is NBE CPD. The mnemonic is NBE CPD. N means normal healing. B means whenever there is healing with bruising. So if there is normal healing with mild bruising or erythema, that is grade 1. So you can see here N, normal healing. B, that is bruising. So whenever there is normal healing with mild bruising or erythema, that is grade 1. Grade 2 is E. E means erythema. So whenever there is erythema plus other signs of inflammation, that is grade 2. After that C. C means clear or hemoserous discharge. That is for grade 3. After that CPD. P. P means pus collection. So it is grade 4. And D, if patient is having deep wound infection with or without tissue breakdown. Got it? So this is 0 to 5 grade. Total 6 grades are there, 0 to 5. And how to remember? NBE CPD. So you can see N, normal healing. B, bruising. E, erythema. C, there is clear or hemoserous discharge. P, pus collection. And D, deep wound infection with or without tissue breakdown. Clear? Now, this is the grade and appearance. After that, see the subtypes and appearance. This grade 1, which is normal healing with mild bruising or erythema, it is further divided into 1A, 1B, 1C. So what is 1A? 1A is having some bruising. So in 1A, there is some bruising. In 1A, there is some bruising. Clear? In 1B, there is considerable bruising. There is considerable bruising. Clear? And in 1C, these patients have mild erythema. So 1C, there is mild. 1C is having mild erythema. Clear? 1C, that's having mild erythema. Clear? After that, grade 2. Grade 2 is also divided into 2A, 2B, 2C, 2D. So 2A to 2D. Now here, there is erythema plus other signs of inflammation in grade 2. So in 2A, where if erythema plus other signs of inflammation are present at 1 point. If it's present at 1 point. Clear? So if it's present at 1 point, that's 2A. What about 2B? If it is present around the sutures. So if it is present around sutures. Around sutures. Clear? 2C, if it is present along the wound. Present along the wound. And 2D, if it is present around the wound. 2D, if it is present around the wound. Clear? After that 3, so grade 3 you can see here. In grade 3, there is clear or hemoserous discharge, right? Grade 3 is also divided into 3A, 3B, 3C, 3D. If there is clear or hemoserous discharge at 1 point only. So at 1 point only. At 1 point, that is 3A. And it's less than 2 centimeter. At 1 point, less than 2 centimeter. If it's along the wound, that's more than 2 centimeter, that is 2B. So if it's along the wound, here it's more than 2 centimeter. Clear? If the clear or hemoserous discharge is of large volume, and this was the question in one of the latest exam. It is 3C. This was the question in latest exam. 3C. Large volume clear or hemoserous discharge. What's the grade? It is 3C. And if it is prolonged, the discharge is prolonged means for how many days? More than 3 days. So whenever discharge is prolonged, there is prolonged discharge for more than 3 days. So whenever clear or hemoserous discharge, that's prolonged. Prolonged means it's for more than 3 days. Clear? After that, grade 4. Grade 4 means there is pus collection, which is further divided into 4A, 4B. If pus collection is at 1 point only, less than 2 centimeter, 4A, and if it's along the wound, which is more than 2 centimeter. So 4A here, it is at 1 point only. At 1 point only. At 1 point only. So it's less than 2 centimeter. Clear? And if it's along the wound, more than 2 centimeter. If it's along the wound, clear, it's more than 2 centimeter. So 4A, 4B. After that 5, here we discussed that there is deep wound infection with or without tissue breakdown. So you have to remember the grading, appearance and subtypes and appearance. So this is very, very important. This is Southampton wound grading system. The another one is asepsis wound score. Next is asepsis wound score. It's very easy to remember. Why? Because the mnemonic is also asepsis. So A means additional treatment. So what is the additional treatment given for the wound? Suppose patient is having wound infection. So what antibiotic is given? So if we are giving antibiotic for the wound infection, so antibiotics given for wound infection. If patient is having pus collection, so in that case what we are going to do? Drainage. So drainage of pus under local anesthesia. So what additional treatment is? Drainage of pus. And drainage of pus under local anesthesia. Or if there is infection, we can go for debridement. So debridement of wound under general anesthesia. So what's the additional treatment? Debridement. What? Wound debridement. So debridement of wound under general anesthesia. Clear? So this is additional treatment. Clear? So first additional treatment. S, what kind of discharge is there? Serous discharge. E, erythema. P, there is purulent exudate. S, separation of deep tissues. I, if there is isolation of bacteria from the wound. And S, stay as inpatients. And this stay is prolonged. Duration more than 14 days. So stay as inpatient. It is prolonged. It is, if the prolonged stay is there, it is prolonged for how many days? More than 14 days. And why the stay is prolonged? The stay is prolonged because of wound infection. So this is asepsis wound score. Clear? So A, additional treatment. S, serous discharge. E, erythema. P, purulent exudate. S, separation of deep tissue. I, isolation of bacteria from the wound. And stay as inpatient, which is prolonged, duration more than 14 days. So both you have to remember the Southampton wound grading system and asepsis wound score. Now see these two conditions. If you see the first one, in the first one you are going to notice that it is having well-defined margin. Can you see here? There is well-defined margin and it is associated with what? Vesicles or bulla. And can you see what is the site? It is going to involve what? Face. So there is involvement of face. There is involvement of cheek and what? Bridge of nose. There is involvement of face, cheek and bridge of nose. What's the name of this condition? This is erysipelas. Clear? And if you see the second one, it is having ill-defined margin. Can you see here? This is having ill-defined margin. So margins are not well defined. And what is the involvement site? It is going to involve the leg. This is cellulitis. In both of these, what is the similarity? That the most common organism is same. That is strep pyogenes. So we are going to discuss the differences. This is frequently asked question. Differences between erysipelas and cellulitis. So first we discuss that margins. See the margins. So margins in erysipelas, we discuss that it is well defined. So margins in erysipelas, this is well defined, but in cellulitis, it is ill defined. So there is indistinct margins. So it's not well defined. It's not well defined. It means what kind of margins? There is indistinct margins. Clear? The most common organism we discussed, it is same. What? Strep pyogenes. So most common organism, it is same in both. It is Streptococcus pyogenes. So this is strep pyogenes. Clear? Most common organism is same for both. If you see cellulitis, sometimes or rarely, Staph aureus is also responsible, but the most common organism, it is strep pyogenes in both. We discussed that in erysipelas, it is associated with what? Vesicles and bulla. So it is associated with vesicles and bulla. Bulla. Clear? But cellulitis, it is rarely associated. It is rarely associated with bulla. And if bulla formation is there, what happens? It is seen in severe cases. So what important point? Bulla formation in cellulitis, it is seen in severe cases. It is seen in severe cases. So there is involvement of which kind of tissues in erysipelas? If you see, there is involvement of upper subcutaneous tissue and lymphatics. So in erysipelas, there is involvement of upper subcutaneous tissue, and lymphatics. Clear? But in cellulitis, there is involvement of deeper subcutaneous tissue. So here, there is involvement of deeper subcutaneous tissue. Clear? What is the common site? We discussed that. The common site in erysipelas, face, cheeks, bridge of nose. So you saw here the common site. It is face, cheek, bridge of nose. Clear? So it's the bridge of nose. And cellulitis, usually it is seen in the legs. So what's the common site of cellulitis? It is seen in the legs. So what kind of questions are asked in exam? They ask you image-based question. They give you these images and then they ask you questions related to erysipelas and cellulitis. Now see this image and tell me what's the diagnosis. What you can see here? In this image, you can see that there is infected mass. Can you see here? Here, there is infected mass, and this infected mass, it is filled with dead tissue, and you can see the multiple openings, and via these multiple openings, what you can see? The pus discharge. So here, there is infected mass inside. You can see infected mass filled with dead tissue, and multiple openings are there over the skin surface, and from the skin surface, you can see there is pus draining onto the skin. Clear? This is carbuncle. What's the name? This is carbuncle. It's a dangerous situation, more common in diabetics and immunocompromised patients. What's the most common organism responsible? Staph aureus. And what is the most common site? It's the nape of neck. So it's carbuncle. It's carbuncle. Carbuncle. What's the most common organism we discussed? The most common organism responsible for carbuncle, important, it is Staph aureus. So what's the name? Organism is Staph aureus. Clear? It is Staph aureus. An important point, what is the most common site? It is nape of neck. Most common site, it's nape of neck. It's the nape of neck. Now you know that. What are the two common risk factors for most of the infections or majority of infections? One, diabetes mellitus, and the second is immunocompromised state. So if patient is diabetic, patient is immunocompromised, patient is having risk of majority of infections. So here also, it is more common in diabetics and immunocompromised patients. So here you can see that there is presence of infected mass with dead tissue and pus draining onto the skin. So obviously we have to drain it. And how we are going to drain it? Can you see here? We are going to give this kind of incision. Can you see here? This kind of incision is given. Clear? What is this incision? You can see here. It is crisscross incision or cruciate shaped incision. Similar incision is also given in which patient? The patients who are having anorectal abscess. This is known as cruciate shaped incision. So how we treat it? Treatment, it's I&D plus antibiotics. So we go for incision and drainage plus antibiotics. Clear? So it is incision and drainage plus antibiotics. And what kind of incision is given? It is cruciate shaped incision. So in this image, you can see this is the cruciate shaped incision. So what kind of incision is given? You can see here. This is cruciate shaped incision. Clear? It is cruciate shaped. Got it? So we gave cruciate shaped incision for drainage of carbuncle. Now see this image. What you can see here? There is thin brown exudate. Can you see here? Clear? You can see this bulla. It is having thin brown exudate. One thing, you're going to notice that there is thin brown exudate. Simultaneously, what else? You can see that there is spreading infection. Can you see here? Brownish discoloration. So thin brown exudate, simultaneously patient is having spreading infection. And what is the problem actually? This patient is having gas gangrene. So what is gas gangrene? Yes, there is presence of gas in gangrenous tissue. Name is gas gangrene. Easy to understand. So gas gangrene means there is presence of gas in gangrenous tissue. It means it is caused by gas producing organism. Can you tell me what is the most common organism responsible? Obviously it is Clostridium perfringens. So for gas gangrene, what's the most common organism responsible? That's Clostridium. Clear? It is Clostridium perfringens. It is Clostridium Perfringens. Clear? Perfringens. That's the most common organism responsible. You know that most of the wound infections or most of the infections, there are two common risk factors. What? Diabetes mellitus and immunocompromised state. This cause Clostridium perfringens. This is an anaerobe. So to grow, it want anaerobic condition. It means the wound which are having necrotic material or foreign material which is going to promote anaerobic environment. It is going to increase the risk of this infection. So what? Risk factors for this condition. Risk factors for gas gangrene. Two common risk factors for infection we discussed: diabetes mellitus. What else? Immunocompromised state, and any situation which is going to promote an aerobic environment. So situations which are going to promote an aerobic environment. An aerobic environment, like if patient is having wound which is having necrotic and foreign material. So wounds containing wound with necrotic or foreign material. Necrotic or foreign material. So wound with necrotic or foreign material. It is going to promote the anaerobic condition, and obviously it is going to increase the risk of gas gangrene. So here term is gas gangrene. Main problem, whenever these patients are coming to us, patients are having severe pain. So what's the big problem? These patients are having severe local pain. Patients are having severe local pain. Clear? Since there is presence of gas in gangrenous tissue, it means whenever you are going to palpate, obviously there is crepitus. So presence of gas, because of that what? On palpation there is crepitus. Gas in gangrenous tissue, so there is presence of crepitus. Another point we discussed that there is thin brown exudate and it is sweet smelling. So there are two characteristic features of gas gangrene. What? Gas plus smell. What are the characteristic features of gas gangrene? One is gas and smell. Gas and smell, these are the characteristic features. And what kind of smell is there? There is sweet smelling exudate. So there is sweet smelling exudate. Sweet smelling exudate. Clear? Now another situation which looks like gas gangrene, necrotizing fasciitis. If you see necrotizing fasciitis, the skin color is black. So it's very similar, but what are the differences? Necrotizing fasciitis, what? It's a polymicrobial infection in which there is necrosis up to the deep fascia. It means there is involvement of skin, superficial fascia and deep fascia. Necrotizing fasciitis. Muscle is typically spared in necrotizing fasciitis. But what's the big problem in gas gangrene? There is myonecrosis. So this is how you can easily differentiate it from necrotizing fasciitis. What? One of the characteristic feature is what? Myonecrosis. Clear? So in patients of gas gangrene, there is myonecrosis, but muscles are spared in necrotizing fasciitis. Now what's the treatment here? In gas gangrene, we have to start the treatment a bit early. So we have to give large doses of IV penicillin and we have to go for extensive debridement of affected tissue. So what we have to give? Large doses of IV penicillin. Large doses of IV penicillin plus extensive debridement. We have to go for extensive debridement of affected tissue. Clear? Extensive debridement. So extensive debridement of affected tissue. Now see this, it is also looking like gas gangrene, but what's the difference here? Can you see here? There is blackish discoloration. Can you see here? There is blackish discoloration of skin. So there is blackish discoloration of skin, there is erythema and edema, and if you do the palpation, on palpation there is woody hard texture of subcutaneous tissue. So blackish discoloration, there is erythema and edema. Clear? Blackish discoloration, erythema and edema, and if you perform the palpation, there is woody hard texture of subcutaneous tissue. Here there is necrosis up to the deep fascia only. So what's the name? Necrotizing fasciitis. So term is self-explanatory. Here there is necrosis of skin, superficial fascia, deep fascia. Typically muscle is spared. Typically muscle is spared. So what kind of infection is this? This is rapidly progressing bacterial infection in which there is involvement of skin, subcutaneous tissue, superficial fascia, deep fascia. Typically muscle is spared. Typically muscle is spared. Clear? Muscle is spared, and we discussed that in gas gangrene there is myonecrosis. What kind of infection is this? This is polymicrobial. So it's a polymicrobial infection, necrotizing fasciitis. Polymicrobial. So here both aerobes as well as anaerobes are responsible. So both aerobes as well as anaerobes, both aerobes as well as anaerobes are responsible for necrotizing fasciitis. But if the question is asked, what is the single most common organism responsible? It is group A, beta hemolytic streptococci. Single most common organism responsible. This is group A. It is group A, beta hemolytic streptococci. Clear? So group A, beta hemolytic streptococci. Clear? This is the single most common organism responsible for necrotizing fasciitis. Here also, the risk factors, two common risk factors are there like diabetes mellitus and immunocompromised state. Imagine the patients who are having necrotizing fasciitis, what's the presentation? Patients are coming to emergency and saying that, sir, I'm having severe pain. So our affected area, what's the problem? These patients are having severe pain. What's the presentation? Yes, most important presenting symptom, that's severe pain. In some patients, you are going to notice that even without treatment, the pain is going to decrease. And if pain decreases without treatment, it means it's an ominous sign. Why? Because what happens? If pain decreases without the treatment, it means there is thrombosis of vessels. And because of thrombosis of vessels, there is what? Destruction of nerves. So whenever pain decreases, if pain decreases without treatment, if pain decreases without treatment, it's an ominous sign. Why it's an ominous sign? Because there is thrombosis of vessels, small vessels, and there is destruction of nerves. So whenever there is destruction of peripheral nerve, obviously there is no pain. So you saw the appearance, how it looks like. There is blackish discoloration, there is erythema, edema, and if we perform palpation, what? There is woody hard texture of subcutaneous tissue. So important question. There is woody hard texture on palpation. Woody hard texture, clear, of subcutaneous tissue on palpation. Right? Now how we have to treat? First, we have to control the infection. Give IV fluids and IV antibiotics. After that, you have to go for urgent surgical debridement. And let me tell you, without surgical debridement, how much is the mortality? 100%. So what's the management here? Management, we have to give IV fluids and IV antibiotics. So we have to give IV fluids plus IV antibiotics. Clear? So apart from IV fluids and IV antibiotics, we have to go for urgent surgical debridement. Urgent surgical debridement. Clear? An important point, without surgical debridement, how much is the mortality? Clear? Without surgical debridement, there is 100% mortality in necrotizing fasciitis. We discussed what's the difference between necrotizing fasciitis and gas gangrene. In gas gangrene, there is myonecrosis. In necrotizing fasciitis, muscle is spared. Next condition is chronic burrowing ulcer. This is frequently asked question. What are the other names of chronic burrowing ulcer? It is also known as Melanese gangrene. Other name, it is also known as burrowing phagedenic ulcer, also known as progressive synergistic gangrene. First question. Why it is known as progressive synergistic gangrene? Because it is caused by synergistic infection of microaerophilic non-hemolytic streptococci and aerobic hemolytic staphylococci. Why it is known as progressive synergistic gangrene? Because it is caused by synergistic infection. This question is frequently asked. It is caused by synergistic infection. Clear? Synergistic infection of microaerophilic non-hemolytic streptococci and aerobic hemolytic staphylococci. Second, it is also known as chronic burrowing ulcer. Why it is known as chronic burrowing ulcer? Because these patients are having burrowing cutaneous fissures and sinus tract. Why the name is chronic burrowing ulcer? Because in these patients there are burrowing cutaneous fissures. There are burrowing cutaneous fissures and sinus tracts. Cutaneous fissures, clear, and sinus tracts. Sinus tracts, clear. So these patients are having burrowing cutaneous fissures and sinus tracts, and both are going to open at distal sites. These are going to opens at distal sites. Opens at distal sites. Distal sites. So the questions which are asked related to chronic burrowing ulcer, they ask the name and they ask the organism responsible. So it is caused by synergistic infection of microaerophilic non-hemolytic streptococci and aerobic hemolytic staphylococci. Now we are going to discuss the tuberculous lymphadenitis. You know that it is more common in children and young adults. And what is the most commonly affected lymph node? It is deep cervical lymph node. Most commonly affected lymph node, it is deep cervical lymph node. Clear? Now how this Mycobacterium tuberculosis enters these lymph nodes? So Mycobacterium tuberculosis enters through the tonsils, and then it is going to involve the access, or it is going to involve the deep cervical lymph nodes. Clear? So in tubercular lymphadenitis, the most commonly affected lymph node, important question, most commonly affected lymph node, that is deep cervical lymph node. Clear? So most common lymph node which is affected, deep cervical lymph node. And tubercular bacilli gain entrance through the tonsils. So there is entrance of organism, entrance through tonsils. Entrance through tonsils. What's the good thing? That in 80% cases, this tuberculous process is limited to the affected lymph nodes, right? But what's the problem? Suppose there is no treatment. So in absence of treatment, see initially what happens? Initially, these patients are having what? Only lymphadenitis. So there is inflammation of lymph node, lymphadenitis. So you are going to notice that there is presence of discrete, non-tender, firm or hard mobile lymph node. But what happens in absence of treatment? What happens? There is matting. And if there is matting, so what will happen? There is firm, non-tender, matted lymph nodes. So what's the problem? These lymph nodes are going to move together towards each other, and these are going to move together en masse. And because of periadenitis, it's going to happen. So this is matting. So what you're going to find? Matted lymph node. You're going to find the matted lymph node. In absence of treatment, what will happen? There is caseation. So if there is caseation of lymph node, what will happen? There is formation of abscess. So in absence of treatment, there is caseation of lymph node. If there is caseation of lymph node, there is cold abscess. And you can see here, this is the abscess, and this abscess is confined to the deep fascia. So it is located deep to deep fascia. So where is deep and superficial fascia? You can see this is superficial fascia, and this is deep fascia. This is known as cold abscess. What happens? Sometimes it is going to rupture through the deep fascia. So what happens if it's going to rupture through the deep fascia? Now it's going to travel where? It is deep to superficial fascia, and there is a rupture of one point. So what happens? There is rupture through the deep fascia under the skin. So what kind of abscess will be there? There is cross fluctuant abscess which is adherent to skin, and the name, it is known as collar stud abscess. Clear? Which is deep to superficial fascia, but what? It is cross fluctuant adherent to skin, and in some patients it is going to rupture. If it is going to rupture outside, what's the problem? There is formation of a sinus. Can you see here? There is formation of sinus if it ruptures outside. So these are the 5 stages of tuberculous lymphadenitis. Initially, there is lymphadenitis. Stage 2, there is matting. After that, there is cold abscess. When it ruptures through the deep fascia, it is collar stud abscess, and if it ruptures outside, it is sinus. There is formation of sinus. Now see the image of this sinus. Actually, these patients are having undermined edges. So in this image, you can see this patient is having the sinus after tuberculous lymphadenitis. Clear? And it is having what? Undermined edges. So this is the characteristic feature. There are undermined edges. It is tuberculous lymphadenitis. So obviously in the treatment, what we have to start? The treatment of tuberculous lymphadenitis, obviously we have to start ATT. But even after ATT, what happens? Some of the abscess is not going to resolve. So if abscess fails to resolve, in these cases, what we have to do? We have to excise the abscess cavity, lymph node and fibrous capsule. So if abscess fails to resolve, even after ATT, if abscess fails to resolve, if it fails to resolve, clear? So in this case, we have to go for excision of what? Excision of abscess cavity plus lymph node plus fibrous capsule. So abscess cavity, lymph node and fibrous capsule, this is excised when there is no response. This is how we treat tuberculous lymphadenitis. Next is enteric fever or typhoid. So tell me, what's the most common organism responsible? It is Salmonella typhi or paratyphi. So most common organism responsible for enteric fever, that is Salmonella typhi. It is Salmonella typhi or paratyphi. Clear? Typhi or paratyphi. Paratyphi. What is the most common cause of ileal perforation in tropical countries, especially India? So it is enteric fever. And what kind of perforation is there? You will notice that a very small perforation, especially in terminal ileum, is there. Clear? So sometimes it's an image based question in exam. In terminal ileum, there is a small perforation because of enteric fever or typhoid. What's the problem here? See, in enteric fever, there is ulceration and necrosis in ileocecal Pierce patches. What? Ulceration and necrosis in ileocecal Pierce patches. And because of that, there are ulcers in the distal ileum. What kind of ulcer is seen in typhoid? In typhoid, you're going to notice that there is longitudinal ulcer. And what kind of ulcer are there in tuberculosis? You are going to notice that there are transverse ulcers. So here you can see in the tuberculosis, these patients are having transverse ulcers, and in typhoid you can see longitudinal ulcers. So what's the problem? Ulceration and necrosis of ileocecal Pierce patches. So presence of ulcer where exactly in the distal ileum, and what kind of? There are longitudinal ulcers, right? What is the hallmark symptom? The patients, you have seen lots of people who are having typhoid. So what's the problem? They have high grade fever. Another problem, these patients are having abdominal pain. So hallmark symptoms are what? Hallmark symptom. These patients are having high grade fever. Patients are having high grade fever. Clear? These patients are having high grade fever. Simultaneously, patients are having abdominal pain. Patients are having abdominal pain. Clear? What's the most common complication? So you know that because of typhoid, there is paralytic ileus, and the second most common complication, intestinal hemorrhage. Another problem, if patient is not receiving the treatment, ileal perforation occurs. And during which week perforation occurs? During third week. So the question is, what's the most common complication of typhoid or enteric fever? We discussed it is paralytic ileus. This is paralytic ileus. Clear? So paralytic ileus followed by intestinal hemorrhage. Followed by intestinal hemorrhage. Clear? So it is paralytic ileus followed by intestinal hemorrhage, and we discussed that there is ileal perforation. We discussed that there is a small perforation in terminal ileum, and on which week perforation is going to occur? Perforation typically occurs during third week. So in absence of treatment, perforation occurs during third week. Clear? Next, there are characteristic signs of typhoid or enteric fever. So in the patients of enteric fever, you can find rose spots. There is splenomegaly. What happens? Typically, if the patient is having infection, you are going to notice that patient is having leukocytosis. But here, there is leukopenia. Apart from leukopenia, there is shift to left. Whenever patient is having high grade fever, obviously patient will be having tachycardia. But here, despite of high grade fever, patients are having relative bradycardia. So important points, there are rose spots, patient is having splenomegaly, there is leukopenia with shift to left, and there is relative bradycardia. Next is SIRS, frequently asked question. What is SIRS? This is systemic inflammatory response syndrome. It means it's the body's inflammatory response to infectious and non-infectious insult. What is systemic inflammatory response syndrome? Term is self-explanatory. It's the body's inflammatory response to infectious and non-infectious insult. First question, what are the mediators of SIRS? It is IL-1, IL-6, TNF-alpha. So it is IL-1, IL-6 and TNF-alpha. Clear? These are the mediators. Questions are asked that what are the parameters of SIRS? There are 4 parameters, and out of these 4 parameters, if 2 or more than 2 are positive, it means patient is having SIRS. So first, how to remember the parameters? The mnemonic is THR counts. Parameters are THR counts. Clear? It is THR counts. T, temperature, H, heart rate, R, respiratory rate, counts means WBC count. Now see, temperature, how much? Whenever the temperature is either more than 38 or less than 36 degrees centigrade. So temperature either more than 38 degrees centigrade or less than 36 degrees centigrade. Heart rate, how much? More than 90 per minute. Heart rate more than 90 per minute. Respiratory rate, how much? More than 20 per minute. Or PaCO2 is less than 32 mmHg. So respiratory rate more than 20 per minute or PaCO2 less than 32 mmHg. WBC count, either it is more than 12,000 per microliter, or it's less than 4,000 per microliter. So less than 4,000 per microliter, or more than 10% immature cells are there on peripheral smear. So you can see here how many parameters are there. THR counts 4 parameters, and out of these 4 parameters, if there are more than equal to 2 parameters are positive, it means patient is having SIRS. So more than equal to 2 parameters are positive, it means patient is having SIRS. See, certain definitions are asked. What's the definition of sepsis, severe sepsis and septic shock? First, sepsis. So whenever there is SIRS plus established source of infection or established focus of infection, so sepsis, it means SIRS plus there is established focus of infection. There is established focus of infection. Clear? So established focus of infection. Okay, that is sepsis. What is severe sepsis? Whenever there is sepsis with organ dysfunction and hypoperfusion, severe sepsis. So there is sepsis plus organ dysfunction and hypoperfusion. Organ dysfunction and hypoperfusion. Clear? Septic shock. So these patients are having severe sepsis, shock, not responding to IV fluid. So septic shock here, severe sepsis. These patients are having severe sepsis, not responding to IV fluids. Clear? Not responding to IV fluids. Clear? So severe sepsis not responding to IV fluids, that is septic shock. Next is MODS, that is multi-organ dysfunction syndrome. What is the meaning of multi-organ? So 2 or more than 2 organs. First, how many organs? 2 or more than 2 organs. Second, dysfunction. So these organs are having either physiological dysfunction and or failure. So 2 or more than 2 organs are having physiological dysfunction. Organs are having physiological dysfunction and or failure. Clear? So 2 or more than 2 organs which are having physiological dysfunction and or failure, that is MODS, multi-organ dysfunction syndrome. Next important point, we discussed that most common hospital acquired infection in surgical patient, it is surgical site infection. So how to prevent the wound infection? One of the most important factor is hand washing. So the most important factor in prevention of wound infection, that is hand washing of medical staff. So it's the hand washing. Second, whenever we take any patient for surgery, usually we go for part preparation, means hair removal prior to surgery. And if you are going for hair removal prior to surgery, tell me what is the best method for hair removal prior to surgery with minimum infection rate or least infection rate, that is on table clipping of hair. So for hair removal prior to surgery, we should go for on table clipping of hair. So on table clipping of hair, that's having least infection rate. Which method is having maximum infection rate? If we are going for pre-operative shaving. Why? Because if you go for pre-operative shaving, you are going to cause minor cuts, and because of those minor cuts, there is bacterial proliferation. So maximum risk of infection occurs after pre-operative shaving, followed by use of depilatory creams, followed by on-table clipping. So which method is having least infection rate? On-table clipping of hair. Next, use of prophylactic antibiotics. So question is asked, what's the best time to give prophylactic antibiotics? So best time to give antibiotics is at the time of induction. At induction of anesthesia. So best time is at induction or 30 minutes to 1 hour prior to surgery. Or 30 minutes to 1 hour prior to surgery. 30 minutes to 1 hour prior to surgery. Clear? In exam, they give you the options at induction of anesthesia or 1 hour prior to surgery. So you have to choose. Clear? Best answer is at induction or 1 hour prior to surgery. Clear? Next is cleaning of parts. So you know that if a patient is posted for abdominal surgery, in abdominal surgery, we are going to clean the patient from nipple to mid-thigh. How we are going to clean the patient? You can see the patient is cleaned from nipple to mid-thigh for abdominal surgery. And how we are going to clean it? Whenever we are cleaning the abdomen, we go from medial to lateral. So we go from medial to lateral in cleaning of abdomen, but in the perineum or genitalia, we go from lateral to medial. Why? Because you know that this perineum or genitalia, this area is most infectious. That's why here we go from lateral to medial, and in abdomen, we move medial to lateral. So while cleaning abdomen, the swab moves medial to lateral. While cleaning the thighs, the swab is going to move from lateral to medial because the most infected part is genitalia or perineum. Another important point, we have to maintain ideal OT parameters to prevent the infection. Next, how much should be the ideal temperature in the OT? The temperature should be between 18 to 25 degrees centigrade. So temperature 18 to 25 degrees centigrade. How much should be the relative humidity? It should be 50 to 60%. So relative humidity 50 to 60%. And how much should be the positive pressure? 2 mmHg above the atmospheric pressure. So positive pressure, it is 2 mmHg above atmospheric pressure. Above atmospheric pressure. Clear? How many air exchanges? So there should be 15 air exchanges per hour. How many air exchanges inside the OT? 15 air exchanges per hour. It should be 15 air exchanges per hour, and at least 4 out of these 15 should be of fresh air. So at least 4 should be of fresh air. So at least 4 air exchanges should be of fresh air. Should be of fresh air. So 15 air exchanges per hour, at least 4 should be of fresh air, and we have to maintain ultra clean laminar flow inside the OT. Questions are asked in relation to causes of post-operative fever. Suppose patient is having fever on post-operative day 1 or 2. What's the most common cause? Atelectasis. And you know, atelectasis means collapse of lung. This is non-infectious cause of fever in the first 48 hours. So post-operative day 1 or 2, most common cause of post-operative fever, that is atelectasis or collapse of lung. So it is atelectasis or collapse of lung. So it's a non-infectious cause of fever for the first 48 hours. Suppose patient is having fever for post-operative day 2nd or 3rd. So between post-operative day 2nd and 3rd, if fever is there, it is because of urinary tract infection, UTI. If it is between post-operative day 3 to 7, it is because of wound infection, that is known as surgical site infection. Between 5 to 7 days, post-operative day 5 to 7. So here patient is having DVT or thrombophlebitis. So fever is because of DVT or thrombophlebitis. DVT or thrombophlebitis. And if the fever is occurring after post-operative day 7, so it is because of drug. So it's drug fever. Drug fever. Clear? So these are the questions which are asked, causes of post-operative fever on the basis of post-operative day. Now there is a typical question which is asked in exam, that one intern was doing dressing between post-operative day 5 to 8. So between 5th to 8th post-operative day, one intern was doing dressing. And when intern was doing dressing, he notices that what? There is serosanguinous discharge or pink colored discharge or serous discharge. So there is serous, serosanguinous or pink colored discharge from the wound. It is suggestive of wound dehiscence or burst abdomen. So what is the name of this sign? Whenever there is passage of serous or serosanguinous or pink color discharge, this is known as Salmon fluid sign, and this is the first sign of wound dehiscence. So typically this wound dehiscence is going to occur on 5th to 8th post-operative day. What's the name? Burst abdomen. So typically it is going to occur on 5th to 8th post-operative day. Question: what is the first sign? What is the first sign? First sign of wound dehiscence, it is Salmon fluid sign. And what is Salmon fluid sign? We discussed that. Salmon fluid sign. Clear? Here typically there is passage of serosanguinous or pink color discharge from the wound. Now see, what are the types of wound dehiscence? It can be partial or total. Whenever there is total dehiscence with extrusion of viscera, so whenever there is extrusion of viscera after disruption of all the layers, this is evisceration. So types, it can be partial dehiscence or total dehiscence. And whenever there is total dehiscence with extrusion of abdominal viscera, that is evisceration. Clear? Now how to manage? Imagine patient is having partial dehiscence. So if patient is having partial dehiscence, in these cases we go for prompt elective closure. Clear? We are going to close the abdomen. So if, see the treatment, if patient is having partial dehiscence, the patients who are having partial dehiscence, in cases of partial dehiscence, we go for prompt elective closure. Clear? So here we go for prompt elective closure. Elective closure. The big problem is when the patient is having evisceration. So when the patient is having evisceration, first what you have to do, you have to cover the bowel. So cover the bowel with moist towel. So we have to cover the bowel with moist towel. After that, the exposed bowel, it is rinsed with ringer lactate containing antibiotics. After that, we are going to return this exposed bowel inside the peritoneal cavity. And how you are going to close the abdomen? You have to close the abdomen with the help of tension sutures. So whenever patient is having evisceration, in cases of evisceration, what we do? We have to cover the bowel with moist towel, then rinse the exposed bowel with ringer lactate containing antibiotic solution, put the bowel back to the peritoneal cavity, and after that we have to close the abdomen by tension suturing. So close the abdomen by tension suturing. Clear? How we do this tension suturing? In one exam, there was image-based question. In this image, you can notice that what? Abdomen is closed, and here you can see this is the tension suturing. Clear? So after closure of abdomen, we are going for tension suturing. So this is done for the patients in whom there is evisceration. So this is how we manage the patients of wound dehiscence, and this is all about general surgery. Now we are going to start the trauma. First of all, we are going to discuss the triage. What is the meaning of triage? Triage means to sort. So triage means to sort. So here it is prioritizing victims into various categories, especially in mass casualties. So suppose there is bomb blast or earthquake, we are going to prioritize victims into categories on the basis of triage tags. This is frequently asked question. So what are the triage tags? You can see here, red. Red means it signifies that immediate care is required. The patients in whom we are going to place this red tag, these are the most critically injured patients. So red. Whenever the triage tag is red, it means immediate care is required. Here, if the red tag is there, it means immediate care is required. So red means immediate care is required. It signifies that patient is most critically injured. So it is for most critically injured patient. Red, that is red, it signifies that immediate care is required, and this is for most critically injured patients. Clear? Most critically injured patients. This is for most critically injured patients. Okay. After that, it is yellow. Yellow signifies that the patient is less critically injured. Here, delayed care is required. It means in this category, patient requires in-hospital treatment. So what you have to remember, in yellow, delayed care is required. Here, delayed care. Clear? And this is for less critically injured patients, but these patients require in-hospital treatment. So this is for less critically injured patient. Right? But these patients require in-hospital treatment. Green is for ambulatory patients. Ambulatory patient means this patient is not having any life or limb-threatening injuries. So if in the patients there is no life or limb-threatening injury, we are using green tag. So green, this is for ambulatory patient. Green, it's used for ambulatory patient. Clear? Ambulatory patient. Here, there is no life or limb-threatening injury. So this patient is having no life or limb-threatening injury. So no life or limb-threatening injury. Limb-threatening injury. Clear? After that, it's black. Black means it's the expectant treatment, and this is for which patients? The patients who are dead or moribund. So here, we are not going for any kind of active intervention. So black is for dead or moribund patient. It is used for dead or moribund patients, and for these dead or moribund patient, obviously, no active treatment is required. So here, only expectant treatment. Here, no active treatment is required. So the questions are asked in exam. They will give you the tags and they will ask the description and what kind of treatment is required. Sometimes they give the example and after that ask that which color coding should be used for this patient. Example, suppose a patient is having head injury. Suppose a patient is having tension pneumothorax. Obviously, immediate care is required. So which triage tag should be used for this patient? Obviously, it's red. Now tell me the full form of ATLS. It is Advanced Trauma Life Support. ACLS, Advanced Cardiovascular Life Support. And BLS, that is Basic Life Support. So the question which is asked frequently, that according to these, which one is followed? ABC or CAB? So if you're talking about ATLS, Advanced Trauma Life Support, here we follow ABCDE. So according to ATLS protocol, we follow ABCDE. So this is airway, followed by breathing, followed by circulation, followed by disability, followed by exposure with environmental control. And if you're talking about advanced cardiovascular life support or basic life support, here we follow CAB. So according to ACLS or BLS, we follow CAB. CAB means circulation, followed by airway, followed by breathing. So in detail, we are going to discuss ATLS protocol. According to ATLS protocol, there is primary survey, there is secondary survey. So one by one, we are going to discuss. First, we are going to discuss the primary survey. So according to ATLS protocol, there is primary survey, there is secondary survey. Primary survey, it is aimed at detecting and simultaneously treating immediately life-threatening injuries. And we discussed that what sequence we have to follow. It is A, B, C, D, E. Here you can see A, that is airway maintenance with cervical spine protection. B, that is breathing. Breathing that includes ventilation and oxygenation. So breathing, which includes ventilation. It includes ventilation and oxygenation. So ventilation and oxygenation, clear? C is circulation with external hemorrhage control. D, that is disability limitation. So here we perform brief neurological examination. So D, disability. So in this we perform brief neurological examination. We perform brief neurological examination. Clear? And E, that is exposure with environmental control. Why environmental control? To prevent the hypothermia. So this is A, B, C, D, E. One by one we are going to discuss. First, see the airway maintenance with cervical spine protection. So one by one we are going to discuss. First, A means airway maintenance with cervical spine protection. So you know that in all patients of trauma, cervical spine injury should be suspected. So question is asked that the first priority should be given to airway maintenance or cervical spine protection. Since cervical spine injury should be suspected in all patients of trauma, the first priority should be given to cervical spine protection. So what's the first priority here? The first priority, it is cervical spine protection followed by airway maintenance. This you have to remember. So it is cervical spine protection. It is cervical spine protection followed by airway maintenance. Clear? So it is cervical spine protection followed by airway maintenance. Clear? So the first priority should be given to cervical spine protection. Next, what should be the stepwise progression if a patient is having compromised airway? So in this case, first we have to clear the airway. How? By suctioning of secretions, or if blood is there in the oral cavity. After that, we have to go for chin lift, jaw thrust, and after that, insertion of oropharyngeal or nasopharyngeal airway. So if a patient is having compromised airway, first we have to clear the airway by suctioning the secretions or blood present in the oral cavity. So clear the airway by suctioning. We have to clear the airway by suctioning. After that, we have to perform the chin lift, jaw thrust, and after that, insertion of oropharyngeal or nasopharyngeal airway. The question which is asked frequently, that what is the definitive airway of choice in most of the trauma patients? Question, what is the definitive airway of choice? What's the definitive airway of choice? Definitive airway of choice in most of the trauma patient. Clear? And the definitive airway of choice, that is what? Oral endotracheal intubation with cuffed ET tube. So what is this? This is oral. It's the oral endotracheal intubation. So that's oral endotracheal intubation with cuffed ET tube. Cuffed endotracheal tube. Clear? Cuffed endotracheal tube. So oral endotracheal intubation with cuffed ET tube. Clear? Another important question, it was asked many times in exam. Imagine a patient is having severe maxillofacial trauma. So if a patient is having severe maxillofacial trauma here, what is the emergency airway of choice and what is the definitive airway of choice? So the patients who are having severe maxillofacial trauma, obviously the emergency airway of choice, we have to save the life of patients. So what we go for? Needle cricothyroidotomy. And the definitive airway of choice, obviously it is tracheostomy. So emergency airway of choice, that's needle cricothyroidotomy. Clear? So it's needle cricothyroidotomy. So it's the needle cricothyroidotomy. And what is the definitive airway of choice? Definitive airway of choice, that is tracheostomy. That's tracheostomy. So this was asked many times. You have to remember facial trauma or especially severe maxillofacial injuries. Here, emergency airway of choice, that's needle cricothyroidotomy, and definitive airway of choice, that's tracheostomy. The next component is B. B means breathing, and we discussed that it includes ventilation and oxygenation. Suppose any patient who is brought to your emergency and airway patency has been maintained, or airway is patent, still patient is having dyspnea or tachypnea. So despite of patent airway, still patient is having dyspnea or tachypnea. It means there is some problem with ventilation. Ventilation means patient might be having tension pneumothorax. There can be massive hemothorax or massive pulmonary contusion. So what we do in breathing, we have to assess the breathing. We have to assess the rate and depth where the patient is having dyspnea or tachypnea, and we have to assess the oxygen saturation. Suppose despite of patent airway, patient is having dyspnea, tachypnea, if saturation is not normal, in those cases we have to suspect ventilation problems. So B is, we have to assess the breathing, we have to assess the rate and depth and oxygen saturation, and if patient is having dyspnea, tachypnea, it can be because of ventilation problems. Now see the important causes of ventilation problems. We discussed tension pneumothorax, massive hemothorax, or massive pulmonary contusion. If patient is having tension pneumothorax or massive hemothorax, can you tell me what is the treatment of choice? For tension pneumothorax and massive hemothorax, we go for ICD insertion. So what is the treatment of choice here? We go for ICD insertion, and you know that what is the site of ICD insertion? We are going to insert intercostal drain or chest tube in 5th intercostal space in anterior axillary line in triangle of safety. And if patient is having massive pulmonary contusion, these patients require aggressive mechanical ventilation. So if there is massive pulmonary contusion, these patients require aggressive mechanical ventilation. Aggressive mechanical ventilation. So these patients require aggressive mechanical ventilation. Next is C. C means circulation with hemorrhage control. So we have to assess the circulation. What is the primary goal to assess the circulation? We have to look for signs and symptoms of shock. And you know that in patients of trauma, what is the most common type of shock? Obviously, it's because of bleeding. So this is because of bleeding or hemorrhage. So what is the type of shock? It is hypovolemic shock. So what is the most common cause of shock in patients of trauma? What's the most common cause? Most common cause of shock in patients of trauma. So most common cause of shock in trauma patients, that's bleeding. So what kind of shock is there? Since there is bleeding, obviously it's hypovolemic shock. Since there is bleeding, obviously these patients are having hypovolemic shock. Hypovolemic shock. Clear? So we have to assess the vitals in these patients. Vitals means we have to assess the pulse rate, we have to assess the systolic blood pressure. Imagine patient is having tachycardia when the pulse rate is more than 100, or patient systolic blood pressure is less than 100. This is considered as unstable vitals. What is the definition of unstable vitals? You have to remember unstable vitals. Yes, this is very useful for trauma patients. Unstable vitals definition. Yes, so remember the cutoff is 100, pulse rate more than 100, systolic blood pressure less than 100. So here, pulse rate, how much? It is more than 100 per minute. Clear? And systolic blood pressure obviously less than 100 mmHg. So systolic blood pressure, that is less than 100 mmHg. So any patient in whom there is unstable vitals, obviously patient is having shock. So whenever you suspect shock, in all patients you have to put 2 large bore IV cannula, preferably green 18 gauge. So we have to put 2 large bore IV cannula, send the blood for cross match, and we have to give warm isotonic crystalloid solution. Initially it was said that what's the amount of warm isotonic crystalloid solution given in adults? Initially it was 1 to 2 liters, but according to latest ATLS modification, nowadays we give only 1 liter of warm isotonic crystalloid solution. So in these patients, we have to put 2 large bore IV cannula, preferably green, so 18 gauge, send the blood for cross match, and we have to give warm isotonic crystalloid solution. How much? Previously it was said that 1 to 2 liters. Previously it was said that 1 to 2 liters of warm isotonic crystalloids are given. Warm isotonic crystalloids. Clear? Are given previously, but there is ATLS modification. Nowadays it is said that at the place of 1 to 2 liters, what? Nowadays only 1 liter. only 1 liter of warm isotonic crystalloids are given in adults. So in adults, only 1 liter is given. At the place of 1 to 2 liters, in adults, only 1 liter of warm isotonic crystalloids are given. If we are talking about children, in children we are giving 20 ml per kg. In children, how much we give? You have to remember, in children we give 20 ml per kg. So it's 20 ml per kg of warm isotonic crystalloids. In children, obviously weight less than 40 kg. So in children, body weight less than 40 kg, clear? We have to give 20 ml per kg of warm isotonic crystalloids. So you have to remember these two values. These two are asked frequently. Clear? In adults, it is 1 liter, and in children, it is 20 ml per kg. What are those 5 areas where massive bleeding can occur and that can lead to shock? How to remember? It is on the floor, 4 more. On the floor means external blood loss at the site of accident or at the site of injury. So it's the external blood loss at the site of accident or at the site of injury. 1. Second, chest. In chest, there can be collection of blood, that's hemothorax. Third, it's abdomen. In abdomen, if huge amount of blood is collected, it is hemoperitoneum. After that, retroperitoneum. Why? Because some patients in whom there is pelvic fracture, there can be retroperitoneal hematoma. And fifth, what? Long bone fractures. So what are the locations of massive blood loss? How to remember? On the floor plus 4 more. On the floor plus 4 more. Total 5 locations. So it is on the floor plus 4 more. On the floor means external blood loss at the site of accident. So external blood loss at the site of accident. Clear? After that, chest. What kind of blood loss in chest? Obviously, if the blood is collected in the thorax, it is hemothorax. If blood is collected in the abdominal cavity or peritoneal cavity, that is hemoperitoneum. So what's the name? This is hemoperitoneum. Clear? Hemoperitoneum. In retroperitoneum, blood is collected. Obviously, it's retroperitoneal hematoma. One of the causes, pelvic fracture. So if there is collection of blood in retroperitoneum, one of the cause, that's pelvic fracture. It's pelvic fracture. And because of multiple long bone fractures, also massive blood loss can occur. Clear? Now, there is another question which is related to this. The question is asked that what are the investigations which are done in primary survey? Now see, it's easy to understand. Investigations done. Clear? First, since the blood is collected in the thorax, it is hemothorax. How will you make the diagnosis? So if there is hemothorax, for that, which investigation is done? We go for chest x-ray. So we go for chest x-ray PA view. Chest x-ray PA view. If there is collection of blood in abdomen, you want to assess the abdomen bedside, obviously we go for fast. Whenever there is pelvic fracture, obviously we go for x-ray pelvis, AP view. So here what? X-ray pelvis, AP view. It is AP view. You have to remember the views also. So what are the investigations which are done in the primary survey? You can see these are the investigations which are done in primary survey. We go for chest x-ray PA view. We go for fast. We go for x-ray pelvis AP view. These can be done bedside. So this question was asked in one of the latest exam, that which of the following investigation is not done in primary survey. So CT is not the part. So CT scan is not the part of primary survey. Chest x-ray PA view, x-ray pelvis AP view, fast, these are the parts of primary survey. This is one question. Second question which is asked, that what are the two most important x-rays in trauma patient? You can see here, chest x-ray PA view and x-ray pelvis AP view. Why? Because with the help of chest x-ray, you can diagnose hemothorax, pneumothorax, and you can easily detect what? Pneumoperitoneum because of perforation. Clear? So what are the two most important x-rays in trauma patients? In trauma patients, two most important x-rays are, yes, chest x-ray PA view. This is chest x-ray PA view and x-ray pelvis AP view. Clear? X-ray pelvis AP view. Clear? X-ray pelvis AP view. These are the two most important x-rays, right? Now imagine the patient again. We put 2 large bore IV cannula. We started the fluid also. Imagine still patient is having signs and symptoms of ongoing shock. So if patient is not improving after fluid resuscitation, in those cases we have to start the blood transfusion. So in non-responding patients who are having ongoing signs and symptoms of shock, in those patients what? First, manage ongoing bleeding. If the patient is having, patients who are having ongoing signs of shock, despite of fluid resuscitation, still patient is not improving. So here, first we have to manage ongoing bleeding. So manage ongoing bleeding. Manage ongoing bleeding. And second, very important, what? Blood transfusion. We have to start blood transfusion. Blood transfusion. And the question which is asked frequently in relation to blood transfusion, in trauma patient we follow trauma transfusion protocol. So according to trauma transfusion protocol, we have to give packed cell, plasma, platelets in ratio of 1:1:1. This you have to remember. So in blood transfusion, what protocol we follow in trauma patients? It's known as trauma transfusion protocol. So name is trauma transfusion protocol. So this is trauma transfusion protocol. Clear? And according to trauma transfusion protocol, we have to give packed cell, plasma and platelets in the ratio of 1:1:1. So we have to give what? Packed cell, plasma and platelets. Packed cell, plasma and platelets. Clear? The question is asked the ratio, and I'm repeating, it's very, very important. Ratio is 1:1:1. So in the ratio is 1:1:1. Next is D. D means disability, where we perform brief neurological examination. So what we have to assess here? We have to assess the GCS. We have to assess Glasgow Coma Scale, assess GCS, and the patients in whom you cannot assess GCS, we have to assess the pupils. So assess GCS and assess pupils. Clear? So here we assess GCS and here we are going to assess the pupils. In pupils, what we have to look for? We have to look for size, reaction and equality. So in pupils, what we have to look for? We have to look for size, reaction and equality. Size, reaction and equality. Clear? One question which is asked almost every year in each and every paper, that is GCS, Glasgow Coma Scale. And you know that the Glasgow Coma Scale was revised in 2014. So we are going to discuss the revised GCS. So what are the components of GCS? First, eye opening, second is verbal response, and third is best motor response. Question is asked, out of these three, which one is the best predictor of survival? So how to remember? The best predictor of survival, that is best motor response. Sometimes in the option they don't mention best. So best motor response or motor response, this is the best predictor of survival. So motor response, this is best predictor of survival. This is first question. Best predictor of survival. Clear? So this is best predictor of survival. Best motor response or motor response. Now see the components. First see the components of eye opening. If the patient is having spontaneous eye opening, the score is E4. It is E4. If it is to loud voice, previously loud voice word was mentioned, and in 2014 update, at the place of loud voice, speech is mentioned. So speech is mentioned. So if patient is having eye opening to loud voice or speech, here it is E3. If it is to pain, previously pain was mentioned, and in 2014 update there is pressure. So if eye opening to pain or pressure, this is E2, and any patient in whom there is no response, obviously it is E1. Right? After that, see the verbal response. Imagine patient is oriented. So here it is V5. If patient is disoriented or confused, the score is V4. Patient is using inappropriate words. Previously it was mentioned inappropriate words, but according to GCS 2014 update, only words are there. So if patient is speaking words, inappropriate words or words, it is V3. And previously incomprehensible sound was mentioned. Incomprehensible sound means A, E, O. Nowadays only sounds are mentioned if patient is producing some sound. So here the score is V2, and obviously if no response is there, the score is V1. Clear? So oriented V5, disoriented or confused V4. Patient is using inappropriate words, that's V3. Patient is producing incomprehensible sound V2, and no response, it's V1. Now see the motor response. If patient is going to obey commands, follow the commands or obey commands, here the score is M6. If patient localizes pain, it is M5. If patient is having withdrawal to pain, that is normal flexion response. So if there is normal flexion response, that is withdrawal to pain, here it's M4. If there is abnormal flexion posturing, it's M3. If there is extension posturing, this is M2, and if there is no response, that is M1. Clear? So this is how we have to remember the GCS. It's very, very important. Almost every year this is asked. How to remember? Eye opening is easy to remember because 4 components are there. E4, spontaneous eye opening. E3, to loud voice or speech. E2, to pain or pressure, and even no response. How to remember the verbal response? The mnemonic is one confused word sounds nowhere. So you can see here, the mnemonic is one confused word sounds nowhere. Mnemonic is one confused word. One confused word sounds nowhere. So 1, that is O means oriented. Oriented means here the score is 5, V5. Confused, so patient is disoriented or confused. Here it is V4. Patient is using words. So what? V3. Inappropriate words, sounds, incomprehensible sounds. V2. And no, nowhere, no response. It is V1. Clear? How to remember the best motor response? Here also the mnemonic is there. Obey localities with flexion and extension. Here, what's the mnemonic? Obey localities. Obey localities. Clear? So obey localities with flexion and extension. Obey localities with flexion and extension. Flexion and extension. Clear? So first, obey. Obey means patient obey commands. So if patient obeys command, it is M6. 6. Localities means patient localizes pain. Here see, obey commands. Localities, localizes pain. With, withdrawal to pain. Flexion, extension. Clear? So here, localities means localizes pain. Here, the score is M5. With, that is withdrawal to pain. That's normal flexion response. That's M4. Flexion. So abnormal flexion posturing. It's M3. Abnormal extension posturing. That's M2. And obviously, it's M1, which is no response. Clear? So this is GCS. I'm repeating. It's very, very important. And if you see here, what's the maximum score? It is E4, V5, M6. You can see here, what's the maximum score in GCS? You can see, it is maximum score in GCS. It is E4, V5, M6. So the maximum score is 15. And if you see the minimum score, that's E1, V1, M1. So it's E1, V1, M1. It is 3. So GCS score varies from 3 to 15. Another question, GCS score varies from 3 to 15. And we discussed that. So what is the best predictor of outcome? We discussed that the best predictor of outcome or best predictor of survival, that is best motor response. Clear? Now, on the basis of GCS, head injury is divided into mild head injury, moderate and severe. So see the types of head injury on the basis of GCS. In mild, how much is the GCS score? It is 13 to 15. This is one of the frequently asked questions. GCS 13 to 15. If it's moderate, the score is 9 to 12. And in severe cases, severe head injury, it is less than equal to 8. Less than equal to 8, that is severe, right? Next, so what is the problem in exam? They are going to describe one particular situation and you have to calculate the GCS. One situation. Second, sometimes they are going to mention that one of the parameter is non-testable. Example, suppose in a patient there is tracheostomy. If tracheostomy is there in any patient, obviously you cannot assess the verbal response. So if you cannot assess any response, so we are supposed to mention NT against that response, means that response is non-testable. If a patient is having tracheostomy, so obviously in front of V, in front of verbal response, we have to write NT. So for any non-testable parameter, NT should be added. So NT, this is non-testable. So NT, it is added in front of the parameter if it is non-testable. For non-testable parameter, we are supposed to add NT. So if verbal response is non-testable, obviously it is mentioned VNT. Previously, additional score of 1 was assigned to non-testable parameter. But nowadays, additional score of 1 is not assigned for non-testable parameter. Let's discuss with one example. Suppose a patient is having spontaneous eye opening. Obviously, it is E4. There is spontaneous eye opening. Patient is having tracheostomy. So obviously, verbal response, it is non-testable, and patient localizes pain. So obviously it is M5. I'm repeating. Patient is having spontaneous eye opening, that is E4. Non-testable parameter tracheostomy is there. So VNT, and patient is localizing pain. It is M5. So how much is the total score? How to write it? We are going to write it 9 VNT. We are supposed to write 9 VNT. Suppose in the options are 9, 10, 11, 12. So what you're going to mark? You are going to mark 9, because additional score of 1 is not assigned nowadays for non-testable parameter. And these are the kind of questions which are asked frequently nowadays. So next is secondary survey. In secondary survey, we have to obtain ample history from the patient or relatives. And second, it is the systemic assessment from head to toe to rule out non-life threatening injuries. So first see, we have to obtain ample history from patient or relative. So what is the meaning of ample history? A means history of allergy. So we have to ask the patient or relative whether patient is having some kind of allergy or not. M, what kind of medications patient is using. P, patient was having some significant history of past illness, or whether patient is pregnant or not. So history of past illness or pregnancy. What's about the last meal, when patient had the last meal. And E, if the relative saw that kind of accident, or the relative was present at the scene of accident. So events related to injury we have to ask. So it's allergies, medication, past illness or pregnancy, last meal, and events related to injury. This is ample history. And if patient is in condition to provide the history, we take the history from patient. Otherwise, we take the history from relative. Now what? In secondary survey, it is the head-to-toe systemic examination to rule out non-life-threatening injury. So see here, what we are going to do. So in secondary survey, we have to perform the examination of head and first, second, examination of neck, third, examination of chest, fourth, examination of abdomen, fifth, examination of back, sixth, examination of extremities, and seventh is the repeat neurological examination. So the same sequence is followed every time. So what? Examination of head and face. Why we want to examine the head and face? Because we want to rule out fracture and laceration. This is the sign of fracture. So to rule out fracture or laceration. Neck, we want to rule out the neck injuries. Chest, we want to rule out the injuries to the chest, especially rib fracture. So rule out rib fracture. We have to rule out rib fracture. Clear? Abdomen examination is important because we have to look for external signs of injury, and we have to rule out intra-abdominal organ injury. So what we have to do? Look for pain, look for any kind of tenderness, look for guarding. And during examination of abdomen, we have to go for insertion of nasogastric tube and Foley's catheter, right? Whenever you are planning to insert the nasogastric tube, what? If you are planning to insert the nasogastric tube, you have to rule out the facial trauma. If there is no facial trauma, obviously we go for what? Nasogastric tube insertion. So nasogastric tube insertion is done. Clear? In majority of patients. But imagine patient is having facial trauma. So if patient is having facial trauma, so in facial trauma patient, we go for orogastric tube insertion. Here, facial trauma patient, what? Orogastric tube insertion. Orogastric tube insertion. Clear? Why? Because if patient is having facial trauma, there might be injury to cribriform plate. Clear? Next, we have to insert the Foley's. Before inserting Foley's, you have to rule out the presence of blood at meatus. Why? Because if there is presence of blood at meatus, we have to suspect urethral injury. So if there is no blood at meatus, Foley's catheterization is done. So second thing, in abdominal examination, what? Foley's catheterization. Foley's catheterization. Not in all patients. First, there should not be any blood at the meatus. If there is no blood at meatus, we go for Foley's catheterization. Important question is asked related to back. Back. What is the name of examination of back? This is also known as log roll. Examination of back, that is also known as log roll. What's the ideal number of people required for log roll or examination of back? 5. And minimum number of people required for examination of back? 4. So 2 questions. For log roll, what's the ideal number of people required? Ideal number of people required for log roll, it's 5. And minimum number of people required? Minimum number of people required 4. So ideal number 5, minimum number 4. Whenever we are performing the examination of back, we perform digital rectal examination only. So during examination of back, digital rectal examination is also done. Next is examination of extremities. So obviously in extremities, what we have to do? Mainly we have to rule out the fracture. So examination of extremities here. we have to rule out the fracture, right? So what we have to look for? We have to look for tenderness, we have to look for crepitus, any kind of abnormal movement or deformity. So look for crepitus, abnormal movement, deformity, or any kind of tenderness. So what? We have to rule out the fracture. And the seventh step is repeat neurological examination. So we have to follow the same sequence in secondary survey. Trauma scoring systems are very important. It is asked frequently nowadays. First is revised trauma score. It is also known as RTS. In short, this is known as RTS, revised trauma score. So what are the components? The mnemonic is GB road. Don't go to this road. Clear? So it is GB road. Clear? Don't go to this road. Clear? So G, that is GCS. B, blood pressure. Which one? Systolic. So G means Glasgow Coma Scale. It is GCS. B, blood pressure. What kind of blood pressure? It is systolic blood pressure. That is systolic blood pressure. It is systolic blood pressure. And road, that is respiratory rate. So easy to remember. Now you will not forget. Revised trauma score. After that, trauma and injury severity score. How to remember? Here the mnemonic is TRIS. It is trauma and injury severity score. So you can see here one component is injury severity score. So how to remember? Mnemonic is injury severity score. It is injury severity score plus RAM. So one component is injury severity score. Mnemonic is R. R means revised trauma score. A means age. So revised trauma score. Age. M means mechanism. What kind of injury was there? Blunt or penetrating? So it's mechanism. It is mechanism. So how many components are there? There are 4 components. Injury severity score, revised trauma score, age, mechanism. Next is mangled extremity severity score. In short form, we call it as MES. So it is MES. How to remember? Here the mnemonic is ELISA. The mnemonic is ELISA. Clear? It is ELISA. Right? So this is E, energy. L, I, limb ischemia. S, shock. A, age. So here E, that's energy. It's the energy. Li, that's limb ischemia. This is limb ischemia. S, that's shock, and age. It is shock and age. Clear? So this is very, very important. Revised trauma score. Components are Glasgow Coma Scale, systolic blood pressure, respiratory rate. TRIS, that is trauma and injury severity score. Here injury severity score plus revised trauma score, age, mechanism, and mangled extremity severity score. Mnemonic is ELISA. So that is energy, limb ischemia, shock, and age. Now we are going to discuss the head injury. First of all, we are going to discuss the skull base fracture. What is the incidence? Skull base fracture is further divided into anterior cranial fossa fracture, middle cranial fossa fracture, and posterior cranial fossa fracture. So you tell me which one is most common. Here you can see it's the anterior cranial fossa fracture which is most common. So how much is the incidence? You see anterior cranial fossa fracture. This is responsible for 70% cases. So anterior cranial fossa fracture, that is 70%. And if you see combined incidence of this middle cranial fossa, combined incidence of this middle cranial fossa fracture, it is 25%. So it is followed by middle cranial fossa fracture. Middle cranial fossa fracture, that is responsible for 25%. And after that, the least common type, here you can see this is posterior cranial fossa fracture. This is responsible for 5% of cases. So this is posterior cranial fossa fracture. Clear? Posterior cranial fossa fracture responsible for 5%. So overall, what is the most common type? It is anterior cranial fossa fracture. Clear? Next, you know that this anterior cranial fossa, it is formed by which bone? You can see it is mainly formed by frontal bone. It is mainly formed by frontal bone. If it is mainly formed by frontal bone, after injury of this bone, obviously there will be contusion in which lobe? So there will be contusion is in frontal lobe. So if there is fracture or injury of frontal bone, obviously it can lead to frontal lobe contusion. So what happens? There is contusion in which lobe? It leads to frontal lobe contusion. Second, you can see the middle cranial fossa. Middle cranial fossa, it is mainly formed by what? Temporal bone. You can see here. It is mainly formed by temporal bone. So you can see here, middle cranial fossa, it is mainly formed by temporal bone. And if it is mainly formed by temporal bone, obviously if there is fracture of what? Petrous part of temporal bone. So obviously there will be contusion of temporal lobe. So temporal bone, that's why here there is temporal lobe contusion. If there is middle cranial fossa fracture, it is associated with temporal lobe contusion. Similarly, if you see the posterior cranial fossa, this posterior cranial fossa, it is mainly formed by what? Mainly formed by occipital bone. You can see here, it is mainly formed by occipital bone. Occipital bone. So obviously, whenever there is fracture, because of this fracture, obviously there is contusion of which lobe? Obviously, occipital lobe contusion. So it leads to occipital lobe contusion. Occipital lobe contusion. Okay, one thing is clear. Second, in relation to petrous part of temporal bone, there are two nerves which are related, seventh nerve and eighth cranial nerve. So what will happen whenever there is fracture of petrous part of temporal bone? Obviously, it leads to injury of, whenever there is fracture of petrous part of temporal bone, obviously it leads to injury of seventh and eighth cranial nerve. So it leads to injury of seventh and eighth cranial nerve. There is another question. Seventh and eighth cranial nerve. If you see occipital bone, the posterior part of jugular foramen is formed by occipital bone. You can see here, where is the jugular foramen? In this image, you can see. This is the jugular foramen. Clear? So posterior part of this jugular foramen, it is formed by occipital bone, and that's why whenever there is posterior cranial fossa fracture, there is involvement of occipital bone. It is associated with jugular foramen syndrome, in which there is paresis of 9th, 10th, 11th nerve. So what happens in occipital bone? Since it is forming the posterior part of jugular foramen, it is associated with jugular foramen syndrome. It is associated with, jugular foramen syndrome. And what is jugular foramen syndrome? You know that here, it is in relation to 9th, 10th and 11th cranial nerves. In relation to 9th, 10th and 11th cranial nerve. So in this jugular foramen syndrome, which is also known as Wernicke syndrome, there is paresis. Paresis of 9th, 10th, 11th cranial nerve. Clear? Another important point here, you can see, this is sieve-like structure. This is known as cribriform plate. So what happens in anterior cranial fossa fracture? The site of fracture is this cribriform plate. And whenever there is site of fracture, the site of fracture is cribriform plate. What will happen? These patients will be having what? CSF rhinorrhea. So because of fracture of this cribriform plate, what happens? The CSF starts coming from the nose. That is known as CSF rhinorrhea. So in detail, we are going to discuss the cranial fossa fractures. First of all, we are going to discuss the anterior cranial fossa fracture. So we discussed that in anterior cranial fossa fracture, what is the site of fracture? It is cribriform plate. So site of fracture, what is the site of fracture? That is cribriform plate. Cribriform plate is the site of fracture. Because of that, what will happen? These patients will start having CSF rhinorrhea. So CSF starts coming from the nose. Second, since it is frontal bone, anterior cranial fossa is mainly formed by frontal bone. So what happens? These patients will be having frontal lobe contusion. Apart from that, patients are having epistaxis. There is subconjunctival hematoma. These patients are having anosmia, and some patients are having periorbital hematoma. In this image, you can see this is periorbital hematoma. This is also known as black eye, also known as raccoon eyes. So what's the name? Periorbital hematoma, also known as periorbital ecchymosis, also known as black eye. What is the other name? It is also known as raccoon eyes. So what's the other name? This is also known as raccoon eyes. Clear? Raccoon eyes. So how to remember? It's very easy to remember. The mnemonic is frontal escape. You can see here, what's the mnemonic here? It's the frontal. Is the frontal escape. You can see here. So the mnemonic is frontal escape. Clear? So that's frontal. Is the frontal escape. Clear? So frontal means frontal lobe contusion. E means epistaxis. S means subconjunctival hematoma. C means CSF rhinorrhea. A means anosmia. And PE, that is periorbital hematoma, that is also known as raccoon eyes, also known as black eyes. Now see this middle cranial fossa fracture. We discussed that it is caused by fracture of petrous part of temporal bone. You can see here. It is caused by fracture of this petrous part of temporal bone. So here, what's the problem? It is caused by fracture of petrous part of temporal bone. Clear? Fracture of petrous part. Clear? So petrous part of temporal bone. Because of this fracture of petrous part of temporal bone, what's the problem? There is dural laceration. And if there is dural laceration, and what happens? The tympanic membrane is also ruptured. So what will happen? And if CSF will start coming out via ear because tympanic membrane is perforated, this is known as CSF otorrhea. And the patients in whom the tympanic membrane is intact, in those patients what will happen? The CSF via ear is coming out via nose. This is known as paradoxical rhinorrhea, also known as otorrhinorrhea. So what? CSF otorrhea. In which patients you are going to find CSF otorrhea? Whenever the tympanic membrane is intact. So CSF otorrhea whenever the tympanic membrane is intact. Tympanic membrane is intact. And whenever tympanic membrane is perforated. So whenever tympanic membrane, it is perforated. Tympanic membrane is perforated. This is known as paradoxical rhinorrhea. This is also known as otorrhinorrhea. What is the other name of paradoxical rhinorrhea? This is also known as otorrhinorrhea. Paradoxical rhinorrhea, also known as otorrhinorrhea. Clear? Whenever tympanic membrane is intact, what happens? The blood is collected beneath the tympanic membrane, that is known as hemotympanum. What is hemotympanum? So in this image, you can see that this patient is having otorrhea, CSF otorrhea, you can see here. What's the problem here? In this patient, the tympanic membrane is perforated. So whenever there is perforated tympanic membrane, clear? If tympanic membrane is perforated, this patient will be having otorrhea. Second, you can see here there is periauricular ecchymosis or ecchymosis over mastoid process. Here you can see bruising over mastoid process or periauricular ecchymosis. This is known as, you can see here, Battle sign. So in this image, you can see the patient is having post-auricular ecchymosis. And what's the name? Name of this sign, it is Battle sign. Name of this sign, it is Battle sign. Another important point, if tympanic membrane is intact and blood is collected beneath tympanic membrane, what is the name of this sign? This is hemotympanum. So CSF otorrhea, hemotympanum, Battle sign, all these are seen in middle cranial fossa fracture. So let's revise quickly. We discussed that if tympanic membrane is intact and blood is collected, this is known as what? Hemotympanum. Clear? There is Battle sign. What is Battle sign? This is post-auricular ecchymosis or ecchymosis over the mastoid process. This was asked many times in exam. Battle sign. And we discussed that 7th and 8th cranial nerves, these are in relation to petrous part of temporal bone. So obviously whenever this fracture will be there, because of this fracture, there is 7th and 8th cranial nerve injury. And since middle cranial fossa is mainly formed by temporal bone, obviously these patients will be having temporal lobe contusion. So I'm repeating, this is very, very important. Middle cranial fossa fracture, it is associated with CSF otorrhea, otorrhinorrhea, also known as paradoxical rhinorrhea, hemotympanum, Battle sign, injury of 7th and 8th cranial nerve, and temporal lobe contusion. Posterior cranial fossa fracture, it is responsible for 5% of skull base fracture, and we discussed that it is mainly formed by which bone? You can see here, it is mainly formed by this occipital bone. So there will be contusion of which lobe? Obviously there is contusion of occipital lobe, and you know that occipital lobe is mainly responsible for visual function. So what happens whenever there is contusion of occipital lobe? What happens? These patients will be having visual disturbances. These patients are having 6th cranial nerve injuries, and there is jugular foramen syndrome. What is this jugular foramen syndrome, and why there is jugular foramen syndrome? In this image you can see. In this image you can see that the posterior part, here you can see the posterior part of jugular foramen, it is formed by occipital bone. So whenever there is fracture of occipital bone, what will happen? There can be jugular foramen syndrome. Via this jugular foramen, 9th, 10th and 11th cranial nerves are passing. So what will happen? If patient is having fracture of occipital bone, so there can be paralysis of this 9th, 10th, 11th nerve, and this is known as jugular foramen syndrome. What is other name of jugular foramen syndrome? This is also known as Wernicke syndrome. What is the other name of jugular foramen syndrome? This is also known as Wernicke syndrome. And here what's the problem? There is paralysis of 9th, 10th and 11th cranial nerve. Clear? So paralysis of 9th, 10th and 11th cranial nerves. There is paralysis of 9th, 10th and 11th cranial nerves. Clear? And it can also lead to injury of basilar artery. So what are the problems with posterior cranial fossa fracture? There is contusion of occipital lobe. Because of that, patient is having visual disturbances. 6th cranial nerve injury. Jugular foramen syndrome, also known as Wernicke syndrome, where there is paralysis of 9th, 10th, 11th cranial nerves, and there can be injury of basilar artery. So we discussed out of these which one is most common. Anterior cranial fossa fracture, responsible for 70% cases. Middle cranial fossa fracture, responsible for 25% cases. And posterior cranial fossa fracture, responsible for 5% cases. Now we are going to discuss the EDH and STH. Before discussing extradural hematoma and subdural hematoma, you should be having some concept. It is very easy to understand extradural and subdural hematoma. You can see here. Suppose this is skull. You can see here. This is the skull. Clear? So inside the skull, you can see this is the brain. This is just for your understanding. Suppose this is the skull, and inside the skull, this is the brain. Clear? Between skull and brain, there is a pad. Can you tell me what's the name of that pad? Between skull and brain, there is pad. What is pad? So outermost is dura, after that arachnoid, after that pia. So outermost is dura, then arachnoid, then pia. So it's easy to remember. Between skull and brain, there is pad. Pia, arachnoid, outermost is dura. Now imagine there is collection between skull and dura. Whenever there is collection between skull and dura, this is known as STH. This is what? Subdural hematoma. Clear? And whenever there is collection of blood between dura and arachnoid, collection of blood between dura and arachnoid, this is known as STH. So this is subdural hematoma between dura and arachnoid, and this is extradural hematoma. Extradural hematoma, this is between skull and dura. One thing is clear. Here you can see STH is red colored, means reddish tinge is there. It means here arterial bleeding is there. STH is bluish. So what happens? Here venous bleeding is there. So EDH, it is because of bleeding in which particular artery? Bleeding of middle meningeal artery. And you know STH, it is because of injury of cortical veins, also known as bridging veins. Injury of cortical veins and bridging veins. This is one concept. Second, you can see what is the thinnest or weakest part of skull. Thinnest or weakest part of skull is terion. You can see here. In this image, you can notice that this is terion, that is the weakest or thinnest part of skull. And you can see it overlies the middle meningeal artery. Can you see here? It overlies the middle meningeal artery. In latest exam, it was asked which division. So you can see here, anterior division. So it overlies anterior division of middle meningeal artery. Since it's the weakest or thinnest part, any kind of trivial trauma can cause the injury of this anterior division of middle meningeal artery. And after that, what will happen? The blood will be collected between skull and dura, and this is known as EDH, extradural hematoma. Clear? So in detail, we are going to discuss the differences between EDH and STH. So first, see the EDH, epidural or extradural hematoma. This is EDH, epidural or extradural hematoma. So in this case, you can see here that the blood is collected between skull and dura. And this is STH, that is subdural hematoma. Here, the blood is collected between dura and arachnoid. You can see here. So this is what? This is dura, and this is arachnoid. Clear? So this is dura, this is arachnoid. So in subdural, the blood is collected between dura and arachnoid. Extradural, the blood is collected between skull and dura. Second, we discussed that even trivial trauma in this terion is the weakest point of skull or thinnest point of skull. So trivial trauma to terion, what happens? There is injury to terion, that is the weakest part of skull. So injury to terion can lead to trauma of middle meningeal artery. Obviously, which division? We discussed that anterior division. So injury of anterior division of middle meningeal artery. So what kind of bleeding is there in EDH? You can see here in EDH there is arterial bleeding. If you see the dura, status of dura here, the dura, it is peeled off in EDH. Clear? Now come to the STH. In STH, significant trauma is responsible for STH, and it is generally seen in elderly. So what kind of trauma here? Significant trauma. Here, significant trauma is responsible. So it's the significant trauma, and especially this is common in elderly. STH is common in elderly. Clear? In this case, there is injury of cortical veins or bridging veins. So you can see here. In STH, there is injury of bridging veins. You have to remember, it is also known as cortical veins. So injury of cortical veins or bridging veins. Clear? That leads to STH. Here you can see the dura is still attached to the skull. And if you see the EDH does not cross the suture line, but STH is going to cross the suture line. So EDH, important point. EDH does not cross suture line. Important point. EDH, it does not cross. Clear? It does not cross suture line. Does not cross suture line. But STH, it crosses suture line. Clear? STH crosses suture line. suture line. Most of the questions are asked in relation to artery and vein injury. So it is caused by injury of middle meningeal artery anterior division, and STH, it is caused by injury of cortical veins or bridging veins. Injury of cortical veins, also known as bridging veins. Clear? Okay, so dura is still attached to the skull in STH, but dura is peeled off in EDH. You know one interval, lucid interval. So what is lucid interval? One episode of consciousness between two episodes of unconsciousness. And you know, this lucid interval, it is positive in extradural hematoma. So here, lucid interval is positive. Lucid interval, that is positive in extradural hematoma. Right? If you see the diagnosis, investigation of choice for diagnosis for both is same. What we go for NCCT, and see the finding of EDH and STH on NCCT. In EDH, you can see that there is biconvex hyperdense lesion. Can you see here? It's the biconvex hyperdense lesion. And if you see STH here, this is concavo-convex. What? This is concavo-convex hyperdense lesion. So investigation of choice for diagnosis is same in both. It's same. We go for NCCT. Investigation of choice for diagnosis, it is same. Clear? Non-contrast CT, and here you can see biconvex hyperdense lesion. This is lens shaped or lenticular shaped. So this is biconvex hyperdense lesion, and this is concavo-convex. Clear? So this is concavo-convex hyperdense lesion. Right? Now, we have to drain the hematoma. So how you drain it? If small hematoma is there, you can drain it by burr hole. And if large hematoma is there, you have to drain by craniotomy. So what happens? What's the treatment options we have? The treatment options we have drainage. So first option, we can go for burr hole, drainage by burr hole. In both, we can drain it by burr hole. And if large hematoma is there, we have to drain it by craniotomy. So it's the drainage by burr hole and drainage by craniotomy. Small hematoma can be drained by burr hole. Large hematoma, it should be drained by craniotomy. What is the special feature of this STH, subdural hematoma? That you can leave small STH. Small STH can be observed, but the problem, since significant trauma is responsible for STH and it is common in elderly, so if we compare STH from EDH, usually STH is having poor prognosis. So usually subdural hematoma, this is having poor prognosis. Clear? It's having poor prognosis. The next is diffuse axonal injury. Here, diffuse means widespread. Axonal injury means axonal damage. So in these patients, what's the problem? These patients have widespread axonal damage. Clear? After severe head injury. So in these patients, there is widespread axonal damage after severe head injury. Clear? Here, what is the most common site? If you see, the most common site, it is lobar white matter. Exactly where? At the junction of gray matter and white matter, followed by corpus callosum, followed by brainstem. So important question about diffuse axonal injury, that what's the most common site? What's the most common site? And it's the lobar white matter. Where exactly? At the junction of gray and white matter. So it's lobar white matter. This is lobar white matter. Clear? Followed by corpus callosum, followed by brainstem. Followed by corpus callosum. Clear? Followed by brainstem. Now, how the questions are asked? The scenario will be, a patient was brought to the emergency, there is loss of consciousness and there is vegetative state, and NCCT was done, non-contrast CT, and NCCT is normal. So what happens? These patients are having loss of consciousness and diffuse axonal injury. This is the most common cause of post-traumatic vegetative state. Important question. Diffuse axonal injury. This is the most common cause of post-traumatic vegetative state. Post-traumatic vegetative state. Clear? So these patients are having severe head injury. But what's the problem? In the scenario, it is mentioned that NCCT is normal. And if NCCT is normal, what is the next best step? So can you tell me what is the investigation of choice for diffuse axonal injury? It is MRI. So important point which you have to remember, that here NCCT is normal. Non-contrast CT, it is normal. That's why the investigation of choice for diagnosis, it is MRI. So here, what's the investigation of choice for diagnosis? It is MRI. But what is the problem? Prognosis is extremely poor. Why? Because already patient is having widespread axonal damage. So if you see the prognosis, prognosis of this patient, it's poor. Diffuse axonal injury patients, they have poor prognosis. The questions which are asked in exam, they ask you, NCCT is normal, what is the next best step? So investigation of choice for diagnosis is MRI. And what is the most common cause of post-traumatic vegetative state? The most common cause, it is diffuse axonal injury. Now we are going to start neck and thoracic injuries. First of all, we are going to discuss neck injuries. If you see, the major vascular structures in the neck means carotid vessels, and if you see the aerodigestive structures like trachea and esophagus, all of these are located in anterior triangle, and anterior triangle means it is located anterior to this muscle, sternocleidomastoid, and it is located deep to platysma. So what are the two useful anatomical boundaries in neck injuries? Two useful anatomical boundaries in neck injuries. One, we discussed sternocleidomastoid muscle, and second is platysma. So two useful anatomical landmarks. What are the two useful anatomical landmarks in neck injuries? First is sternocleidomastoid muscle. So it is sternocleidomastoid muscle, clear? And second, it is platysma. It is platysma. Okay. After that, see the zones of neck injuries. What are the zones in neck injuries? Zone 1, Zone 2, Zone 3. Here you can see what is the Zone 1. Zone 1, it is located between sternal notch and cricoid cartilage. So Zone 1 between sternal notch and cricoid cartilage. Zone 2, it is located between cricoid cartilage and this angle of mandible. So you can see Zone 2. Zone 2, it is located between cricoid cartilage and angle of mandible. And if you see Zone 3, here, this is base of skull. So this is base of skull. So what's the location of Zone 3? You can see here, Zone 3 is located between angle of mandible and base of skull. So these are the various zones. Now see the important questions related to various zones. If you see Zone 1, we discussed that it is located between sternal notch and cricoid cartilage. You can see here, it is located between sternal notch and cricoid cartilage. And what are the important structures located here? You can see there is location of what? Carotid artery. So carotid vessels, esophagus and trachea. You can see here, there is location of carotid vessels, esophagus and trachea. So all these important structures are located here. So what happens? Injury to Zone 1 is having highest mortality. Why? Because injury to Zone 1 can lead to carotid vessels injury. So first, Zone 1. Zone 1 injuries, important point. Zone 1 injuries. So Zone 1 injuries, these are associated with highest mortality. So why Zone 1 injuries are having highest mortality? Because it can lead to carotid vessels injury. So it is associated with highest mortality. Highest mortality, you can see in Zone 1, there is location of carotid vessels and aerodigestive structures means trachea and esophagus. If you see Zone 2 is most exposed and most commonly injured zone. Here you can see, this is Zone 2. This is Zone 2. So this is most exposed and most commonly injured zone. This is most exposed, Zone 2. That is most exposed and most commonly injured zone. This is most commonly injured zone. Clear? Since it is most exposed, that's why it is most surgically accessible also. So Zone 2, that is most surgically accessible because it is most exposed. And if you see Zone 3, what's the location? It is located between angle of mandible to the base of skull. So what's the location? Angle of mandible to the base of skull. So maximum mortality or highest mortality is seen in Zone 1, and most exposed, most commonly injured and most surgically accessible, that is Zone 2. Now see the important questions related to thoracic injuries. First, what is the most common thoracic injuries? These are chest wall injuries. Most common thoracic injuries, these are chest wall injuries. Clear? Most common thoracic injuries, these are chest wall injuries. Chest wall injuries. Clear? After that, what is the most common cause of mortality in thoracic injuries? If there is blunt thoracic trauma and if there is penetrating trauma. So if there is blunt thoracic trauma, it is because of tracheobronchial injury. So most common cause of mortality in blunt thoracic trauma, this is because of tracheobronchial injury. It is because of tracheobronchial injury. And if it's penetrating trauma, the cause of death is hemothorax. What is the most common cause of mortality in penetrating trauma? So in penetrating trauma, there is hemothorax. And what is the cause of hemothorax? It is secondary to pulmonary laceration. So most common cause of mortality in penetrating trauma, this is hemothorax. It is hemothorax. And what's the cause of this hemothorax? It is secondary to pulmonary laceration. One question which was asked many times in the exam, that what is the most commonly fractured rib during CPR? So where you put your hand during CPR on the left side, around 4th, 5th, 6th ribs. So what happens? There is fracture of these ribs. So most commonly fractured rib during CPR, it is 4th to 6th rib. This was the question. It's the 4th to 6th rib. If you see the fracture of first rib and 10th, 11th, 12th ribs, these are uncommon. So fracture of which ribs are uncommon? Fracture of first rib. So fracture of first rib, so it's the first rib fracture, and the fracture of 10th to 12th ribs. Number 10th to 12th rib. So first rib fracture and 10th to 12th rib fracture, it's uncommon. It's uncommon. Suppose a patient is having fracture of these ribs. So if there is fracture of first rib or fracture of 10th, 11th, 12th ribs, it suggests that there is high velocity impact. So it is caused by high velocity impact. So what's the cause? It is caused by high velocity impact. Clear? The cause is high velocity impact whenever there is fracture of first rib or fracture of 10th, 11th or 12th rib. One topic which is asked almost every year in each and every paper, that is tension pneumothorax. So what is the cause of tension pneumothorax? It is caused by one-way valve air leak, either in the lung or in the chest wall. What? One-way valve air leak. So you can see here, there is one-way valve air leak, either in the lungs, you can see in the lungs, or in the chest wall. So there is one-way valve air leak. What's the problem? In this case, just imagine that patient is doing inspiration. So during inspiration, the chest cavity is moving out, and what will happen? The valve is open, and if the valve is open, air is pushed in or air is forced into the thoracic cavity. Second, suppose patient is having some kind of rupture of the lung. So what will happen? Whenever patient is doing inspiration, the lung is going to expand during inspiration, and what happens? The site of puncture is going to enlarge. So again, there is air leak. What will happen in expiration? Obviously, lung is collapsed during expiration, so obviously the air is not able to escape. Same thing happens to the chest wall injury. During expiration, when the chest cavity is moving in, there is positive pressure. What will happen? Valve is closed. So you can notice here, in this image, you can notice that there is one-way valve air leak in the chest wall or in the lungs. Because of that, what will happen? Air keeps on collecting under tension. And when air keeps on collecting under tension, what will happen? First, you can see here, it will collapse the ipsilateral lung. Second, what will happen? There will be shift of mediastinum to opposite side. So you can see here, there is shift of mediastinum to opposite side. Third, you can see here, there is compression of these major vessels. You can see here, there is compression of inferior vena cava. There is compression of superior vena cava. Another thing, it is going to depress the diaphragm. So what are the manifestations? So what's the pathophysiology here? I'm repeating. In this case, there is collapse of ipsilateral lung, shift of mediastinum to opposite side, depressed diaphragm, and compression of these major vessels. Because of this, what are the symptoms? Have a look. So in the image, you saw that there is collapse of ipsilateral lung, and because of this, what will happen? Patient will be having manifestations like dyspnea or tachypnea. So collapse of ipsilateral lung. So patient will be having what? Dyspnea. There is dyspnea, and the patients are having tachypnea. So there is dyspnea, tachypnea. There is shift of mediastinum to opposite side. There is depressed diaphragm and decreased venous return. Why? Because it is going to compress the large vessel. Why there is decreased venous return? Because of compression of, what's the problem? There is compression of superior vena cava as well as inferior vena cava. There is compression of superior vena cava as well as inferior vena cava. Because of compression of inferior vena cava, what will happen? Since there is decreased venous return to the heart, so obviously what will happen? These patients will be having decreased cardiac output. So because of decreased venous return, what will be the problem? There is decreased cardiac output. Clear? Right? It means what's the problem? Patient will be having hypotension. So these patients are having hypotension. Another problem, since superior vena cava is also compressed, so what you are going to see that there is distended neck veins. So because of compression of superior vena cava, in these patients, there are distended neck veins. What's the problem? The patients are having distended neck veins. Distended neck veins. So what is the typical manifestation? See the presentation. A patient of road traffic accident will be brought to your emergency. Patient will be having fracture of some ribs. Patient will be having dyspnea, tachypnea. There will be hypotension, distended neck veins. And whenever you are going to do the percussion, on percussion, since affected hemithorax is filled with air, there is hyperresonance. And since the ipsilateral lung is collapsed, there is absent breath sounds. So what will be the manifestations apart from this? What? There is hyperresonance. Manifestations apart from this. There is hyperresonance over affected hemithorax. So hyperresonance and what? Absence of breath sound. So absent breath sounds over affected hemithorax. Absent breath sounds. Clear? So there is absent breath sounds. Right? So any patient who is brought to your emergency who is having dyspnea, tachypnea, there is hypotension, these patients are having distended neck veins, hyperresonance is there on percussion, absent breath sounds. Yes, this is enough hint that patient is having tension pneumothorax. So how you are making the diagnosis here? The diagnosis of tension pneumothorax is clinical. You have to remember, in trauma patients, especially related to thorax, diagnosis of flail chest and diagnosis of tension pneumothorax, it is clinical. Diagnosis of flail chest and diagnosis of tension pneumothorax, it's clinical. So here, the diagnosis is clinical. You have to remember. We are not going to send the patient for X-ray. If you're going to send this patient for X-ray, patient might die or might expire in the radiology department. So diagnosis is clinical. On the basis of suspicion only, we have to put a wide bore needle in second intercostal space in mid-clavicular line in children and in fifth intercostal space in anterior axillary line in adults. So only on the basis of suspicion, what we have to start the management. So put a wide bore needle. So what? Wide bore needle insertion only on the basis of suspicion. Wide bore needle insertion. Clear? So it's the wide bore needle insertion. Where exactly? Wide bore needle insertion in second intercostal space. It's in second intercostal space in mid-clavicular line. In mid-clavicular line in children. So in children, it's the second intercostal space in mid-clavicular line. And if you see adults, it's the fifth intercostal space in anterior axillary line. It's the fifth intercostal space in anterior axillary line. Second, sometimes in exam you will find the X-ray also, examiner is giving X-ray of tension pneumothorax. Suppose X-ray of tension pneumothorax is there in exam. How to identify? So in this image, you can see the most characteristic feature of tension pneumothorax. If you compare the level of diaphragm, can you see here? There is depressed diaphragm. This is the most characteristic feature. What? These patients are having depressed diaphragm. Apart from that, you can notice that what? The lung is being collapsed. Clear? Loss of bronchovascular marking. So here, collapsed lung. You can see that there is shift of mediastinum to opposite side. So all these findings will be there on the chest X-ray. Second, so on the basis of clinical suspicion, you inserted a wide bore needle, right? So that you are buying some time to put the chest tube. So what is the treatment of choice? The treatment of choice doesn't matter whether patient is a child or adult. The treatment of choice is ICD insertion, and where we are inserting ICD means intercostal drain. So chest tube insertion in fifth intercostal space in anterior axillary line. So what is the treatment of choice? The treatment of choice for tension pneumothorax, it is ICD insertion, intercostal drain insertion. Clear? So this is intercostal drain insertion in fifth intercostal space. This is fifth intercostal space in anterior axillary line. It's ICD insertion in fifth intercostal space in anterior axillary line. That's the treatment of choice. See this X-ray. X-ray of a trauma patient. This patient is having enlarged cardiac shadow. And what is the cause of this pericardial tamponade? Here, there is rapid accumulation of blood or fluid in the pericardial space. This is pericardial tamponade. And in trauma, what is the cause? It is caused by penetrating trauma. So this is pericardial tamponade. What's the cause? It's caused by penetrating trauma. It is caused by penetrating trauma. Clear? Now you know that What's the name of triad which is associated with this pericardial tamponade? The name is Bake's triad. What are the components? Muffled heart sound, distended neck veins, and hypotension. In patients of pericardial tamponade, the Bake's triad is positive. How to remember? The mnemonic is MDH. MDH means asli masale such. So you can see here, muffled heart sound, distended neck veins, and hypotension, right? Second, sometimes the presentation will be very similar to tension pneumothorax. Both of these are trauma patients. Suppose the presentation is like that patient is having hypotension, patient is having distended neck veins. So we discussed that hypotension and distended neck veins, both of these are present in tension pneumothorax. So if you compare hypotension, it is also present in tension pneumothorax. Distended neck veins, it is also present in tension pneumothorax. But muffled heart sound, it is the feature of pericardial tamponade. And what's the feature of tension pneumothorax? In tension pneumothorax, there is absent breath sounds. So how to differentiate? If you see tension pneumothorax, in tension pneumothorax, if you see tension pneumothorax, clear, both of these features will be there. So there will be distended neck veins, there will be hypotension. But what's the differentiating feature here? There is absent breath sound, and if you do the percussion, there is hyporesonance over the affected hemithorax. So characteristic feature by which you can easily differentiate it from pericardial tamponade. First, these patients will be having absent breath sounds. Absent breath sounds over the affected hemithorax. Clear? Absent breath sounds over the affected hemithorax. And second, there will be hyporesonance on percussion. So if we go for percussion, there is hyperresonance. Clear? Hyperresonance. So this is how you can easily differentiate pericardial tamponade from tension pneumothorax. What is the investigation of choice for diagnosis of pericardial tamponade? So obviously we go for echo. Here, the investigation of choice for diagnosis, it is echocardiography. It is echocardiography. And what are the chest X-ray findings? You saw here on chest X-ray there is enlarged cardiac shadow. So on this chest X-ray you saw that there is enlarged cardiac shadow. Clear? So on chest X-ray there is enlarged cardiac shadow. Clear? So there is enlarged cardiac shadow. Okay. Now patient is having pericardial tamponade because of collection of excessive amount of blood or fluid. So what you have to do, you have to take it out. How in emergency you can do it? Insert a needle and perform pericardiocentesis. So what's the emergency treatment? It's the needle pericardiocentesis. And what's the treatment of choice? We perform pericardiotomy and we drain the fluid. So treatment, if you see the treatment of pericardial tamponade, treatment. If you see the emergency treatment, what's the emergency treatment? We perform needle pericardiocentesis. So emergency treatment, it is needle. We insert the needle and perform the aspiration. So this is needle pericardiocentesis. Clear? So it's the needle pericardiocentesis. And if you see the treatment of choice, that's pericardiotomy. Treatment of choice, that's pericardiotomy. Treatment of choice, that's the pericardiotomy. So we have to drain via performing pericardiotomy. Next, what is the definition of flail chest here? Fracture of two or more than two consecutive ribs fractured at two or more than two places. What? Fracture of two or more than two consecutive ribs fractured at two or more than two places. So after that, what will happen? That part of chest wall becomes isolated. You can see after this kind of fracture, that part of chest wall becomes isolated. And when that part of chest wall becomes isolated, what will happen? Whenever your chest cavity moves out in inspiration, that part of chest wall moves in. And whenever your chest cavity moves in during expiration, that part of chest wall moves out. Clear? So this is known as paradoxical respiration. What happens whenever this kind of movement is there? There is severe pain. So patient will be having voluntary splinting also, and there is mechanically impaired chest wall movement. So because of all of these, what's the problem in patients of flail chest? There is increased risk of respiratory failure. So first, what's the definition? That it is associated with or characterized by fracture of two or more than two consecutive ribs. So here, there are fracture of two or more than two consecutive ribs. Important point, consecutive ribs. Clear? Fractured at two or more than two places, which are fractured at two or more than two places. Simple. So we discussed that. What's the problem here? These patients are having paradoxical respiration. There is voluntary splinting due to pain, and these patients are having mechanically impaired chest wall movement. Because of this, what's the problem? In patients of flail chest, there is increased risk of respiratory failure. So these patients have increased risk of respiratory failure. Increased risk of respiratory failure. Now, how we are going to make the diagnosis? We discussed that. In thoracic trauma, tension pneumothorax diagnosis and diagnosis of flail chest, it is purely clinical. So it's the clinical diagnosis. So you tell me how you are going to make the diagnosis. Is the clinical diagnosis. So how we are going to make the diagnosis? We have to observe the patient during respiration. So whenever the part of chest wall which is isolated, it is moving in opposite direction. It means if patient is having paradoxical motion of chest wall segment, means patient is having paradoxical respiration. By this method, you are going to make the diagnosis. Sometimes patient is having voluntary splinting. So if you want to make the diagnosis, you have to ask the patient to cough. And when patient is coughing, what will happen? When patient is coughing, the chest wall moves in, but the part of chest wall which was isolated, it is going to move out. So diagnosis is clinical. Now coming to the treatment. Treatment. If patient is having only flail chest, there is no respiratory failure. In these patients, we go for oxygen administration. Most important aspect is, since there is severe pain, analgesia. So in some cases, we go for epidural analgesia and we go for physiotherapy. And if patient is having respiratory failure, in that case, we go for intermittent positive pressure ventilation. So if the patient is having only flail chest, no respiratory failure, here we go for oxygen administration. So what? Oxygen administration. The most important aspect is, since it's very painful, what? We go for adequate analgesia plus adequate analgesia. So some patients require epidural analgesia. So it is adequate analgesia. Some patients require epidural analgesia plus physiotherapy. Plus physiotherapy. Clear? And the question which is asked frequently, that patient who is having flail chest, apart from flail chest, patient is having respiratory failure. So in these cases, we go for what? We go for intermittent positive pressure ventilation. So if patient is having flail chest, apart from that, there is respiratory failure, the treatment of choice, it is intermittent positive pressure ventilation. Now we are going to start abdominal trauma. First of all, we are going to discuss the one-liner questions related to abdominal trauma. So what is the most commonly injured organ in blunt trauma abdomen? You know, it is spleen followed by liver. So most commonly injured organ in blunt trauma abdomen, that is spleen. So this is spleen followed by liver. Clear? So it is spleen followed by liver. And what is the most commonly injured organ in penetrating trauma? So in penetrating trauma, it is liver followed by stomach followed by small intestine. So in penetrating trauma, it's liver. This is liver followed by stomach. So it is liver followed by stomach followed by small intestine. Followed by small intestine. Next, what is the most commonly injured organ in gunshot wound? And in gunshot wound, it is the small intestine. So you have to read the question carefully. If it is penetrating trauma, mark liver followed by stomach followed by small intestine. And whenever firearm is fired, means there is gunshot wound. In that case, the most commonly injured organ, that's small intestine. Most commonly injured organ in gunshot wound, small intestine. Now, what is the most commonly injured part of bowel in blunt trauma abdomen? So what will happen? In blunt trauma abdomen, the part of bowel will be injured, which is mobile also and which is fixed also. So which part of bowel is mobile as well as fixed? It is jejunum. You know that jejunum is fixed at which junction? DJ, duodenojejunal junction. So that is the site of injury. So most commonly injured part of bowel in blunt trauma abdomen, obviously it is jejunum. And what is the most common site? If you see the most common site of injury in blunt trauma abdomen in bowel, that is DJ, that is duodenojejunal junction. Next, what is the most common site of injury in deceleration injury? It is same. What? DJ, that is duodenojejunal junction. It is DJ, that is duodenojejunal junction. Clear? So that's DJ. What is the most commonly injured structure in seat belt injury? And you know that in seat belt injury, the most commonly injured structure, that's mesentery. So what's the most commonly injured structure in seat belt injury? And that is mesentery. Clear? Now coming to the investigation. Tell me, what is the first investigation done in the patients of blunt trauma abdomen? Doesn't matter patient is stable or unstable. So first investigation done in patients of blunt trauma abdomen, that is fast. And if the question is asked, gold standard investigation, what? Gold standard investigation in stable patients of blunt trauma abdomen, then CCT. So important questions first. First investigation done in patients of blunt trauma abdomen, doesn't matter. Patient is stable or unstable, it is fast. But gold standard investigation for stable patients of blunt trauma abdomen, we go for CCT. So when fast is positive, patient is stable, we have to confirm the findings by CCT. One by one we are going to discuss. First we are going to discuss the FAST. Tell me what's the full form. It is Focused Assessment with Sonography for Trauma. So in this image you can see this is FAST, Focused Assessment with Sonography for Trauma. What is FAST actually? It's ultrasound, emergency ultrasound, which is done very fast. So emergency ultrasound which is done very fast, that is FAST. So it is done within how many minutes? It is done within 2 to 4 minutes. You have to remember. It is done within 2 to 4 minutes. So first question, it is done within 2 to 4 minutes. What we are going to assess here? We are going to assess 4 P's. So in FAST, we are going to assess 4 P's. Clear? So how to remember? 4 minutes, 4 P's. 4 minutes, 4 P's. Now what are those 4 P's? Here you can see. First thing you can see here, I'm going to assess pericardial sac. So what I'm going to assess? Pericardial sac. And to assess pericardial sac, we have subxiphoid transverse view. Then we are going to assess what? Perihepatic region. After that we are going to assess perisplenic region, and after that we are going to assess what? Pelvis. Clear? So it's the sequential assessment of what? Pericardial sac, then perihepatic region, then perisplenic region, then pelvis. So what? It is the sequential assessment like this. So in this sequence only we are going to do it. So first we are going to assess what? Pericardial sac. So first we are going to assess here 4 P's. What are those 4 P's? We are going to assess pericardial sac. Clear? Pericardial sac. So another question you can see here, for pericardial sac, what view is required? So we are going for subxiphoid transverse view. After that, we are going for perihepatic region. So what? We are going to assess perihepatic region. And you can see here, for perihepatic region, what's the view? Can you see the view? The view is right upper quadrant longitudinal view. And for perisplenic region, there is left upper quadrant longitudinal view. So perihepatic region, third P is this perisplenic region. That's perisplenic region. And fourth P, we are going to assess pelvis. Clear? And you can see here, for pelvis, there are 2 views. What? Suprapubic longitudinal as well as transverse view. So there is suprapubic longitudinal as well as transverse view. So here we are going to assess 4 P's. That is FAST. Another investigation is asked in exam. That is EFAST. What do you mean by EFAST? EFAST means extended fast. What is EFAST? EFAST means extended fast. So what do you mean by extended fast? Here, apart from these 4 views, 4 P's, we are going to assess what? Right thoracic. So there is right thoracic as well as left thoracic view. So whenever we are going to include 2 more views, right thoracic as well as left thoracic view, it is EFAST, that is extended fast. So you tell me how many views are there in EFAST? Obviously 6 views. So here you can see in EFAST, the 2 additional views which are included. Here we are going to include what? Right thoracic view and left thoracic view. So we are going to include right and left thoracic view. Clear? So we are going to include left and right thoracic view. Clear? And here how many views are there? You can see total 6 views are there. So total 6 views, 4 P's, right thoracic and left thoracic view. So 4 P's, right thoracic and left thoracic view. Clear? The question which is very famous and asked frequently, that on EFAST, the patients who are having pneumothorax, which sign is seen? It is known as stratosphere sign or barcode sign. So what's the name of sign? It's important. The name of sign, it's barcode sign. The name of sign, this is barcode sign. Clear? Also known as stratosphere sign. So this is barcode sign, also known as stratosphere sign. Clear? So barcode sign or stratosphere sign, and it is seen in which patients? The patients who are having pneumothorax. So in patients of pneumothorax, obviously on which investigation? Obviously on EFAST. So there is barcode sign or stratosphere sign in patients of pneumothorax on EFAST. We discussed that first investigation done in patients of blunt trauma abdomen, doesn't matter. Patient is stable or unstable, that is FAST. There is another investigation known as diagnostic peritoneal lavage, DPL. But what's the good thing? FAST has replaced DPL. FAST is non-invasive investigation. So FAST has replaced DPL. But sometimes in exam, examiners are asking DPL also. DPL means diagnostic peritoneal lavage. Now see the DPL. What we do in DPL or diagnostic peritoneal lavage, we perform peritoneal lavage with 1 liter of saline or ringer lactate. So what is done here? peritoneal lavage is done. So we perform peritoneal lavage with 1 liter of normal saline or ringer lactate to make the diagnosis in patients of blunt trauma abdomen. So that's why the name is diagnostic peritoneal lavage. Peritoneal lavage is done to make the diagnosis in patients of blunt trauma abdomen. Now see how it's done. First, we have to go for midline infraumbilical incision. Midline infraumbilical incision. And after that, we have to insert a catheter. And this catheter, you can see here, this catheter is inserted, and this DPL catheter, you can see here. This is the DPL catheter. So this catheter is inserted, and this catheter is actually guided towards pelvis. Clear? Whenever we are inserting the catheter, after that we have to perform the aspiration. When aspiration is done, after that we have to instill 1 liter of normal saline or ringer lactate. So you can see here there is IV fluid bag. In this IV fluid bag, what is given? 1 liter of ringer lactate or normal saline. So here either ringer lactate or normal saline is given. How much? 1 liter. So 1 liter of ringer lactate or normal saline is given, and this fluid is going into the peritoneal cavity. After that, what you have to do, you have to put this IV fluid bag down. So can you see here? This IV fluid bag is put down. Clear? And whatever the fluid is there in the peritoneal cavity, it is going to mix with ringer lactate or normal saline. So that lavage fluid, it starts collecting in the bag. And when that lavage fluid starts collecting in the bag, this fluid is sent for the examination. Clear? So this fluid is sent for the examination, and on the basis of examination findings, we are going to confirm whether DPL is positive or DPL is negative. So in which cases DPL is positive? First, see the important questions. What kind of incision is given? It's midline infraumbilical incision. So in DPL, what kind of incision first? In DPL, we give midline, it's a midline infraumbilical incision. So we give midline infraumbilical incision. Clear? So it's the midline infraumbilical incision which is given. For lavage, which fluid is used? We can use normal saline or we can use ringer lactate. How much? You have to remember 1 liter. 1 liter. Clear? Before putting this lavage fluid into the peritoneal cavity, we have to perform the aspiration. And if on aspiration 10 ml or more of frank blood is aspirated, it means DPL is positive. Second, whenever you are sending this lavage fluid for examination, on the basis of examination findings, whether there is RBCs, WBCs, RBCs more than 1 lakh per mm cube, WBCs more than 500 per mm cube, or there is presence of bile or bacteria. So normal saline or ringer lactate 1 liter fluid is given for the lavage. Clear? So in which cases we are going to consider that DPL is positive? See, so we discussed that after insertion of catheter, we have to perform the aspiration. When you perform the aspiration, if 10 ml or more of frank blood is aspirated, then also DPL is considered positive. It means significant bleeding has occurred. Or whenever you are going to send the lavage fluid for examination, that is known as effluent. So if returned effluent contains RBC, what's the number? RBC is more than 1 lakh per mm cube. So how much? RBCs number you have to remember. RBCs more than 1 lakh per mm cube. Clear? Or WBC, how much? More than 500 per mm cube. Or in the effluent, returned effluent contains bile or bacteria. What do you mean by presence of bile or bacteria in the peritoneal cavity? It means perforation has occurred. Or if there is amylase, what's the level? If the level of amylase is more than 174 international units per deciliter. How much? More than 174 international units per deciliter. So what do you mean by RBCs, WBCs? RBCs more than 1 lakh, WBCs more than 500. It means significant bleeding has occurred. Or if there is presence of bile bacteria or there is presence of amylase, it means perforation has occurred. So let me tell you one thing. FAST is positive. FAST, focused assessment with sonography for trauma. FAST is positive whenever there is fluid collection, and fluid collection is because of bleeding or perforation. Similarly, DPL is positive when there is bleeding or perforation. Clear? So when significant bleeding is there, obviously 10 ml or more of frank blood is aspirated, or in the effluent you are going to find RBCs more than 1 lakh per mm cube, WBCs more than 500. There is presence of bile bacteria, means perforation, presence of amylase more than 174 international units per deciliter, it means perforation. Clear? So this is DPL. Okay, we discussed already that FAST has replaced DPL. Now see the penetrating trauma. What is the most commonly injured organ in penetrating trauma? We discussed it is liver, followed by stomach, followed by small intestine. So most commonly injured organ in penetrating trauma, that is liver. It's liver followed by stomach. So it's liver followed by stomach followed by small intestine. What is the most commonly injured organ in gunshot wound? We discussed it is small intestine. Small intestine. So what kind of penetrating trauma is there? Usually it is stab wound or gunshot wound. Stab wound or gunshot wound. So question is asked, in which case exploratory laparotomy is mandatory? Now see, if there is stab wound, so what happens in stab wound? In some cases, there is very little penetration. And whenever very little penetration is there, and peritoneum is not breached, if peritoneum is intact, only there is little penetration, it means it is actually a CLW, clean lacerated wound. So stab wound in which the depth of penetration is little, it's small, and peritoneum is intact, it means what? It is a CLW, clean lacerated wound. So in this case, exploratory laparotomy is not mandatory. It means in all patients of stab wound, exploratory laparotomy is not mandatory. But if a bullet is fired, if there is gunshot wound, in all those cases, exploratory laparotomy is mandatory. So exploratory laparotomy is mandatory in gunshot wound. It's not mandatory in all cases of stab wound. So exploratory laparotomy is mandatory in gunshot wound. It is mandatory in gunshot wound. Before discussing the management of blunt trauma, let's discuss the simple principles. We discussed that what is most commonly injured organ in blunt trauma abdomen? It is spleen followed by liver. What is the special feature of splenic trauma? Whenever there is splenic trauma, usually the bleeding is arterial and it is very difficult to control this arterial bleeding. That's why if we have to perform laparotomy, whenever patient is unstable in patients of splenic trauma or higher grade of injury is there, and if we have to perform laparotomy, usually we have to go for splenectomy. Why? Because it's very difficult to control the bleeding in splenic trauma. Why? Because it's arterial. Now see liver trauma. In liver trauma, if you see, the bleeding is venous. And if there is venous bleeding, what happens? If we can use the low pressure tamponade or compression or packing. So low pressure tamponade can easily control the bleeding. That's why in patients of liver trauma, you can control the bleeding by tamponade, by packing, but it's difficult for you to control the bleeding in splenic trauma because it is arterial. One thing. Second, suppose any patient of blunt trauma abdomen is brought to your emergency, first investigation done is FAST. If patient is unstable, obviously FAST will be positive and you take the patient to OT for exploratory laparotomy. Second situation, if patient is stable and FAST is negative, we go for observation. But if patient is stable, FAST is positive, confirm the findings by CCT. What is CCT? It is contrast enhanced CT. So you inject the contrast. After performing CCT, imagine a situation whenever there is active bleeding going on in the body. So what will happen? There is contrast extravasation. So if there is contrast extravasation or contrast blush or contrast leak, it is suggestive of active bleeding. Since patient is stable, these patients' bleeding can be easily controlled by angioembolization. And if the facility of angioembolization is not available or failed, in these patients, we take the patient for exploratory laparotomy. So this is in general protocol for management of blunt trauma abdomen. Another important point, if patient is having high grade injury, high grade means grade 4 onwards. So grade 4, grade 5 injuries. Even if patient is stable, it is very difficult to manage these patients conservatively. That's why it doesn't matter whether patient is stable or unstable, patient is having high grade injury, grade 4, grade 5. In all these cases, we have to go for exploratory laparotomy. Clear? So one by one, we are going to discuss. First, we are going to discuss the splenic trauma. In relation to splenic trauma, two signs are asked. First is Keher sign and the second is Balan sign. Now see what is the Keher sign. Imagine after splenic trauma, there is collection of blood and this blood which is collected under surface of diaphragm, it is going to irritate the under surface of diaphragm. So blood collection, it is going to cause the irritation of under surface of diaphragm and via C4 and C5 fibers of phrenic nerve, there is referred pain to left shoulder. So this is known as Keher sign. So what's the problem here? In Keher sign, in patients of splenic trauma, there is blood collection. So what happens? There is blood collection under surface of diaphragm and this blood collection, it is going to irritate the under surface of diaphragm. So there is irritation. Clear? So there is irritation of under surface of diaphragm, under surface of diaphragm, and because of irritation of this under surface of diaphragm, there is referred pain to left shoulder. These patients have referred pain to left shoulder. Via which nerve? Via phrenic nerve, which branches? C4 and C5. So via C4 and C5 fibers of phrenic nerve. So via C4 and C5 fibers of phrenic nerve. Fibers of phrenic nerve. Clear? Phrenic nerve. Okay. So this is Keher sign. One question, it is because of irritation of under surface of diaphragm by the collected blood. Second important point, what happens in some cases, the blood is going to clot. And whenever there is clotted blood. So because of this coagulation of blood, what happens? If you do the percussion, there is fixed area of percussible dullness in left upper quadrant, and this fixed area of percussible dullness in left upper quadrant, that is known as Balans sign. So it is because of collection of coagulated blood. So there is presence of coagulated blood, and because of presence of this coagulated blood, what's the problem? There is fixed area of percussible dullness. So there is fixed area. Clear? There is fixed area of percussible dullness. Percussible dullness. Where exactly? So there is fixed area of percussible dullness in left upper quadrant. Where exactly? Left upper quadrant. So these two questions are asked, Keher sign and Balans sign, in relation to splenic trauma. Now see the management of splenic trauma. So see here, blunt trauma abdomen, if patient is having splenic trauma. Clear? One situation, patient is unstable. Second situation, stable. In both of these cases, we go for fast. So here you can notice that in both of these cases, we are going to do the fast. If patient is unstable, you are going to perform the fast. Obviously, it will be positive. And we go for what? Exploratory laparotomy. So exploratory laparotomy is done. If patient is stable, go for the fast. Imagine fast is negative. If fast is negative, we just go for observation. If fast is positive, we have to confirm the findings. How will you confirm the findings? CECT. We discussed that. Higher grade injury. If patient is having higher grade injury like grade 4, grade 5, doesn't matter patient stable or unstable. In these cases, we go for exploratory laparotomy. Okay. Suppose patient is having lower grade injury like grade 1, grade 2, grade 3. So imagine patient is having grade 3 injury or grade 1 or grade 2 injury. In these cases, just look for what? Look for pseudoaneurysm, contrast blush, moderate bleed. If there is no pseudoaneurysm, contrast blush or moderate bleed, in these cases, what? We go for observation. Observation means intensive observation. It is done in ICU. It is intensive observation, and after that you have to perform the repeat scan after 72 hours. But imagine pseudoaneurysm, contrast blush, moderate bleed, all these are positive. So we discussed that how to control the bleeding. Easiest by angioembolization. So we control the bleeding by angioembolization. Imagine this facility is not available or failed. So if it is not available or failed, and whenever all these things are being done, imagine patient became unstable. So whenever patient is having hemodynamic instability or patient develops peritonitis, in these cases, again, what we have to go for? We have to go for exploratory laparotomy with splenectomy. Clear? So how we manage? You can see quickly. Blunt trauma abdomen, spleen, unstable or stable. In both cases, do the fast. Fast is positive. Patient is unstable, take the patient to OT for laparotomy. If fast is positive and patient is stable, do the CCT to confirm the findings. Grade 4, grade 5 injury, we go for exploratory laparotomy plus splenectomy. Grade 1 to grade 3 injury, look for pseudoaneurysm, contrast blush, moderate bleed. If it is absent, observation, and if it's present, go for angioembolization. Not available or failed, or patient became unstable, there is peritonitis, again we go for exploratory laparotomy plus splenectomy. Now see the management of liver trauma, it is very, very easy. Here also, doesn't matter whether patient is stable or unstable. First investigation done fast, so here we go for fast, clear, right? If patient is unstable, obviously fast will be positive, so you can see here. And then we go for exploratory laparotomy, right? Suppose patient is stable, fast is negative. In that case, we go for observation. Fast is positive and patient is stable. We have to confirm the findings. How we have to confirm the findings? CCT. We discussed that whenever higher grade injuries are there. So if injury grade is grade 4 or more, in that case, we go for laparotomy. Here you can see, we go for laparotomy. If it is grade 4 or more, right? Imagine patient is having grade 1 to grade 3 injury and there is contrast blush. If contrast blush is there, we go for angioembolization. Suppose there is no contrast blush, what is done? Only observation. And if angioembolization, it is not available or failed, in that case, again we go for laparotomy, exploratory laparotomy. So this is how we manage the patients of liver trauma, and it's frequently asked. Lots of questions are asked in relation to blunt trauma abdomen involving liver and spleen. In this image, you can see that patient is having seatbelt injury. Can you see the classical skin abrasion? So this is known as classical seatbelt sign. So you are going to find the skin abrasion involving what? Neck, chest, abdomen. So what is the location of this skin abrasion? You can see here. It is involving what? You can see here. Neck, clear, then chest, and then abdomen. So presence of skin abrasion over neck, chest, abdomen, this is known as classical seatbelt sign. So what happens in classical seatbelt sign? In classical seatbelt sign, there is presence of skin abrasion. So this is classical seatbelt sign. Classical seatbelt, clear? So this is classical seatbelt sign. And in classical seatbelt sign, what's the location of skin abrasion? It is involving neck, chest, abdomen. So there is involvement of neck, Abrasion is present in the neck, chest, abdomen. Neck, chest, abdomen. Clear? So this is classical seatbelt sign. Another question is asked, what is seatbelt syndrome? So the unique injury profile associated with seatbelt injury. Unique injury profile associated with use of seatbelt, that is known as seatbelt syndrome. And what is the problem with seatbelt injury? Here, it is associated with internal organ injury, especially which organ? There is increased risk of pancreaticoduodenal injuries. There is increased risk of intra-abdominal organ injuries, especially which one? Pancreaticoduodenal injuries. Clear? So question is asked, what is the most commonly injured structure in seatbelt injury? We discussed mesentery. So most commonly injured structure. This is frequently asked question. What is the most commonly injured structure? Clear? So most commonly injured structure in seatbelt injury, that's mesentery. It's the mesentery. Nowadays, examiners are twisting the question. If mesenteric tear is there, mesenteric trauma is there, what will happen to the gut? So lymphovascular supply of gut is going via mesentery. So if there is mesenteric trauma or mesenteric tear, because of this, what will happen? Gut ischemia. So this is the new question examiners are asking. They are asking that seatbelt injury is associated with what? Gut ischemia. Seatbelt injury, it is associated with gut ischemia. Why? Because there is tear in the mesentery. Clear? Now see what's the problem and how we are going to manage. You can see this image. This is normal mesentery with vasculature. So you can see here, via mesentery, the bowel is receiving its lymphovascular supply. Clear? Imagine some patient is having horizontal tear and some patient is having transverse tear. Imagine patient is having horizontal tear. Can you see here? There is this kind of tear. This is horizontal tear. Whenever horizontal tear is there, what will happen? This part of bowel will be ischemic. What? The bowel segment will develop ischemia. Clear? And if bowel segment will develop ischemia, obviously in this case, what's the treatment? Can you see here? We go for resection and anastomosis. So we are going to excise the ischemic bowel and then you can see here, we perform the anastomosis. So it is resection and anastomosis. What kind of tear is there? If the patient is having horizontal tear, can you see here? Which kind of tear is there? If the patient is having horizontal tear. So horizontal tear, this is also known as transverse mesenteric tear. Horizontal tear. This is also known as transverse mesenteric tear. So if there is transverse or horizontal mesenteric tear, we go for resection and anastomosis. You can see here, we perform resection and anastomosis. But if patient is having longitudinal tear, you can see here, patient is having longitudinal tear. So what's the good thing? Yes, that the bowel is receiving blood supply. Can you see here? The bowel is receiving its blood supply. So here ischemia is not there. So in this case, if tear is there, what kind of longitudinal tear? So we just suture the tear. So what we do? We just repair the tear. So if patient is having horizontal or transverse tear, what's the treatment? We perform resection and anastomosis. And if patient is having only longitudinal tear and there is no bowel ischemia, in these cases, just the tear in mesentery is sutured with hemostasis. So this is how we manage the patients of mesenteric trauma. What are the components of trauma triad of death? The components are hypothermia, coagulopathy and metabolic acidosis. What are the components? Components of trauma triad of death. Yes, this is hypothermia, and you know that hypothermia leads to coagulopathy. So components are hypothermia, it leads to coagulopathy, clear? And whenever there is coagulopathy, what happens? Perfusion is affected. It can lead to lactic acidosis, and after that, what will happen? There is metabolic acidosis. Clear? So this is trauma triad of death. What are the components? How to remember? It is hypertrophic cardiomyopathy, HCM. Mnemonic is HCM, that is hypertrophic cardiomyopathy. So hypothermia, coagulopathy, metabolic acidosis. What's the problem of hypothermia? We discussed that. Hypothermia halt coagulation cascade. There is coagulopathy. Because of coagulopathy, the perfusion is impaired. So there is lactic acidosis. And if patient is having metabolic acidosis, it is going to decrease the myocardial performance. So this is a vicious cycle, also known as trauma triad of death. Another important question. Out of these three, can you tell me what is the most common cause of death? So out of hypothermia, coagulopathy and metabolic acidosis, is the coagulopathy which is most common cause of death. So here, coagulopathy, this is the most common cause of death. Clear? Most common cause of death, this is coagulopathy. Now, what is the concept of damage control surgery? Previously, 40, 50, 60 years back, what happens? The patients who are unstable, having blunt trauma abdomen. Unstable patient having blunt trauma abdomen. Clear? In these patients, what happened? Previously, long duration surgeries were done, and if you are going to perform long duration surgery in a patient who is already having hypothermia, coagulopathy, metabolic acidosis, so you are just going to strengthen this by a long duration surgery. And what will happen? Obviously, it is going to increase the mortality. So nowadays, the concept is damage control surgery. So patients who are having blunt trauma abdomen, who are unstable, in these patients we go for damage control surgery, where we perform the abbreviated laparotomy. Whatever hemorrhage is there, contamination is there, we are going to control that. So control the hemorrhage and contamination. After that, shift the patient to ICU for resuscitation for 48 hours, where we are going to correct hypothermia, coagulopathy, metabolic acidosis. And when this hypothermia, coagulopathy, metabolic acidosis is corrected, next we are planning the definitive reoperation, and definitive operation is done where we are going to perform the planned re-exploration. So this is the concept of damage control surgery, which is also known as abbreviated laparotomy. So what are the phases of damage control surgery? There are 3 phases. Phase 1, where we perform the initial exploration. So what we do here rapid control of hemorrhage and contamination is done. Phase 2, that is secondary resuscitation. So we shift the patient to ICU for 48 hours and we correct hypothermia, coagulopathy and metabolic acidosis. And phase 3, here we perform the definitive operation. So one by one. Phase 1, that's initial exploration. So here what we do, rapid control of hemorrhage and contamination. What is done here? Rapid control of hemorrhage and contamination. So we perform laparotomy with rapid control of hemorrhage. So it's a rapid control of hemorrhage and contamination. Sometimes it's difficult to control the bleeding. If it's difficult to control the bleeding, in that case we can do the packing. And if there is perforation, we can just do the stapling. So it's a rapid control of hemorrhage and contamination. After that, secondary resuscitation. So we shift the patient to ICU. So what happens? Shift the patient to ICU for 48 hours. So this patient is shifted to ICU for 48 hours. And what we do here we are going to correct the hypothermia, coagulopathy, metabolic acidosis. So correct, what we are going to correct? Hypothermia. So we correct hypothermia, clear, coagulopathy and metabolic acidosis. So hypothermia, coagulopathy, metabolic acidosis, which was responsible for trauma triad of death, coagulopathy and metabolic acidosis. Clear? Metabolic acidosis. Okay. After that, phase 3, that's definitive operation. So here we perform planned re-exploration. So here planned re-exploration is done. Clear? So here we perform planned re-exploration. Clear? In these cases, the stoma formation is preferred over complex anastomosis. So these are the phases of damage control surgery: phase 1, phase 2, phase 3. Sometimes in exam, they ask the stages of damage control surgery. So there are 5 stages, 3 phases, 5 stages. See the stages of damage control surgery. So what are the stages? Stage 1, first the patient selection, that in which patient we are going for damage control surgery. So stage 1 is patient selection. That's the stage 1. Patient selection. In stage 2, obviously it's the operative control of hemorrhage and contamination. So what is the operative control? In stage 2, we perform the operative control of hemorrhage and contamination. Control of hemorrhage and contamination. Clear? So this is operative control of hemorrhage and contamination. Clear? After that, stage 3, we discussed that. After that, we are going to send the patient to ICU. So stage 3, that is ICU resuscitation. So stage 3, that is ICU resuscitation. After that, stage 4. Stage 4 is definitive surgery. It is definitive surgery. And what is stage 5 here? We go for abdominal closure. So stage 5, that's abdominal closure. It's the abdominal closure. Clear? So these are the 5 stages. If you're going to see the stage 2, 3, 4, the stage 2 is phase 1 of damage control surgery, stage 3 is phase 2, and stage 4 is phase 3. Clear? So these are stages and those were the phases. So read the question carefully whether stages are being asked or phases are being asked. Now we're going to discuss the abdominal compartment syndrome. First tell me what is the normal intra-abdominal pressure. Normal intra-abdominal pressure, that is 5 to 7 mmHg. It is 5 to 7. Okay. So normal intra-abdominal pressure, that is 5 to 7 mmHg. How much is the pressure if the patient is having intra-abdominal hypertension? In intra-abdominal hypertension, the pressure is more than equal to 12. So whenever pressure is more than equal to 12 mmHg, that is intra-abdominal hypertension. What is abdominal compartment syndrome? So whenever the intra-abdominal pressure is more than 20 mmHg, what will happen if there is intra-abdominal pressure more than 20? It results in the compression of abdominal structures. Now what happens in abdominal compartment syndrome? In abdominal compartment syndrome, the pressure is more than 20 mmHg. And what is the effect of this pressure? When pressure is more than 20 mmHg, obviously there is compression of intra-abdominal structures. What happens? There is compression of IVC. And because of increased intra-abdominal pressure, the diaphragm is pushed up. So if diaphragm is pushed up, the patients who are having abdominal compartment syndrome, these patients might be having fatal complications because of pulmonary failure. And since there is compression of intra-abdominal structure, compression of IVC, so there can be mesenteric vascular compromise. So abdominal compartment syndrome, what's the problem here? Pressure more than 20 mmHg with compression of intra-abdominal structure. So it results in compression of intra-abdominal structures. And because of compression of intra-abdominal structures and diaphragm is pushed up, what's the problem? These patients are having fatal complications. So it is associated with fatal complications. What are the causes of fatal complications? Yes, fatal complications. It can lead to what? Pulmonary failure. So fatal complications because of pulmonary failure and mesenteric vascular compromise. Clear? Pulmonary failure and mesenteric vascular compromise. Clear? Mesenteric vascular compromise, because if IVC will be compressed, venous return is reduced, cardiac output is decreased, patient is having hypotension. So obviously what will happen? There is ischemia. So there is mesenteric vascular compromise. Okay, so what's the problem? Whenever IVC is compressed, decreased venous return to heart is there is decreased cardiac output. Because of that, patient will be having hypotension and there will be mesenteric vascular compromise. Now see the pathophysiological changes in the patients who are having abdominal compartment syndrome. What are the parameters which are decreased and what are the parameters which are increased? What is the problem? Here you can see whenever there is increased intra-abdominal pressure, there is compression of IVC, and because of IVC compression, what will happen? There is decreased venous return to the heart. Because of decreased venous return to the heart, there is decreased cardiac output. Because of decreased cardiac output, what will happen? There is decreased renal blood flow, as well as it leads to decreased visceral blood flow. Clear? Decreased renal blood flow as well as visceral blood flow. Because patient is having hypotension. If there is decreased renal blood flow, obviously patient is having decreased GFR and there will be decreased urine output. So it leads to decreased GFR, and because of that, what will happen? There is decreased urine output. So patient will be having oliguria and ultimately anuria. Clear? And there is decreased visceral blood flow. So what will happen? Ultimately, patient will be having hypotension. So main problems in this situation, what happens? The patient will be having hypotension. The patient is having hypotension and the patient is having initially oliguria, and finally it can progress to anuria. So these are the parameters which are decreased. What? Blood pressure is decreased, hypotension, urine output is decreased, renal blood flow, visceral blood flow, all these are decreased. Now see the parameters which are increased. What is the problem? Because of increased intra-abdominal pressure, the diaphragm is pushed up. And what will be the after effects? There is increased peak inspiratory pressure, increased pulmonary capillary wedge pressure, there is increased intrapleural pressure, even CVP, central venous pressure is increased, heart rate or cardiac rate that is increased, and systemic vascular resistance, obviously this is also increased. Why? Because there is hypotension. So what will happen? Because of that, there is vasoconstriction. Clear? So all these parameters are increased. So these are the parameters which are increased. How to remember? You can see the mnemonic is PICS. It is PICS. So what is increased? PICS. It is increased. PICS. So PICS, that is peak inspiratory pressure, pulmonary capillary wedge pressure, intrapleural pressure, CVP, cardiac rate means heart rate, and systemic vascular resistance. These parameters are increased. The patients in whom there is increased peak inspiratory pressure. So because of this increased peak inspiratory pressure, the patients are having hypoxia and hypercapnia. So because of increased peak inspiratory pressure, patients are having hypoxia. So these patients are having hypoxia and hypercapnia. Clear? There is hypoxia and hypercapnia. Okay. Now, how to make the diagnosis of abdominal compartment syndrome? We can measure the bladder pressure. Why? Because bladder pressure represents the intra-abdominal pressure. So what's the gold standard indirect method to measure intra-abdominal pressure? Gold standard indirect method to measure the intra-abdominal pressure, we have to put a catheter in bladder. So with the help of urinary bladder catheter. So important question, how to make the diagnosis? How to make the diagnosis of abdominal compartment syndrome? Gold standard. So what's the gold standard indirect method? Clear? So gold standard indirect method. Gold standard indirect method to measure intra-abdominal pressure. It is the with help of urinary bladder catheter. So with the help of urinary bladder catheter, we can measure the intra-abdominal pressure. Now see the management of abdominal compartment syndrome. The management depends on the grade. In exam, they ask the grade also. So grade, it is on the basis of bladder pressure in what is grade 1 when the bladder pressure is 12 to 15, grade 2 it is 16 to 20, grade 3 21 to 25, and whenever it is more than 25 mmHg it is grade 4. Now see the clinical features. If it's grade 1, here patient is not having any clinical features. So clinical features, these are none. And how to manage? We go for resuscitation. What kind of resuscitation? We go for normovolemic resuscitation. So treatment, what we go for? Here we go for normovolemic resuscitation. It's the normovolemic resuscitation. Normovolemic resuscitation. If it is grade 2 and the pressure is 16 to 20 mmHg, now patient will be having oliguria. We discussed there is hypotension, reduced renal blood flow. So there is splanchnic hypoperfusion and oliguria. So these patients are having problems. What? Oliguria, and there is splanchnic hypoperfusion. There is splanchnic hypoperfusion. Splanchnic hypoperfusion. In these cases, again we go for resuscitation. But here, what kind of resuscitation is done? Here is the hypovolemic resuscitation. So in these patients, we go for what? We go for hypovolemic resuscitation. What kind of? It is hypovolemic resuscitation when it's grade 3. In grade 3, the pressure is 21 to 25 mmHg. Now here, the patient is having anuria and there is increased ventilation pressure. So what's the manifestation here? In grade 2, it was oliguria. Now it progressed to anuria. Here, patient is having anuria and there is increased ventilation pressure. Here, patient is having increased ventilation pressure. There is increased ventilation pressure. Clear? In grade 3, we have to go for decompression. So what's the management here? We go for decompression. We perform the decompression. And when it's grade 4, pressure more than 25 mmHg, apart from anuria and increased ventilation pressure here, patient is having reduced PO2. So apart from anuria and increased ventilation pressure, the patient is also having reduced PO2. PO2 is also reduced, and here we perform emergency re-exploration. So when patient is having grade 4 of abdominal compartment syndrome, here we perform emergency re-exploration. So here we perform emergency re-exploration. Clear? So it's the emergency re-exploration which is done. Now see the one-liner questions related to renal trauma. First, what is the most commonly injured part of urinary tract in trauma? The most commonly injured part of urinary tract, that's kidney. Most commonly injured part of urinary tract, that's kidney. What is the most common cause of renal trauma? So obviously it's road traffic accident. Most common cause of renal trauma, that's the road traffic accident. What's the best predictor of traumatic urinary system injury? Best predictor of traumatic urinary system injury. So obviously it's hematuria. Best predictor of traumatic urinary system injury, that is hematuria. Clear? Now see the investigations which are important in relation to renal trauma. So the question is, what is the investigation of choice for diagnosis of renal injury in stable patient? If the patient is stable, what is the best investigation to assess the kidney? Obviously, we go for CCT. It is CCT. So investigation of choice for diagnosis of renal injury in stable patient, CCT. But the problem, investigation of choice for diagnosis of renal injury in unstable patient. Since the patient is unstable, what? We don't have time to perform the CCT. Imagine patient is having renal trauma and what? Suppose this is the situation where you have to plan the nephrectomy, and without knowing the status of contralateral kidney, you cannot perform the nephrectomy. So if patient is unstable, what? We have to assess the contralateral kidney, and for assessment of contralateral kidney, we have to go for single shot IVP. So if patient is unstable, in these cases, we go for single shot IVP. Why we go for single shot IVP? Just we want to know whether the contralateral kidney is functioning or not. If you have to plan the nephrectomy, you have to see the status of contralateral kidney. So these were the important questions related to renal trauma, and this is all about abdominal trauma. Now we are going to start the shock. What is shock? It's the clinical syndrome resulting from inadequate tissue perfusion. Tell me, what is the most common type of shock? It is hypovolemic shock. And what is the cause of hypovolemic shock? It is caused by loss of blood volume, plasma volume, body sodium or water. So important question C related to shock. First, what's the most common type of shock? This is hypovolemic shock. Clear? So most common type of shock, that is hypovolemic shock. What's the cause of hypovolemic shock? It is caused by loss of blood volume, plasma volume, body sodium or water. Now see the important questions. What is the best clinical indicator of tissue perfusion, especially in the patients of shock? So best clinical indicator of tissue perfusion, that is urine output. So what's the best clinical indicator of tissue perfusion? That's urine output. Clear? It is urine output. Another question you can see, what is the best indicator to detect fluid required for resuscitation? What? Detect fluid required for resuscitation. So best indicator to detect or estimate fluid required for resuscitation, that is CVP, central venous pressure. It is CVP. These are one-liner questions which are asked in relation to shock. Many questions are asked about ATLS classification of hypovolemic shock. This is very, very important. See, ATLS classification. So according to ATLS classification, there are 4 classes of hypovolemic shock, and these classes are based on amount of blood loss. In questions, they are actually asking how much blood loss is there. So what's the percentage of blood loss which is going to occur in class 1? In class 1, the percentage of blood loss, it is 0 to 15%. So how much is the blood loss in class 1? It is 0 to 15. In class 2, it is 15 to 30%. Class 2, 15 to 30%. Class 3, 30. So in class 3, it is 30 to 40%. And class 4, how much? It's more than 40%. Class 4, it is more than 40%. So how to remember? 3, 30, 4, 40. Remember? 3, 30, 4, 40. So in class 3, it is 30 to 40. In class 4, it is more than 40. Clear? So blood loss in class 1, 0 to 15, class 2, 15 to 30, class 3, 30 to 40, and class 4, more than 40. Now see the pulse rate. Pulse rate, it's less than 100 in class 1. So how much is the pulse rate? It's less than 100 per minute in class 1. But what happens in class 2? It is more than 100. Class 3, it is 120, more than 120. And in class 4, it is more than 140. More than 140 per minute. After that, see the blood pressure. If you see blood pressure, it is maintained, or blood pressure appears normal in class 1 and class 2. Why? Because whenever there is blood loss, what happens? There is sympathetic stimulation, and because of that there is vasoconstriction, and whenever vasoconstriction is there in class 1 and class 2, it appears normal or maintained. So in class 1 and class 2, the BP is normal. It is normal in class 1 and class 2. But what happens in class 3 and class 4? Obviously the BP is decreased. So BP, it is decreased. In class 3 and class 4, it is decreased. If you see the urine output, in class 1, it is more than 30 ml per hour. How much? So more than 30 ml per hour in class 1. In class 2, it is 20 to 30 ml per hour. Here, it's 20 to 30 ml per hour. In class 3, it is only 5 to 15 ml. How much? It's 5 to 15 ml per hour. And what about class 4? The urine output in class 4, it's almost nil. So it's negligible or it's nil. It's nil or negligible. If you see the fluid required or fluid given for the resuscitation, in class 1 and class 2, we are just giving crystalloids. So for resuscitation, which fluid we are supposed to give? In class 1 and class 2, we are giving crystalloids. So what we are giving? We are giving crystalloids. In class 1 and class 2, we are giving crystalloid. Clear? What about class 3? Apart from crystalloid, we have to go for blood transfusion. Not only in class 3, in class 4 also. So apart from crystalloids here, we have to go for blood transfusion. So blood transfusion is also given apart from crystalloid in class 3 and class 4. Now let me discuss the questions. The questions which are asked frequently, they ask the blood loss. Class 1, 0 to 15, class 2, 15 to 30, class 3, 30 to 40, and class 4, there is more than 40% of blood loss. Another question which is asked frequently, that is related to physiological characteristics of various types of shock. Now see first hypovolemic shock. We discussed that. What's the cause of hypovolemic shock? Loss of blood volume, plasma volume, body sodium or water. Clear? Now what happens in this case? There is vasoconstriction. So see, because of loss of blood volume, plasma volume, body sodium or water, here CVP and pulmonary capillary wedge pressure, both of these are going to decrease. Clear? What about cardiac output? Obviously it is going to decrease. What about systemic vascular resistance? Because of sympathetic stimulation there is vasoconstriction, and if there is vasoconstriction, obviously there is increased systemic vascular resistance. What about venous oxygen saturation? Obviously it is going to decrease. Venous oxygen saturation is going to decrease in all types of shock. The only exception is what? Hyperdynamic phase of septic shock. Only in hyperdynamic phase of septic shock there is higher venous oxygen saturation. Otherwise in all types of shock there is lesser or venous oxygen saturation, it is decreased. Only in hyperdynamic phase of septic shock it is increased. Clear? What happens in cardiogenic shock? There is impaired pumping ability of heart. Clear? So because of this, what will happen? The CVP and pulmonary capillary wedge pressure, this is going to increase. But obviously cardiac output, it is going to decrease. Clear? Obviously there will be increased systemic vascular resistance, right? And what happens? The venous oxygen saturation, again it is going to decrease. Clear? So in cardiogenic shock, what you have to remember, that CVP and pulmonary capillary wedge pressure, it is going to increase. Why? Because there is impaired pumping ability of heart. Now, if you see septic shock, there is early phase, there is late phase. The early phase is hyperdynamic and the late phase is hypodynamic. So, if there is hyperdynamic phase of septic shock here, what happens? The CVP and pulmonary capillary wedge pressure, it can be increased also or it can be decreased. But if you see cardiac output, this is the only type of shock where cardiac output is increased and venous oxygen saturation is increased. Only type of shock where cardiac output and venous oxygen saturation is increased. But here systemic vascular resistance, this is decreased. Clear? Next, hypodynamic phase. In hypodynamic phase, if you see CVP and pulmonary capillary wedge pressure, it can be increased or it can be decreased. Cardiac output, obviously it is decreased. Here systemic vascular resistance, obviously it is going to increase, and venous oxygen saturation, it can be decreased or it can be increased. Clear? Now coming to the neurogenic shock. In neurogenic shock, what's the problem? There is loss of sympathetic tone. And if there is loss of sympathetic tone, what will happen? There is vasodilatation in the arteries as well as vein. What? Vasodilatation in the artery as well as vein. So what will be happening here in neurogenic shock? Obviously CVP and pulmonary capillary wedge pressure, this is going to decrease. Obviously cardiac output is going to decrease. Systemic vascular resistance, again it is going to decrease. Why? Because there is vasodilatation of both artery as well as vein, and venous oxygen saturation, this is also going to decrease. So let me tell you, neurogenic shock is the only type of shock where you can see all these parameters are going to decrease. So you can see here all these parameters are going to decrease in neurogenic shock. Next, hypoadrenal shock. If you see the hypoadrenal shock here, there is CVP and pulmonary capillary wedge pressure which is going to decrease. Cardiac output, again it is going to decrease. If you see systemic vascular resistance, it can be normal or it can decrease. It can be normal or it can be decreased. And venous oxygen saturation, it is decreased. Clear? Now the questions which you have to remember. See, first question, that systemic vascular resistance, if you see, it is increased. Systemic vascular resistance, it is increased in hypovolemic shock and hypodynamic phase of septic shock. Clear? Second question, what? Venous oxygen saturation, it is increased only in, you can see here, venous oxygen saturation, it is increased only in hyperdynamic phase of septic shock. And what is the another feature of hyperdynamic phase of septic shock? That cardiac output is increased. So only type of shock where cardiac output as well as venous oxygen saturation, it's going to increase. That's hyperdynamic phase of septic shock. And all parameters are decreased, like CVP, pulmonary capillary wedge pressure, cardiac output, systemic vascular resistance, venous oxygen saturation. That is what? That's neurogenic shock. Clear? So all these are questions which are asked frequently. Now see the questions which are asked in surgery. This kind of scenarios mention that a patient of road traffic accident is brought to your emergency. First situation, that patient is having tachycardia and cold peripheries. What kind of shock is there? And second, there is bradycardia and warm peripheries. So first see, if there is tachycardia and cold peripheries, it is suggestive of hypovolemic shock. Why? Because hypovolemic shock in trauma patient, obviously it is because of blood loss. Whenever there is blood loss or loss of blood volume, there is sympathetic stimulation. And if there is sympathetic stimulation, what will happen? There is vasoconstriction. So because of that, what happens? Patient is having sympathetic stimulation. What happens? Tachycardia, and since there is vasoconstriction, obviously there is cold peripheries. So patients are having tachycardia and cold peripheries in which type of shock? Yes, this is a question. In hypovolemic shock. In hypovolemic shock. Clear? In hypovolemic shock. So tachycardia, cold peripheries, just opposite. Road traffic accident patient with bradycardia and warm peripheries. Now what happens? It is typically seen in neurogenic shock. Because of injury, what happens? There is loss of sympathetic tone. And if there is loss of sympathetic tone, there is vasodilatation in arteries as well as vein. So if there is vasodilatation in arteries and vein, obviously there is bradycardia because there is loss of sympathetic tone. And since there is vasodilatation, the peripheries are warm. So bradycardia and warm peripheries, these are seen in neurogenic shock. In neurogenic shock. Clear? So both of these questions are asked. Read the question carefully, mark the answer accordingly. There are questions which are asked in relation to shock index and modified shock index. First, see the formula. What is shock index? It is heart rate divided by systolic blood pressure. So shock index, the formula is heart rate divided by systolic blood pressure. And if you see modified shock index here, it is heart rate divided by mean arterial pressure. So this is what? Heart rate divided by mean arterial pressure, right? Now, the problem, if you see the shock index, this is hemodynamic stability indicator. It is also known as hemodynamic. So this is also known as hemodynamic. Clear? This is hemodynamic stability indicator. Stability indicator. Right? So this is hemodynamic stability indicator. So if you compare modified shock index with shock index, modified shock index is a better marker for mortality rate prediction. So modified shock index is a better marker. This is better marker. It's better marker for mortality rate prediction. Better marker for mortality rate prediction. Clear? So the questions which are asked in exam, shock index, that is heart rate divided by systolic blood pressure, and modified shock index, it is heart rate divided by mean arterial pressure, and it's better marker for mortality rate prediction. So this is all about shock. Now we are going to start facial injuries and abnormalities. First of all, we are going to discuss the cleft lip and cleft palate. So what's the most common congenital abnormality of orofacial structures? It is cleft of lip, cleft of alveolus, cleft of soft and hard palate. So most common congenital abnormality of orofacial structures, it is cleft abnormalities. So what's the problem there? There is cleft of lip. So it's cleft lip, cleft of alveolus, and cleft of soft and hard palate. So cleft of soft and hard palate. Clear? Soft and hard palate. Okay. If you see cleft lip and cleft palate, usually these are isolated. But there is one syndrome with which it is associated, and this is asked frequently. It is associated with Pierre-Robin syndrome. What's the name? It is associated with Pierre-Robin syndrome. Associated with Pierre-Robin syndrome. Clear? So it is associated with Pierre-Robin syndrome. Now see the incidence of cleft lip and cleft palate and incidence of isolated cleft palate. The incidence of cleft lip and palate, it is common. It is 1 in 600 live births. This is 1 in 600 live births. Clear? And if you see the incidence of isolated cleft palate, that is 1 in 1000 live births. So this is 1 in 1000 live births. 1 in 1000 live births. Okay. If you see which combination is most common, it's cleft lip alone, cleft palate alone, or cleft lip plus cleft palate. So the most common combination is actually, it's the cleft lip plus cleft palate. Now see the development of upper lip and lower lip. What happens? Upper lip mainly develops from maxillary process. This is known as, this process, it is known as maxillary process. So upper lip mainly develops from this maxillary process. This is maxillary process. Okay. And if you see in upper lip here, there is a philtrum. So this philtrum develops from this frontonasal process. What's the name? This is frontonasal process. So philtrum develops from frontonasal process and the upper lip develops from maxillary process. Clear? If you see the lower lip here, the lower lip develops from mandibular process. So this is mandibular process. Lower lip develops from mandibular process. It develops from mandibular process. Okay. So what kind of questions which are asked nowadays in exam? The questions are in relation to unilateral cleft lip and bilateral cleft lip. So what's the problem in unilateral cleft lip? You can see here, it is caused by failure of fusion of, this is maxillary process and this is medial nasal process. What's the name? This is medial nasal process. So unilateral cleft lip, it is because of failure of fusion of maxillary process and medial nasal process. And if you see bilateral cleft lip, it is caused by failure of fusion of what? Maxillary process. Failure of fusion of, you can see, maxillary process and what else? Frontonasal process. So I'm repeating, unilateral cleft lip, it is because of failure of fusion of medial nasal process with maxillary process, and bilateral cleft lip, it is caused by failure of fusion of maxillary process and frontonasal process. So what are the problems with the patients who are having cleft lip and cleft palate? These patients are having breathing and feeding difficulty. What's the problem? The problem with cleft lip and cleft palate, the patients are having breathing difficulty. So these patients are having breathing difficulty and patients are having feeding difficulty. So there are breathing difficulty and feeding difficulty. Clear? Important question. Can you detect cleft lip and cleft abnormality during pregnancy? Yes. If patient is having isolated cleft palate, it can be detected at 18th weeks of gestation. So prenatal diagnosis is possible in cleft lip and cleft palate. Prenatal diagnosis. Yes, prenatal diagnosis is possible if patient is having isolated cleft palate. Patients who are having isolated cleft palate, it can be detected at 18 weeks. This question was asked. It is detected at 18 weeks of gestation. Clear? So it is detected at 18 weeks of gestation. It means the cleft abnormality can be detected during pregnancy. Now what's the management? Here we have to go for surgery. Why we have to go for surgery? Here the surgery is done for restoration of anatomy. So in these cases, why we do surgery? Surgery is done for restoration of anatomy. What are the names of surgical procedures which are performed? So you have to remember the names. First is Millard rotation advancement technique, and this is the most commonly used technique. So this is the most commonly used surgical procedure or technique. The name is Millard rotation advancement technique. Other names which you have to remember. The second is Lee Museriers, Tennyson, Rendall and Thompson. So you have to remember the names. Most commonly used, that is Millard rotation advancement technique. Second is Lee Museriers, third Tennyson, Rendall and fourth is Thompson. Now, what is the timing of repair? This is one of the frequently asked questions and it's very easy to remember. Imagine patient is having soft tissue abnormality. Soft tissue abnormalities are repaired together. Means if patient is having cleft lip, cleft of soft palate and hard palate, so cleft lip plus cleft of soft palate is repaired together. So soft tissue abnormalities are repaired together, hard tissue abnormalities are repaired separately. One principle is clear. Second, soft tissue abnormalities. If the patient is having cleft lip, the best age for repair is 5 to 6 months. If it is unilateral, best age is 5 to 6 months. And if patient is having bilateral cleft lip, the best age is 4 to 5 months. So unilateral cleft lip, it is repaired at 5 to 6 months. Bilateral cleft lip, 4 to 5 months. Okay. Soft palate, it should be repaired at 6 months, and hard palate, it should be repaired at 15 to 18 months. Clear? This you have to remember. Now see the management and timing of repair. So first see, if patient is having cleft lip alone, and if it's unilateral, we go for one operation and it is performed at 5 to 6 months. So one operation is done at 5 to 6 months. 5 to 6 months of age. Clear? If it is bilateral, we discussed that it should be done at 4 to 5 months of age. 4 to 5 months. If patient is having cleft lip alone. Second situation, if the patient is having cleft palate alone, we discussed that if abnormalities involving only soft palate, so soft palate is repaired at 6 months. Soft palate, it is repaired at 6 months. So one operation for soft palate at 6 months. If patient is only having cleft of hard palate, in this case the surgery should be done. There is one operation and this operation is done at 15 to 18 months. It is done at 15 to 18 months. If patient is having cleft palate involving both soft and hard palate, so here we discussed that soft palate repair should be done at 6 months, hard palate repair should be done at 15 to 18 months. So here we go for 2 operations. In this case, we go for 2 operations. So 2 operations are done. Here 2 operations. Soft palate, it is repaired. Here you can see. So soft palate is repaired at 6 months. So soft palate, it is repaired at 6 months, and hard palate, it is repaired at 15 to 18 months. Hard palate, it is repaired at 15 to 18 months. Clear? Now see the next situation. If patient is having both cleft lip plus palate, patient is having both cleft lip plus palate. So if it is unilateral, in that case we go for cleft lip plus repair of soft palate at 5 to 6 months. Cleft lip plus soft palate repair at 5 to 6 months. It is done at 5 to 6 months. And you know, hard palate repair, it is done at 15 to 18 months. So hard palate repair, it is done at 15 to 18 months. Clear? If it's unilateral. If cleft lip and palate it's bilateral, so cleft lip plus soft palate repair, obviously it's done a bit earlier, 4 to 5 months. It's done a bit earlier, 4 to 5 months. And hard palate repair, you know the age, 15 to 18 months. Hard palate age 15 to 18 months. So easiest way to remember, you know, cleft lip, best stage to repair 5 to 6 months if it's unilateral, bilateral 4 to 5 months, soft palate best stage 6 months, hard palate best stage 15 to 18 months. And you know, soft tissue repairs are done together. So cleft lip is repaired along with soft palate, hard palate repair should be done separately at 15 to 18 months. Now we are going to discuss the mid-phase fractures. These are also known as Lee-Ford fractures. So what's the name? These are mid-phase fractures. Clear? Mid-phase fractures. These are also known as Lee-Ford fractures. What's the name? Also known as Lee-Ford fractures. So Lee-Ford fractures. Clear? Lee-Ford fractures are further divided into 3 levels. Level 1. So Lee-Ford 1, Lee-Ford 2, Lee-Ford 3. If you see Lee-Ford 1 here, in the Lee-Ford 1, the fracture line you can see here, the fracture line, it runs above and parallel to the palate. Since it runs above and parallel to palate, it is going to separate alveolus and palate from the facial skeleton. So you can see it separates alveolus and palate from the facial skeleton. This is Lee-Ford 1. If you see Lee-Ford 2, in Lee-Ford 2 you can see the fracture line passes through the root of nose. Clear? Here you can see lacrimal bone. You can see this part, this is floor of orbit, and upper part of maxillary sinus, you can see this, and pterygoid plate. So fracture line passes through root of nose, nasal bone, floor of orbit, upper part of maxillary sinus and pterygoid plate. Clear? After that there is Lee-Ford 3. Lee-Ford 3 level, here you can see there is complete disjunction. In this case you can notice that there is complete disjunction of facial skeleton from skull. So in Lee-Ford 3 there is complete disjunction of this facial skeleton from skull. And in this case the fracture line passes through what? Nasal bone. Here you can see the fracture line passes through nasal bone. You can see in Lee-Ford 3, the fracture line passes through nasal bridge. Here you can see it's nasal bridge, septum, ethmoid. Here you can see orbit, so bone of orbit, and what? Frontozygomatic suture. Clear? So it passes through nasal bone, septum, ethmoid, orbit, and frontozygomatic suture. So this is Lee-Ford 3. So let's compare Lee-Ford 1, Lee-Ford 2, Lee-Ford 3 fractures. So you can see this is Lee-Ford 1. In Lee-Ford 1, the fracture line runs above and parallel to the palate. And here, the alveolus and palate, it is separated from the facial skeleton. So alveolus and palate, it is separated from the facial skeleton. This is Lee-Ford 1. In this image, you can see the shape of Lee-Ford 2. So here, Lee-Ford 2 fracture, you can see it is pyramidal. And here the fracture line passes through nose, lacrimal bone, orbital floor, upper part of maxillary sinus and pterygoid plate. So how to remember? How to remember this Lee-Ford 2? The mnemonic is nose, low, maxilla pe. Here the mnemonic is nose. It's nose, low, maxilla pe. Clear? So it is nose, low, maxilla pe. Nose means obviously nose, LA. This is lacrimal bone, O. That is orbital floor, maxilla. This is the maxillary sinus upper part, and pe. This is pterygoid plate. Clear? After that, see the Lee-Ford 3 fracture. So in Lee-Ford 3, you can notice that there is complete disjunction of facial skeleton from the skull. So here, there is complete disjunction of facial skeleton from skull. And in this case, you can notice that the fracture line passes through here. What? Nasal bridge. So here you can notice that the fracture line passes through the nasal bridge, septum, ethmoid, orbit, and frontozygomatic suture. Clear? How to remember this? The mnemonic is NSC of Z. So fracture line passes through NSC of Z. It is NSC of Z. N nasal bridge, S septum, E ethmoid, O orbit, so orbital bone, FZ, that is frontozygomatic suture. So nowadays frequently they are asking Lee-Ford fracture, Lee-Ford 1, Lee-Ford 2, Lee-Ford 3. So this is all about facial injuries and abnormalities. Now we are going to start burns and plastic surgery. First of all, we are going to discuss the causes of death in patients of burns. First, what is the most common cause of death at the site of burn or at the site of accident? That is asphyxia. So most common cause of death at the site of burn or at the site of accident, that is asphyxia. It is asphyxia. Clear? Next question. What is the most common cause of early death? Most common cause of early death in burns, it is hypovolemia or shock. So most common cause of early death in patients of burns, that is hypovolemia. So this is hypovolemia or shock. Hypovolemia or shock. Next, what is the most common cause of late death in patients of burns? That is sepsis. So most common cause of late death in patients of burns, sepsis. And suppose it is asked that overall most common cause of death in patients of burns. So overall most common cause of death in patients of burns, that is sepsis. So overall most common cause of death in patients of burns, that is sepsis. Now tell me, what is the most common organism responsible for sepsis in patients of burns? Usually after 7 to 10 days, whenever we are changing the dressing, the color of dressing started turning green. So obviously which organism? Pseudomonas. So most common organism responsible for sepsis in patients of burns, that is Pseudomonas. That is Pseudomonas. So these are important one-liner questions which are asked frequently. Next, now see the degree of burns. So the burn classification, it is based on the depth of burn. So see the degrees of burns. In this image you can see what is first degree burn. In the first degree burn there is involvement of only epidermis. Since there is only involvement of epidermis, so this first degree burn, it is also known as what? Epidermal burn. So first degree burn, what is the other name? This is also known as epidermal burn. First degree burn, that is also known as epidermal burn. So you saw here that there is involvement of which layer? There is involvement of epidermis. In epidermal burn, obviously there is involvement of epidermis. That is the first degree burn. What is the classical example? Whenever you are going to the kitchen and suddenly you are going to touch some hot object, or whenever you are going to touch hot iron, what happens? At the site of touch, you can see that there is a red line, means there is erythema, and obviously it is painful. But blisters are not there and healing occurs within 5 to 10 days. This is first degree burn or epidermal burn. So there is involvement of epidermis. What? There is redness or erythema. So it is erythematous. Epidermal burn, this is erythematous. Clear? You know, it is painful. Painful. There are no blisters. So it is painful. There are no blisters. No blisters. And you know, healing occurs without scarring within 5 to 10 days. So healing occurs without scarring within 5 to 10 days. Healing occurs without scarring within 5 to 10 days. Clear? This is epidermal. Whenever, apart from epidermis, there is involvement of dermis, this is known as second degree burn. And what is the other name of second degree burn? This is also known as partial thickness burn. So second degree burn, this is also known as partial thickness burn. This is also known as partial thickness burn. Clear? Second degree burn, also known as partial thickness burn. So here, you know, there is involvement of epidermis plus dermis. There is involvement of epidermis. So apart from involvement of epidermis, there is involvement of dermis. Clear? Partial thickness burn. This second degree burn, it is further divided into superficial partial thickness burn and deep partial thickness burn. What's the problem? In superficial partial thickness burn, there is involvement of papillary dermis, and in deep partial thickness burn, there is involvement of reticular dermis. See the differences? So second degree burn is further divided into superficial partial thickness burn and deep partial thickness burn. First see the superficial partial thickness burn. In superficial partial thickness burn, there is involvement of epidermis plus papillary dermis. Blisters are present. So in superficial partial thickness burn, there is presence of blisters and healing occurs without scarring within 7 to 14 days. So healing occurs without scarring within 7 to 14 days. Let's discuss it with one example. Suppose you are making tea or coffee for someone special for the first time. So in excitement, what happens? Whenever you are transferring the tea or coffee, sometimes there is spillage of hot tea, hot milk, hot water. And because of spillage of that hot liquid, what happens? There are 3 to 4 blisters. So obviously it is painful. There are blisters, but what is the good thing? Healing occurs without scarring within 7 to 14 days. What happens in deep partial thickness burn? Here, there is involvement of epidermis plus reticular dermis. So here, there is involvement of epidermis plus, so there is involvement of epidermis plus reticular dermis. Epidermis plus reticular dermis. Clear? involvement of epidermis plus reticular dermis. If you see the burned surface is mottled. There are pinkish and whitish areas. But here the problem, there are no blisters, there is no pain. So there are no blisters, there is no pain, but pinprick sensation is preserved. In these patients, what? Pinprick sensation is preserved. Pinprick sensation. Clear? So pinprick sensation, it is preserved. This is preserved, right? And in these patients, healing occurs with permanent scar and it takes 3 to 9 weeks. So deep partial thickness burn here, healing occurs with permanent scar. So healing occurs with scarring. Healing occurs with scarring. So healing with scarring in 3 to 9 weeks. So healing occurs with scarring in 3 to 9 weeks. So within 3 to 9 weeks. That's the problem. Clear? So superficial partial thickness burn, deep partial thickness burn. One question is asked directly that in which degree of burn you are going to find the blisters. Blisters are only seen in second degree burn, and which type? Superficial partial thickness burn. Clear? After that, see third degree burn. In third degree burn, you can see here, apart from involvement of epidermis, dermis, there is involvement of subcutaneous fat. So what? Apart from epidermis, dermis, there is involvement of subcutaneous fat. And this was the question in latest exam, that subcutaneous fat is involved in which degree of burn? Third degree burn. And what is the other name of third degree burn? This is full thickness burn. So what's the other name? Third degree burn. Third degree burn, it is also known as full thickness burn. So this is also known as full thickness burn. Full thickness burn, what you have to remember, that apart from epidermis and dermis, there is involvement of subcutaneous fat. Clear? What is the problem here? Whenever there is full thickness burn or third degree burn, yes, the burned surface is having leathery eschar. What kind of leathery eschar? There is black colored leathery eschar. One problem. So burned surface, what happens? The burned surface is having black colored leathery eschar. So there is presence of black colored leathery eschar. Clear? Second, since there is involvement of epidermis, dermis, subcutaneous fat, there is no pain, no blisters, no pinprick sensation. No pain, no blister, no pinprick sensation. Suppose patient is having this third degree burn in some of the limb and it is circumferential eschar. What is the problem? If there is circumferential eschar, there is increased risk of compartment syndrome. So how to prevent it? How to prevent this compartment syndrome? We have to perform escharotomy. So if patient is having circumferential eschar increases the risk of compartment syndrome. Clear? So it can lead to compartment syndrome. Why? Because beneath eschar there is fluid collection, there is edema. So how to prevent this compartment syndrome? To prevent the compartment syndrome, what we go for? We go for escharotomy. So how to prevent the compartment syndrome? We go for escharotomy. And in these patients, means in third degree burn, healing occurs with contracture. Here, the big problem, that healing occurs with contracture. So I'm sure you have seen a patient of contracture. What happens? The flexor aspect is going to fuse. So suppose here is the contracture. So this is the posture. This kind of posture is there. Clear? So this is what? Contracture. How to prevent contracture? So whenever these patients are brought to the emergency, we resuscitate the patient first. We take the patient to OT, we excise the burned skin and we'll go for skin grafting. So this is how we are going to prevent the contracture in patients with third degree burn. Next, fourth degree burn. So in fourth degree burn, apart from skin involvement, there is involvement of underlying structures. So what are those underlying structures which are involved? There is involvement of muscle, bone or brain. So in fourth degree burn, there is involvement of skin. Plus underlying structure. There is involvement of skin plus underlying structures. So what are those underlying structures? Like muscle, bone or brain. So involvement of skin plus underlying structures like muscle, bone or brain. Clear? So involvement of muscle, bone or brain. This is fourth degree burn. So these are the degrees of burns. This is the burn classification, and this is one of the frequently asked question. Now see the management of burn patient. Burn is a kind of trauma. So burn patients are also managed like trauma. What are the components of primary survey in trauma? A, B, C, D, E. In burns also we follow A, B, C, D, E. Apart from A, B, C, D, E, sometimes F is also added. So what is A, B, C, D, E? A means airway, B breathing, C circulation, D disability, E exposure with environmental control. What is F in burns? F means fluid resuscitation. Clear? So whenever these patients are brought to emergency, we have to look for danger signs of airway burns. What are the danger signs? Suppose the patient is having burns involving head and neck and face. Head and neck and face. If you are going to examine it closely, there is singed or burned nasal hair. Patient is having carbonaceous deposit in the sputum, or patient is having hoarseness of voice, or relatives are giving the history that there was history of burn in the closed room. So in all these cases, yes, we suspect the airway burns. And whenever we suspect airway burns, what is safest? In airway burns, elective intubation is safest. So in these cases, whenever you are going to suspect the airway burns, what is safest? Elective intubation is safest. Elective intubation. So if you suspect the airway burns, elective intubation is safest. Why? Why elective intubation is safest? See, if you are not going to perform the intubation, elective intubation, what will happen? After some time, patient is going to develop laryngeal edema. And if patient develops laryngeal edema and you are going to attempt intubation, obviously it is going to fail. So if there is delay, what will happen? If there is delay in elective intubation, then what happens? Patient develops laryngeal edema. If there is delay, so what is the problem? Then patient develops laryngeal edema. You have seen cases of laryngeal edema. Clear? So if patient develops laryngeal edema, obviously in these cases we have to go for emergency cricothyroidotomy. So what happens? If patient develops laryngeal edema, in these patients we go for what? Emergency cricothyroidotomy. Emergency cricothyroidotomy. Clear? So what is safest? If there are danger signs of airway burns, elective intubation is safest. If there is delay, if patient develops laryngeal edema, in that case we have to go for emergency cricothyroidotomy. So we discussed that in patients of burns we are going to follow A, B, C, D, E, F. A, B, C, D, E, F. F means fluid resuscitation. So see the important points related to fluid resuscitation in patients of burns. First, what is the fluid of choice in burns? Obviously, it is Ringer lactate. Fluid of choice in burns, it is Ringer lactate. Second, in children, there is very little glycogen reserve. That's why in children, for maintenance fluid, we have to add dextrose. So what is the maintenance fluid of choice in burns in children? Maintenance fluid of choice in burns in children, it is DNS, that is dextrose normal saline. Maintenance fluid of choice in burns in children, it is dextrose normal saline. And some patients who are having burn shock means you are giving crystalloids, still patient is not improving. Clear? In those cases, we have to give colloids. Clear? So what is the fluid used for burn shock patient? We use hypertonic saline. So fluid used for burn shock patient, what we use? We use hypertonic saline. We use hypertonic saline. You know that for calculation of fluid requirement, what we use formula, and what is the most commonly used formula? We follow Parkland formula. So see the important points related to Parkland formula. Yes, for calculation of fluid, we use this Parkland formula. Parkland formula. Clear? So what is this Parkland formula? 24 hours fluid requirement in ml is 4 into body weight in kg into percentage of burn surface area. So see here, it is the 24 hours fluid requirement. How much is the 24 hours fluid requirement? 24 hours fluid requirement. Clear? In ml. In ml. How it is calculated? It is 4 into body weight in kg. 4 into body weight. Clear? So this is 4 into body weight in kg into percentage of burned surface area. So 4 into body weight in kg into percentage of burnt surface area. Burnt surface area. Clear? Right? Here, first degree burns are not included in the calculation. Second, the time is calculated since the time of burns. Half of the calculated fluid is given in the first 8 hours. Rest half is given in next 16 hours. Half of the calculated fluid it is given in first 8 hours, rest half is given in next 16 hours, and maximum fluid given is calculated according to 50% of burns. Okay, let's discuss with one example. Imagine there is a 50 kg female. Imagine there is a 50 kg female. Clear? She is having 50% burns. So 50 kg female having 50% burns. Right? Calculate the fluid requirement. So here you can easily calculate. It is 4 into body weight, how much? 50 into burn surface area 50%. So it is total 10,000. So it is 10,000 ml, that is equivalent to 10 liters. Clear? So this is the 24 hours fluid requirement. We discussed that half of fluid is given in first 8 hours and rest half is given in next 16 hours. So you can see obviously 5 liters will be given in first 8 hours. 5 liters in first 8 hours. Clear? And rest 5, it is given in next 16 hours. Rest 5 liter, it is given in next 16 hours. Clear? Suppose this patient is having 60% burn, 70% burns, 80% burns, even 100% burns. Then also the 24 hours fluid requirement is 10 liters only. Why? We discussed that the maximum fluid given is calculated according to 50% of body surface area. Clear? So if it's 60, 70, 80, 90, 100%, then also it is 10 liters only for this patient because the body weight is 50. Clear? So 5 liters in first 8 hours, 5 liters in next 16 hours. In one of the latest exam, this question was asked that what is the second day fluid requirement? And if you see, second day fluid requirement is 50% of first day fluid requirement. So obviously, second day fluid requirement will be also 5 liters. What? If you see the second day fluid requirement, it is usually 40 to 60%, but we take average how much? 50%. So second day fluid requirement, it is 40 to 60% of first day. 40 to 60% of first day. How much we take? Average 50% is taken. So obviously, second day fluid requirement will be 5 liters. 5 liters should be given on second day also. So here you can see that if X amount of fluid is given in first 8 hours, the same X amount is given in next 16 hours and the same X amount is given in next 24 hours. But guys, see, this is traditional Parkland formula. There is ATLS modification. So what is this ATLS modification of Parkland? Now see the ATLS modification. If patient is having flame or scald, category of burn, there is flame or scald, and age and weight, adult patient and older children. Older children means whenever the age is more than equal to 14 years. So adults and children more than equal to 14 years. Here, what we have to calculate, the formula, it was 4 ml into body weight in kg into percentage of burn surface area. But here, it is half. How much? It is 2 ml. So here, it is 2 ml. Clear? And if the age of child is less than 14, or if patient is infant or young children, body weight is less than equal to 30 kg. For both of these, how much we take? It is 3. It is 3 into body weight in kg into percentage of burn surface area. So I'm repeating. In adults and in children more than equal to 14 years, it is 2 ml into body weight in kg into percentage of burn surface area. In children less than 14 years of age and body weight less than equal to 30 kg, it is 3 ml into body weight in kg into burn surface area. Clear? In children, you know that we have to use a sugar, means dextrose containing solution for the maintenance. And we discussed that maintenance fluid of choice in burns in children. What? It is DNS, dextrose normal saline. Clear? And suppose patient is having electrical injury or electrical burn, any patient, adult, child, in all those cases, what? It is 4 ml. It is just like traditional Parkland 4 ml. Clear? So you have to remember this ATLS modification also. In exam, if it is mentioned that you have to use ATLS modification, use this one. And if nothing is mentioned, you have to use traditional Parkland formula. See the important points related to monitoring of fluid resuscitation. First question, what is the best clinical? What is the best clinical indicator of tissue perfusion? And you know, the best clinical indicator of tissue perfusion, that is urine output. So the best clinical indicator of tissue perfusion, that's urine output. Clear? So it is urine output, best clinical indicator for tissue perfusion. Now what should be the minimum urine output after adequate tissue perfusion in adults and in children? The minimum urine output after adequate tissue perfusion in adults and in children. So you know that in adults it should be 1 ml per minute. How much in adults? It is 1 ml per minute. Clear? If you calculate it, it will be 60 ml per hour, and in children it is 0.5 to 1 ml per minute. So in children it is 0.5 to 1 ml per minute. Obviously in children it will be 30 to 60 ml per hour. So best clinical indicator of tissue perfusion, that is urine output. Minimum urine output after adequate tissue perfusion in adults, it should be 1 ml per minute. We have to calculate the burn surface area also, and you know that determination of burn size, it is going to estimate the extent of injury. Determination of burn size, it is going to estimate the extent of injury. One of the commonly used formula is rule of 9, and who gave rule of 9? Wallace. So in this image you can see this is rule of 9. It was given by Wallace. Rule of 9, it was given by Wallace. How to remember? It's very easy. Whatever the small surface area is there in the body, that is 9%, means head and neck 9 and upper limb 9. Whatever the areas which are having large areas, yes, those are 18%. So what? Chest and abdomen 18, back 18, lower limb 18, and the smallest is genitalia, that is 1%. So it's very easy to remember. Yes, 9%. Clear? 9%, it is for head and neck. 9%, this is for head and neck. Clear? And this is for upper limb. So 9% is for head and neck and upper limb. Clear? 18%. If you see 18%, it is for chest and abdomen. 18%, that is for chest and abdomen. Clear? It is for back and lower limb. So it's for back, and it's for lower limb. And 1%, the smallest area, that's 1%, and 1% is for genitalia. So 1% is for genitalia. It's for genitalia. Clear? Now let me tell you, there is symmetrical distribution. Means in head and neck, if it is 9%, anterior aspect 4.5, posterior aspect 4.5. If upper limb is 9, anterior aspect 4.5, posterior aspect 4.5, chest and abdomen 18, chest 9, abdomen 9, back 18, upper back 9, lower back 9, lower limb 18, so thigh 9, leg 9. Clear? Now imagine this is arm and this is forearm. So since upper limb is 9, arm and forearm is there. So in arm there is 4.5, in forearm there is 4.5. Clear? So this is the symmetrical distribution. Nowadays questions are asked like there is involvement of only anterior aspect of head and neck, there is involvement of only chest, involvement of only abdomen. So accordingly you have to calculate. So this is rule of 9 which was given by Wallace. Problem. This rule of 9 is not very accurate in children. Why? Because in children with age, there is difference in the body surface area. So which formula is most accurate? Is the Lund and Browder chart, which is most accurate for estimation of burn size, estimation of true burn size in children. So what's the name? It's the Lund and Browder chart. You have to remember. It's the Lund and Browder chart. Name, that's Lund and Browder chart. Clear? Lund and Browder chart. This is most accurate for estimation of true burn size in children. This is most accurate. So this is most accurate for estimation of true burn size. For estimation, clear? Estimation of true burn size in children. Of true burn size in children. For estimation of true burn size in children. Clear? This is also asked frequently. What's the name? It's Lund and Browder chart. Next, it is very difficult to get the ideal patient in whom there is exactly involvement of head and neck, exactly involvement of upper limb or lower limb. What happens? These patients are having patchy burns. So whenever the patients who are having patchy burns, in these cases we are using Palmer method or rule of palm. So you can see here, rule of palm means under palm and extended fingers, how much area is there? 1%. So it is 1% of body surface area of patient. So patient's hand area under palm and extended fingers, it is 1% of body surface area of that patient. Clear? So this is used for estimation of splash burns and mixed distribution of burns. So it is used for estimation of, this is used for estimation of splash burns, or the patients who are having mixed distribution of burns. Patients who are having mixed distribution of burns. Clear? So patients who are having mixed distribution of burns. Clear? How we calculate it? So we put the hand of patient on a piece of paper, we cut the piece of paper accordingly, and with that piece of paper we are going to calculate the burn surface area. Now how to take care of burn wound? One of the method is cool the burn wound. What's the advantage? Cooling of burn wound, it is going to provide the analgesia, and second, it slows the delayed microvascular damage. It provides analgesia and it slows the delayed microvascular damage. So what are the important points related to cooling of the burn wound? Cooling should occur for a minimum of 10 minutes. So cooling, it should occur for minimum of 10 minutes. For minimum of 10 minutes. Clear? And the cooling is effective up to 1 hour after burns. So it is effective up to 1 hour after burns. 1 hour after burns. After burns. Clear? Next, what is the best temperature of water used for cooling of burn wound? The best temperature is 15 degrees centigrade. The best temperature is 15 degrees centigrade. If it's not available, even we can use the tap water. Tap water can also be used for cooling of burn wound. But we should not use ice or cold water. Why ice or cold water should not be used for cooling of burn wound? Because it increases the risk of hypothermia first. Second, it increases the risk of cutaneous vasoconstriction. And whenever there is cutaneous vasoconstriction, what will happen? It is going to increase the extent of thermal damage. Cutaneous vasoconstriction, it is going to increase the extent of thermal damage. That's why ice or cold water, it should not be used for cooling of the burn wound. Next important point, in the management of burns, we have to use topical antimicrobials or systemic. So obviously it's the topical antimicrobials which are preferred over systemic because these are having lesser side effects. To topical antimicrobials, these are preferred. These are preferred over systemic antimicrobials or systemic agents. Clear? So topical antimicrobials are preferred over systemic agents. What are the topical antimicrobials used? It is 1% silver sulfadiazine, silver nitrate percentage 0.5%, third is 5% mafenide acetate, and fourth, combination of silver sulfadiazine and cerium nitrate. Clear? Out of these, which one is most commonly used? The most commonly used agent is silver sulfadiazine. 1% silver sulfadiazine, this is most commonly used, and it is going to provide broad spectrum antimicrobial prophylaxis against Pseudomonas and MRSA. So it is going to provide broad spectrum antimicrobial prophylaxis. It is going to provide broad spectrum antimicrobial prophylaxis against Pseudomonas and MRSA. Against Pseudomonas and MRSA. Methicillin resistant Staph aureus MRSA. Clear? So you have to remember the percentage. It is 1% silver sulfadiazine, 0.5% silver nitrate, 5% mafenide acetate, and combination of silver sulfadiazine and cerium nitrate. Which one is most commonly used? It is silver sulfadiazine 1%. See these instruments. These instruments are used for harvesting the skin graft. Can you tell me what's the name? The first one, it's Humvee knife. Name of the instrument. This is Humvee knife. Clear? One of the frequently asked image-based question. It's the Humvee knife used for harvesting the skin graft. And second, you can see, this is the electric dermatome. You can see here. What's the name? This is electric dermatome. So name, this is electric dermatome. Clear? Humvee knife, and the second is electric dermatome. So these are the instruments which are used for harvesting the skin graft. Clear? What are the types of skin graft? It is split thickness skin grafting and full thickness skin grafting. See the difference? So in this image, you can see if we are going to take epidermis plus part of dermis. If we take epidermis plus part of the dermis, this is known as split thickness skin grafting. What's the name? The other name, STSG. It is split thickness skin grafting. This is also known as Thiersch skin grafting. Thiersch skin grafting. And whenever you take epidermis plus full thickness of dermis, this is known as FTSG. FTSG means full thickness skin grafting. And what is the other name? This is also known as Wolff's. What's the name? This is also known as Wolff's skin grafting. Clear? So split thickness skin grafting is Thiersch, full thickness skin grafting is Wolff's. See the difference. So first of all, split thickness skin grafting, which is also known as Thiersch. Here we are going to take epidermis plus part of dermis. Now see the comparison. In split thickness skin grafting, we take epidermis plus part of dermis, and in full thickness skin grafting, we are taking epidermis plus full thickness of dermis. So here we take epidermis plus full thickness of dermis. Clear? In split thickness skin grafting, large graft can be taken, but here in full thickness skin grafting only small graft can be taken. Only we are going to take small graft. Why? Because in full thickness skin grafting, if you are going to harvest some graft, there is permanent defect at the donor site. And if there is permanent defect at the donor site, that should be closed with the sutures, or it should be left as such for healing by secondary intention. It means the donor site will develop permanent defect. That's why in full thickness skin grafting only small graft is taken, and since donor site develops permanent defect, repeated grafts cannot be taken. But what happens? In split thickness skin grafting, the graft survival is easy because it's thin. Graft survival is easy, but in full thickness skin grafting, since the graft is thick, the graft survival is difficult. Donor site heals spontaneously in split thickness skin grafting. Donor site develops permanent defect. Here, donor site develops permanent defect. And since donor site develops permanent defect here, repeated grafts cannot be taken. So repeated grafts cannot be taken. Clear? So repeated grafts cannot be taken in full thickness skin grafting. Okay? Now, there is significant secondary contraction. What is primary contraction? What is secondary contraction? Whenever you are going to harvest the graft and the graft is going to coil, there is elastic recoil because of thickness of dermis. This is primary contraction. So, in full thickness skin grafting, what? There is significant primary contraction. What is this primary contraction? The primary contraction is elastic recoil because of dermis. So, there is significant primary contraction. Significant primary contraction, but there is lesser secondary contraction. What is secondary contraction? Contraction after maturation. Contraction after maturation. So there is lesser secondary contraction. Clear? And if there is lesser secondary contraction, so what happens? There is better cosmetic appearance in full thickness skin graft. So there is better cosmetic appearance. Better cosmetic appearance. Because on maturation, it is not going to shrink significantly. So there is better cosmetic appearance. But what is the problem which you have to remember? In split thickness skin grafting, there is significant secondary contraction. And because of that, there is poor cosmetic appearance. Because of that, there is poor cosmetic appearance. Poor cosmetic appearance. Clear? So this you have to remember. And how to remember? S is more common in S. S means secondary contraction. It is more common in S. S means STSG. So S is more common in S means secondary contraction is more common in STSG, split thickness skin grafting. Can you tell me what is the most common donor site for split thickness skin grafting? And the most common donor site, that's the inner aspect of thigh. What is the most common donor site? It is inner aspect of thigh. This is another question which is asked frequently. It's the inner aspect of thigh. Inner aspect of thigh. That's the most common donor site for split thickness skin grafting. Presence of which organism is an absolute contraindication for skin grafting? Presence of beta hemolytic streptococci. So presence of beta hemolytic streptococci, it's an absolute contraindication for skin grafting. Why? Because beta hemolytic streptococci, it is going to produce hyaluronidase and it is going to destroy the split thickness skin grafting. So presence of beta hemolytic streptococci, it's an absolute contraindication for skin grafting. What is flap? It is partially or completely isolated segment of tissue with its own blood supply. What is the other name of flap? It is pedicle graft. So what are the areas where we are going to use the flap? Imagine there is exposed bone. Imagine what happens because of musculoskeletal injury. There is exposed bone, exposed joint. So bone and joint, these are relatively avascular recipient beds. So whenever the recipient bed is relatively avascular or hypovascular, in those cases, we are going to use the flap. Now see what are the absolute indications for flap. So we discussed exposed bone, exposed brain and radiated vessel. Why radiated vessel? Whenever we are giving radiotherapy, what's the problem? In the vessels, there is obliterative end arteritis. So whenever there is obliterative end arteritis after radiotherapy, what happens? The recipient bed becomes relatively hypovascular or relatively avascular. Another is pressure sore. So you know that the patients who are immobilized for long duration, they are going to develop the pressure sore. So pressure sore at bony prominences, obviously we have to cover it with flap. Or if there is open joints, or if we have to use non-biologic implant material, so to cover these implants, we have to use the flap. On the basis of vascular supply, there are 3 types of flap. See the types. So these are the types of flap based on vascular supply. You can see the first is random flap, second is axial flap, and the third is free flap. So random, axial and free flap. What is random flap? The term is self-explanatory. It is based on some random vessel or subdermal plexus of vessel. So if you see this flap here, you can see that it is based on this random vessel or subdermal plexus of vessel. So random flap, it is based on subdermal plexus of vessel, which is not having any name. So it is based on subdermal plexus of vessel. Clear? And what is the use of this random flap? It is used to cover small full thickness defect. Used to cover small full thickness defect. Second is axial flap. You can see axial flap is based on a named vessel. So whenever any flap is based on a named vessel, if it's based on a named vessel, that is axial flap. In the breast chapter, we discussed tram flap, transversus rectus abdominis muscle flap. So you know that is based on inferior epigastric artery. It's an axial flap. We discussed LD flap, latissimus dorsi flap, that is based on thoracodorsal vessels. So again, it's axial flap, right? Now imagine there is axial flap. What we are going to do, it is devascularized from donor site, and if it is revascularized at recipient bed. So what is the problem here? There is autogenous transplant of vascularized tissue. What is the meaning? You can see here, this is devascularized. You can see here, it is devascularized from donor site, and you can see it is revascularized at recipient bed. How we are going to revascularize it? You can see here, via this microvascular anastomosis. So via this microvascular anastomosis, we are going to revascularize. This is free flap. So what is this actually? Actually, this is autogenous transplant. This is autogenous transplant. Autogenous transplant. Clear? It is a type of axial flap. So what is done here? The flap is devascularized from donor site and it is revascularized at recipient bed. Now see this flap. This is one of the most commonly asked question related to flap. What is the name of this flap? This is PMMC flap. Name is PMMC flap. What is the full form of this PMMC flap? This is pectoralis major myocutaneous flap. Pectoralis major myocutaneous flap. In this case, you can see it is based on which vessel? So this is frequently asked question. In this image, you can see it is based on pectoral branches of thoracoacromial artery or thoracoacromial vessel. So it is based on pectoral branches of thoracoacromial artery. Clear? So this is the thoracoacromial artery and this is the PMMC flap. Clear? What is the use of this PMMC flap? It is used for reconstruction of head and neck defects. So this is most commonly used flap for reconstruction of head and neck defects. Imagine this patient. This patient was having carcinoma oral cavity involving the cheek. After that, what was done? After that, wide local excision was done. And after wide local excision, how this reconstruction was done? You can see here, this reconstruction was done with the help of this flap. So the reconstruction was done with the help of this flap. So this muscle was used here for reconstruction, and this is what? Pectoralis major myocutaneous flap. So important questions related to pectoralis major myocutaneous flap. First, that this is the most commonly used flap for reconstruction of head and neck defects. First question, this is most commonly used flap for reconstruction of head and neck defects. For reconstruction, so reconstruction of head and neck defects. Clear? Head and neck defects. And the second question which is asked, they ask that it is based on which artery? Pectoral branches of thoracoacromial artery. So it is based on pectoral branches of thoracoacromial artery. Clear? So this is pectoral branches of thoracoacromial artery. Thoracoacromial artery. Clear? These are the questions which are asked. Thoracoacromial artery. You can see this flap. What is the name? This is deltopectoral flap. Can you see here? This is deltoid. So this is deltopectoral flap. So this is DP flap, also known as deltopectoral flap, and it is based on perforators of internal mammary artery. First question, deltopectoral flap. It is based on perforators of internal mammary artery. So this is based on perforators. Clear? So it is based on perforators of internal mammary artery. Now tell me, what is the use of this DP flap? Again, it is used for reconstruction of head and neck defects. So DP flap, it is also used, you can see here, it is used for reconstruction of head and neck defects. So DP flap is also used. It is used for reconstruction of head and neck defects. Reconstruction of head and neck defects. Clear? Used for reconstruction of head and neck defects. Clear? So these are the two commonly used flaps which are used for reconstruction of head and neck defects. What is ulcer? Ulcer is break in continuity of covering epithelium or mucous membrane. The questions which are asked in relation to ulcers are the parts of ulcer. So how to remember? What is the base? Base is the surface on which ulcer rests. So how to remember? Suppose your room is ulcer, right? You can see the floor. In the floor, what is there? There is tile, and these tiles are fixed to the concrete. So what is the base? Base is the concrete. How to remember? The base is the concrete. On the concrete, tiles are being fixed or marble is being fixed. So that is known as floor. Floor means exposed surface of ulcer. The walls, the side walls, these are known as edge. And these side walls are going to touch the ceiling. And that point of touch where the side walls are touching the ceiling, that is known as margin. Right? Now see here, what is base? Base is the surface on which ulcer rests. So base is the surface. It is the surface on which ulcer rests. Surface on which ulcer rests. Clear? So surface on which ulcer rests, that's the base. Clear? After that, what is the floor? Floor is exposed surface of ulcer. So what will you see in the floor? If you have seen the ulcer, you will see slough, you will see pus, you can see granulation tissue. So what is floor? Floor is exposed surface. Floor, this is the exposed surface of ulcer. So this is exposed surface. So exposed surface of ulcer, that is floor. What is the margin? Margin is the junction of normal epithelium with ulcer. You can see here, this is the margin. So margin is the junction. Is the junction of normal epithelium and ulcer. So that's the junction of normal epithelium and ulcer. So junction of normal epithelium and ulcer, that is the margin. And what is edge? Edge is an area between floor and margin. You can see here, this is edge. So edge, what is this edge? Edge is an area. This is area between floor and margin. So it's area between floor and margin. Area between floor and margin. Floor and margin. Clear? So it is easy to remember. Again, I'm discussing what? The concrete is base. On concrete, marbles or tiles are fixed. That is floor. Edge is the side wall, and margin where the edge means the side walls are going to touch the ceiling. So these are the parts of ulcer. Most of the questions which are asked in exam, the questions are in relation to edges. So see the important points related to edges. Now see the first one. Here you can see what there is sloping edge, and this sloping edge, it is seen in varicose ulcer or venous stasis ulcer. So sloping edge, it is seen in venous ulcer. So these are varicose ulcer or venous stasis ulcer. So it is seen in venous ulcer. After that, you can see this is punched out edge. Punched out edge, it is the characteristic feature of ischemic ulcers or arterial ulcer. So punched out edge, it is characteristically seen in ischemic or arterial ulcer. Seen in ischemic or arterial ulcer. Ischemic or arterial ulcer. Clear? After that, you can see here what this kind of edge is there. What is this kind of edge? You can see there is undermined edge, and undermined edges are typically seen in tuberculosis. So undermined edge, this is the characteristic feature of tuberculosis. After that, you can see rolled out edges, and rolled out edges are characteristically seen in basal cell carcinoma. So rolled out edges, these are seen in basal cell carcinoma. After that, you can see everted edges. What is the meaning of everted edges? You can see here, there is growth towards the surface. So there is outward growth towards the surface, and it is typically seen in squamous cell carcinoma. So everted edges, these are typically seen in squamous cell carcinoma. Now see this ulcer, it is arising from, can you see, it is arising from burn scar. So whenever some ulcer is arising from long-standing burn scar or chronic benign ulcer, that is known as Marjolin's ulcer. So what is this Marjolin ulcer? Actually, Marjolin's ulcer is a low-grade squamous cell carcinoma. It's a type of low-grade squamous cell carcinoma, and it arises from long-standing scar, this is the frequently asked question, it arises from long-standing burn scar or chronic benign ulcer. Arises from long-standing burn scar, or chronic benign ulcer. Clear? Chronic benign ulcer. Now what is the problem in Marjolin's ulcer? Yes, mainly it arises from scar tissue. And if you see the scar, in scar, there is destruction of nerves, vessels and lymphatics. If nerves are destroyed, there are no nerves, it means it is painless. If vessels are also destroyed, obviously it is slow growing, it is hypovascular, relatively hypovascular or relatively avascular. So it is slow growing and it is radio resistant. And lymphatics are also destroyed, it means it is associated with lymph node metastasis or not associated with lymph node metastasis. It is not associated with lymph node metastasis. So see the characteristic features. Since in the scar tissue there is no nerves, so first it is painless. No nerves, nerves are destroyed, so it is painless. It is relatively avascular, that's why it is slow growing and radio resistant. So this is slow growing. It's slow growing and radio resistant. So this is slow growing and radio resistant. Clear? Since there are no lymphatics also, so obviously it is not associated with lymph node metastasis. So this is not associated with lymph node metastasis. Clear? These are the characteristic features. It's a low-grade squamous cell carcinoma. Obviously, how we are going to make the diagnosis? Investigation of choice for diagnosis is biopsy. And how we are going to treat it? You can see here. The treatment, obviously we go for wide local excision. And whenever you perform this wide local excision, obviously you have to cover this defect with the flap. So what's the management here? In the management, we go for wide local excision with flap closure. So what we do? We go for wide local excision with flap closure. Clear? So in Marjolin's ulcer, we go for wide local excision with flap closure. Now see the skin malignancies. Tell me, what is the most common skin malignancy? Obviously, it is the basal cell carcinoma. Most common skin malignancy, basal cell carcinoma, followed by squamous cell carcinoma, followed by malignant melanoma. And what is the most common skin malignancy in darkly pigmented races like Negroes? In Negroes or darkly pigmented races, the most common skin malignancy, that is squamous cell carcinoma. These are very important. One by one we are going to discuss. First of all, see the basal cell carcinoma. What are the names of basal cell carcinoma? It is also known as rodent ulcer. Why? Because it is locally invasive. It is going to destroy the surrounding tissue. Known as rodent ulcer. What is the other name? Tear cancer. So it arises from, the name is basal cell carcinoma. So it arises from basal layer of epidermis. First question, arises from basal cell carcinoma. So arises from basal layer of epidermis. It arises from basal layer. What is the most common site? You know, that is nose followed by inner canthus. So most common site of basal cell carcinoma, that's nose. It's the nose followed by inner canthus. Nose followed by inner canthus. Clear? This is one of the frequently asked image-based question. See the images. Now see the typical location of this tumor. You can see the typical location close to nose. So most common site is nose followed by inner canthus. And see the appearance. If you see this tumor is having pearly white nodules in the periphery. Can you see? These are the pearly white nodules in the periphery. Simultaneously, you can see that there are dilated vessels or telangiectatic vessels over the surface. And third, you can see the classical sign, there is central depression with umbilication. So here you can see there is central depression with umbilication. Clear? So there is pearly white nodules in the periphery, dilated vessels on the surface. These are telangiectatic vessels. And you can see classical sign, there is central depression with umbilication, right? So this is what? This is typical basal cell carcinoma. And you know what is the most common type of basal cell carcinoma? It's the nodular. So all these features are of nodular variety. So important questions related to this. This is nodular variety. This is the feature of nodular variety. So what is the most common type of basal cell carcinoma? Which variety is most common? Is the nodular variety. The nodular variety is the most common. And what you saw here, there is small pearly white nodules in the periphery, dilated vessels on the surface. And what is the classical sign? You can see here, there is central depression with umbilication. So the classical sign is central depression. Clear? There is central depression with umbilication. So there is central depression with umbilication. Clear? These are the image-based questions which are asked frequently. Here also, how you make the diagnosis. Investigation of choice for diagnosis is biopsy. Here also, how we are going to treat it. Wide local excision with 2 centimeter margin. So for most of the tumors, what is sufficient? We go for wide local excision with 2 centimeter margin. But imagine patient is having recurrent tumor, or patient is having large aggressive tumors involving vital areas or cosmetic areas. In these cases, we go for Mohs micrographic surgery. So whenever patient is having recurrent tumors or there are large aggressive tumors involving vital areas or cosmetic areas, here we are going for Mohs micrographic surgery. Mohs micrographic surgery. Mohs micrographic surgery. So if you see, the treatment protocol is same even in squamous cell carcinoma. For squamous cell carcinoma also, we go for what? Wide local excision. And if patient is having recurrent tumors, or if there are large aggressive tumors involving vital areas or cosmetic areas, we go for Mohs micrographic surgery. So treatment protocol of basal cell carcinoma as well as squamous cell carcinoma, it's quite similar. So we discussed the squamous cell carcinoma is the second most common type of skin malignancy and the most common skin malignancy in darkly pigmented races. It arises from which layer? Arises from prickle cell layer of epidermis. So it arises from prickle cell layer. Clear? Arises from prickle cell layer of epidermis. Arises from prickle cell layer of epidermis. Clear? What's the most common causative factor for squamous cell carcinoma? It's the sunlight. Most common causative factor, that's the sunlight. So can you tell me what are the most commonly involved areas in squamous cell carcinoma? If the causative factor is sunlight, so obviously the areas which are exposed to sunlight, like ears, like cheeks, lower lip and back of hand. So ears, cheeks, lower lip, back of hand, these are the parts exposed to sunlight and these are most commonly involved in squamous cell carcinoma. How squamous cell carcinoma presents in the form of ulcer? So what is the most common variety of squamous cell carcinoma? Obviously it's the ulcerative variety. Most common variety of squamous cell carcinoma, it is the ulcerative variety. Since it presents with ulcer, so it is ulcerative variety. Clear? On histopathological examination, since it is squamous cell carcinoma, what you are going to find? There is cell nest, epithelial pearl or keratin pearl. So what we are going to find? We are going to find cell nest, or there is epithelial pearl, also known as keratin pearl. Epithelial pearl or keratin pearl. Clear? See how it looks like. We discussed that the squamous cell carcinoma is having outward growth, means growth is towards the surface. And since the growth is towards the surface, it is having everted edges. So special feature, obviously it presents with ulcer. Squamous cell carcinoma, obviously it presents with ulcer. And what kind of edges? There are everted edges with indurated base. There is everted edges. So these patients are having everted edges and there is indurated base. So there is ulcer with everted edges and indurated base. Clear? Rest of the protocol is very similar to basal cell carcinoma. Here also investigation of choice for diagnosis is same, biopsy. Here also the treatment protocol is almost same. We go for wide local excision with 2 centimeter margin, and if patient is having recurrent tumors or aggressive tumors or tumors involving vital areas, cosmetic areas, in those cases we go for Mohs micrographic surgery. Malignant melanoma, you can see how it looks like. This is malignant melanoma. It is caused by malignant transformation of which melanocytes? Junctional melanocytes. So important question. It is caused by malignant transformation of junctional melanocytes. Malignant transformation of junctional melanocytes. You tell me, what do you understand by junctional melanocytes? So these melanocytes are located at dermoepidermal junction. Junctional melanocytes, these are located at dermoepidermal junction. Next, what is the most common site of malignant melanoma? Most common site. So most common site, it is different in males and females. Now see, what's the most common site in males? In males, it is back and trunk, and in females, it's lower extremity. So most common site in males, it's back and trunk. It's the back and trunk. and in females it's the lower extremity. So in females it's the lower extremity. Lower extremity. Clear? After that, this question was asked in one of the latest exam, that what are the markers which are positive for malignant melanoma? Vimentin is positive, S100 is positive, HMB45 is positive. So see the markers. So the markers are Wish. How to remember? It's Wish. So it's a Vishala tumor, means toxic tumor. It is having very poor prognosis. How to remember? The mnemonic is Wish, means poison. Clear? So Vimentin, S100, HMB45, these are positive. In that exam, the question was asked, it is negative for which one? So negative is cytokeratin 20, it's negative. Clear? So the markers which are present or markers which are positive, it is Vimentin, S100, HMB45, and you know that HMB45 is also positive where? It is also positive in angiomyolipoma of kidney. So it is also positive. HMB45 is positive for angiomyolipoma involving the kidney. See the types of malignant melanoma according to decrease in incidence or according to decreasing frequency. So what is the most common type? Superficial spreading. Most common type, it is superficial spreading. Second most common type, nodular. Third most common type, lentigo maligna. And which one is rare or least common? It is acral lentiginous. So most common, that is superficial spreading. Least common, that is acral lentiginous. See the important questions related to these types. So superficial spreading, that is the most common type. And what is the most common site? The most common site of superficial spreading malignant melanoma, it is torso. What is the most common site? It is torso. If you see the nodular is having vertical growth. Mainly the melanoma is having vertical growth. So this is the most malignant type, and the most common site is head and neck. Nodular, this is most malignant. This is most malignant type of malignant melanoma. So this is most malignant, and what is the most common site? Head and neck. Nodular, most common site, it is head and neck. This is head and neck. If you see lentigo maligna, this is least malignant. Usually it is seen in elderly, in the sun exposed areas. So what is the most common site? Face. This was asked in one of the latest exam. Lentigo maligna, important question. What? It is least malignant. Lentigo maligna, that is least malignant. Clear? It is seen in elderly. In which areas? It is seen in sun exposed areas. And what is the most common site? Most common site is face. Clear? So most common site is face. The question which was asked in exam, it was like this: a 60 years old male was having malignant melanoma and the site was face. Which type? So most probably it could be what? Lentigo maligna. Acral lentiginous, we discussed that it is least common and it is having worse prognosis. It is least common, having worse prognosis. Clear? What is the typical location? Here the most common site is sole, and where exactly? Under the great toenail. Acral lentiginous, what is the most common site? The most common site is sole. This is a question frequently asked. Sole, where exactly? Under the great toenail. Under great toenail. Great toenail. Clear? So under great toenail. These are the questions which are asked frequently. There are characteristic features. Malignant melanoma, it is characterized by ABCDE. What is the full form of ABCDE? ABCDE of malignant melanoma. A means asymmetry, B means border irregularity, C means color variation, D means change in diameter more than 6 mm, E means evolution in size, shape, color. First you see, it's normal. Here you can see it's a mole. If there is ordinary mole, it is symmetrical, borders are even, there is a single color, diameter less than 6 mm. So this is ordinary mole, right? Now see, in cases of malignant melanoma, you can see here, this is melanoma. So what? There is asymmetry, border irregularity, multiple colors you can see here, color variation, change in diameter, how much? More than 6 mm. And there is change in size, shape, color. So that is evolution, evolving size, shape, color. What happens in malignant melanoma? The most common route of spread, it is lymphatic, and the most common site of metastasis, it is liver. What is the big problem? That at one point of time, multiple organs are affected in metastasis. So important point, if you see, what is the most common route of spread in malignant melanoma? The most common route of spread, again it's a question, it is lymphatic spread. So what kind of spread is there? There is lymphatic spread. Clear? There is lymphatic spread. And what is the most common site of metastasis? It is liver. So most common site of metastasis in malignant melanoma, it is liver. Liver. How we are going to make the diagnosis? See, suppose patient is having a small lesion. This is the lesion. If there is a small lesion, in this case, what kind of biopsy we go for? We go for full thickness excisional biopsy. And if patient is having large lesion, imagine this is the lesion. If patient is having large lesion, in this case, what we go for? We go for incisional biopsy. Clear? So if small lesion is there, we go for full thickness excisional biopsy, and large lesion is there. In that case, we go for incisional biopsy. The treatment protocol is very similar to other skin malignancies. Here also we go for wide local excision and we take how much margin? Usually 2 centimeter margin. But see, the margin depends on the tumor thickness and depth of invasion. So if you see the management protocol, it is very similar. We go for what? Wide local excision with 2 centimeter margin, and we also do sentinel lymph node biopsy. So it is wide local excision with 2 centimeter margin usually, with sentinel lymph node biopsy, but margin mainly depends on the tumor thickness and depth of invasion. There are Clark levels in malignant melanoma. Clark levels, it is based on depth of invasion. In malignant melanoma, the Clark levels, it is based on depth of invasion. It is based on depth of invasion. Clear? It is further divided into 5 types. So what is type 1? Whenever there is involvement of or invasion of epidermis. Type 2, whenever there is invasion of papillary dermis. Type 3, in type 3, involvement or invasion of junction between papillary dermis and reticular dermis. So that is known as interface. So whenever there is invasion of interface of papillary dermis and reticular dermis. In type 4, there is invasion of reticular dermis, and whenever subcutaneous tissues are invaded or affected, that is type 5. So how to remember? It's very, very easy. Here you can see the mnemonic is appears. How to remember? The mnemonic is appears, and this is 1, 2, 3, 4, 5. E means epidermis, type 1. P means papillary dermis, type 2. I means interface between papillary dermis and reticular dermis, type 3. R means reticular dermis, type 4. And S means whenever there is involvement of subcutaneous tissue. This is Clark levels. Right? There is another staging for malignant melanoma, that is Breslow staging. What is Breslow staging? It is based on actual measurement of deepest invasion from granular layer. It is based on actual measurement of deepest invasion from granular layer. If we compare Breslow staging and Clark levels, you tell me which one is preferred. Breslow staging is preferred over Clark levels. See the Breslow staging. So according to Breslow staging, what is stage 1? Whenever the depth of invasion is less than 0.75 mm. Depth of invasion, it is less than 0.75 mm. What is stage 2? Whenever the depth of invasion is 0.75 mm to 1.5 mm. What is stage 3? It is depth of invasion 1.6 mm to 4 mm. And whenever the depth of invasion is more than 4 mm, this is stage 4. So this is Breslow staging. Both of these are asked in exam. Clark's level as well as Breslow staging. And which one is preferred? Breslow staging. Clear? Now, question. Prognostic factors. So can you tell me what is the most important prognostic factor in malignant melanoma? Obviously, it's the depth of invasion. Most important prognostic factor in malignant melanoma. It is the depth of invasion. This is the question. So it's the depth of invasion. Clear? Depth of invasion. That's the most important prognostic factor. This is the most important prognostic factor. So most important prognostic factor in malignant melanoma is the depth of invasion. See this image, you can see here, there is firm, round, flesh-colored nodule which is having black-colored punctum. Firm, round, flesh-colored nodule with black-colored punctum. Can you see this? Black-colored punctum. So what is the name? This is actually sebaceous cyst. What are the other names of sebaceous cyst? It is also known as epidermal cyst, also known as epidermoid cyst. So this is also known as epidermal cyst, also known as epidermoid cyst. So epidermal cyst or epidermoid cyst. Clear? Epidermal or epidermoid cyst. Clear? One of the typical feature in this image, you can see one of the typical feature is what? This black colored punctum. So one of the typical feature is punctum in sebaceous cyst. But what are the exceptions where punctum is not seen? In the scalp and in the scrotum. You can see in the scrotum, these are the sebaceous cysts in the scrotum. In the scrotum, and here you can see in the scalp, there are no punctum. So no punctum in scrotum and scalp. No punctum in the scrotum and scalp. How we are going to treat it? If you see the cyst is having wall inside. Clear? It is actually a type of retention cyst. So what happens? Inside the cyst, there is cheesy or creamy material. Whenever we are going to perform the excision, so we have to perform the excision along with the cyst wall. So what is the treatment here? Treatment of sebaceous cyst. What's the treatment? We go for excision along with cyst wall. So we do excision. Excision is done along with cyst wall. Excision along with cyst wall. Along with cyst wall. In this image, you can see this swelling. This is actually painless and soft swelling. This swelling is painless and soft. So it is painless, soft, smooth swelling. What is the location? It is in relation to outer angle of eye, beneath or in close proximity to eyebrow. This is known as angular dermoid. It is located near outer angle of eye, in close proximity to eyebrow. It is painless, soft and smooth. This swelling is, it's painless, it is soft and smooth. What is the name? This is angular dermoid. Angular dermoid. Sometimes it is in relation to frontozygomatic suture. This is also a question. It is in relation to which suture? It is in relation to frontozygomatic suture. Frontozygomatic suture. Clear? This is in relation to frontozygomatic suture. And the question which is asked in exam, the question is that what is the treatment of angular dermoid? The treatment is surgical excision. So in angular dermoid, what is the treatment? We go for surgical excision. Surgical excision. And in the exam, usually they ask this image only. Now see the vascular anomalies of skin. First you see this one. It is looking like strawberry. That's why what's the name? This is strawberry angioma. What is this strawberry angioma actually? It is capillary hemangioma. So strawberry angioma, it is actually capillary hemangioma. This is capillary hemangioma. Here, the child is normal at birth, means there is no hemangioma, strawberry angioma at birth. But what happens? It is going to appear at 1 to 3 weeks. So at what age it is going to appear? It appears at 1 to 3 weeks of age. The child is normal at birth, appears at 1 to 3 weeks of birth. Clear? And what happens here? It is going to grow along with child till 1 year. What is the good thing? That complete involution occurs by 9 years of age. So in strawberry angioma, there is growth along with the child. So strawberry angioma, it grows along with child till 1 year of age. Grows along with child. So it grows along with child till 1 year. Till 1 year. Clear? And the good thing, there is complete involution by 9 years of age. In what percentage? 90% patients. So in 90% patients, complete involution by 9 years. There is complete involution by 9 years of age. Clear? There is one sign which is positive. If you press it and you release the pressure, there is emptying sign. So which sign is positive in strawberry angioma? Emptying sign. This is known as emptying sign. So emptying sign is positive. It's the emptying sign. Clear? So important point, child is normal at birth. It appears after 1 to 3 weeks. Emptying sign is positive. There is complete involution in 90% of patients by 9 years of age. Next is Salmon's patch. What are the other names of Salmon's patch? It is also known as macular stain, also known as stork bite. You can see here. See the location. So it is also known as macular stain. Also known as macular stain. This is also known as stork bite. Stork bite. Clear? It is present at birth. So it is present at birth. And if you see the typical location, it is in midline from forehead till occiput. Here you can see what is the location. Here you can see the location in the forehead. So location, forehead to occiput. It is located in midline, especially from forehead till occiput. And here also what's a good thing? That it disappears by 1 year of age. So even Salmon's patch is a patch, disappears by 1 year of age. So it disappears at 1 year of age. Clear? at 1 year of age. Now here you can see it is port wine stain, and you know that the stain is going to persist. It doesn't disappear. So can you see this is the distribution of which particular nerve? It's the distribution of fifth cranial nerve, that is trigeminal nerve. So here what are the important points? That port wine stain, it's a stain, so it doesn't disappear. It present at birth and it is going to grow along with the child. So it grows along with child. Grows along with child. Clear? It grows along with child. And what is the typical distribution? You can see it is in distribution of trigeminal nerve. So where exactly it is located? In the face, in the distribution of fifth cranial nerve or trigeminal nerve. An important point that it is going to persist. It persists. Clear? So P port wine stain, P persist. P port wine stain, P persist, and you know that stain is going to persist. So important questions. Out of these, which two are present at birth? Port wine stain and Salmon's patch. Which two are going to disappear? Strawberry angioma and Salmon's patch. P port wine stain, P is going to persist, and you know that stain is going to persist. See the one-liner questions which are asked in exam. Here you can see that there is infected sebaceous cyst of scalp. This is infected sebaceous cyst of scalp. And what is the name of this tumor? This is known as Cox peculiar tumor. So what's the name? It is known as Cox peculiar tumor. This is Cox peculiar tumor. And what is this Cox peculiar tumor? This is infected sebaceous cyst of scalp. One of the frequently asked question. So this is infected sebaceous cyst of scalp. This is infected sebaceous cyst of scalp. Clear? So this is infected sebaceous cyst of scalp. See this image. Here you can see that there is osteomyelitis of skull bone, and in the image you can see which bone? This is frontal bone. So osteomyelitis of skull bone, frontal bone, this is known as Potts-Puffy tumor. So this is another important question. Here there is osteomyelitis of skull bone. Osteomyelitis of skull bone, and most commonly involved bone, frontal bone. Which bone? Is the frontal bone. What's the name? This is known as Potts-Puffy tumor. So it is osteomyelitis of skull bone. Which bone? Frontal bone, that is Potts-Puffy tumor. You can see this one. This is actually benign hair follicle derived tumor. Can you see here? This is benign hair follicle derived tumor. Clear? What is the name? It is pilomatrixoma. What is the other name? This is also known as calcifying epithelioma of Malherbe. So what is this actually? This is benign hair follicle derived tumor. So this is benign hair follicle derived tumor. Clear? So it's benign hair follicle derived tumor. Benign hair follicle derived tumor. That is pilomatrixoma. And what is the other name? This is calcifying epithelioma of Malherbe. In this case, you can see that there is piling of tissues one over another. So in this image, you can see piling of tissues one over another. It is looking like turban. That's why what's the name? Turban tumor. So cylindroma, other name is turban tumor. And what happens in cylindroma? In cylindroma, there is piling of tissues one over another. Clear? So these are one-liner questions which are asked. Most commonly, they are asking what? Cox peculiar tumor, Potts-Puffy tumor. So this is all about burns and plastic surgery. Now we are going to start wound healing, tissue repair and scar. First, what is the definition of wound? It is breach in continuity of skin or surface epithelium. Most important topic is classification of surgical wound. So we are going to discuss the classification of surgical wound. Surgical wound is classified into 4 classes. What is class 1? Class 1 is clean wound. Class 2, clean contaminated. Class 3 is contaminated, and class 4 is dirty. First, see the class 1, also known as clean wound. It's easy to remember. In clean wound, there is no infection, no inflammation. Just remember, clean wound, there is no infection, no inflammation. So this is uninfected operative wounds without any inflammation. No infection, no inflammation. Second important point here, respiratory tract, gastrointestinal tract or genitourinary tract, that is not entered. So no infection, uninfected, no inflammation, so without inflammation. Respiratory tract, gastrointestinal tract and genitourinary tract, this is not entered. This is not entered. Clear? And generally these wounds are closed primarily. Sometimes we are going to insert the drain, and if we are inserting the drain, what kind of drain is being inserted? Mostly it's a closed drain. What are the classical examples of clean wound? These are some of the commonly performed surgeries in your elective OT, like inguinal hernia surgery, mastectomy, thyroidectomy. Can you tell me what kind of drain is inserted in mastectomy or thyroidectomy? Here we are going to insert the closed drain, and that is Romovac drain. What's the name of that drain being inserted? This is Romovac drain. So this is closed drain which is being inserted. Joint replacement, or if we perform abdominal aortic aneurysm repair. So examples: inguinal hernia repair, mastectomy, thyroidectomy, joint replacement, abdominal aortic aneurysm repair. Now see the class 2 wound, that is clean contaminated wound. We discussed that in class 1, respiratory tract, gastrointestinal tract and genitourinary tract, that is not entered. But in class 2, respiratory tract, GIT and GUT, it is entered under controlled condition. Important point. Respiratory tract, GIT and GUT, this is entered under controlled condition. So here respiratory tract, GIT and GUT is entered without unusual contamination. Clear? These questions are frequently asked. So what are the examples of clean contaminated wound? Examples are cholecystectomy, we perform CBD exploration, elective GI surgery. Classical example, whenever we are going for elective colonic resection or elective gastrectomy. Suppose you are planning elective colonic resection, in those cases we give bowel preparation. So whenever you give bowel preparation, obviously GIT is entered here. GIT is entered, but there is no unusual contamination. So elective GI surgery like elective colonic resection. Example, elective colonic resection. Elective colonic resection. Since you are going for bowel preparation, so that's why there is no unusual contamination. And elective gastrectomy. Elective gastrectomy. Clear? Elective gastrectomy. Clear? So these are the surgeries which are examples of, these are the examples of clean contaminated wound, that is class 2. After that, see class 3, that is contaminated wound. So class 3, this is contaminated wound. Class 3 is contaminated. Okay, how to remember this class 3? It is contaminated wound. Here accidents are included. Because of accident, what will happen? It is contaminated with soil and major break in sterile technique during elective surgery. If there is major break in sterile technique, that is included in class 3 or contaminated wound. So what we are going to include here? We are going to include open fresh accidental wounds, and you know that in open fresh accidental wounds, what happens? It is going to be contaminated with soil. So it is contaminated with soil. Second, if we are performing the surgeries or operations in which there is major break in sterile technique or there is gross spillage from GIT. Imagine patient is a case of intestinal obstruction, and what you did, you perform iatrogenic perforation. So if iatrogenic perforation is done, what will happen? Obviously there is contamination with fecal matter. Got it? So here what happens? There is gross spillage from GIT. Here there is inflammation, but what kind of inflammation? It is non-purulent. Whenever it becomes purulent inflammation, it is class 4, that is dirty wound. So this is class 3, contaminated wound. Here there is acute non-purulent inflammation. Now see the examples. So in examples, you are going to notice that we are going to include perforations, or we are going to include what? Contamination. So first see appendicular perforation, or imagine there is gastric perforation, appendicular perforation, gastric perforation, and if you are going to perform enterotomy, that is iatrogenic perforation or enterotomy during bowel obstruction, obviously what will happen? There is gross spillage from GIT. Even human bite, that is also contaminated wound. Open fracture, what is the problem with open fracture? If it's open, obviously there is contamination with soil. And in one of the latest exam, this question was asked that this open cardiac massage, what? Open cardiac massage, it is a type of class 3 or contaminated wound. So this was the question in one of the latest exam, that open cardiac massage is class 3 or it's a type of contaminated wound. Class 4 or dirty wound, how to remember? Here infection is already present, or organism causing infection is already present in the wound, or patient is having purulent inflammation. It means here there is presence of frank pus. So either there is presence of organism or frank pus, so that's why it's dirty. So here what is included? It is going to include old traumatic wound with retained devitalized tissue, or if there is wound with clinical infection, means organism is already there, wound with clinical infection, or there is perforated viscera with high degree of contamination. This one is associated with severe inflammation. Clear? So what kind of inflammation? This is purulent inflammation. We discussed that if it is acute non-purulent inflammation, it is contaminated, and if it is purulent inflammation or already there is presence of organism, it is class 4, that's dirty wound. Now see the examples: perforated diverticulitis, fecal peritonitis whenever there is contamination with fecal matter, presence of frank pus. So we discussed that if there is presence of frank pus, obviously it is dirty wound, or patient is having necrotizing soft tissue infection. So what kind of questions are being asked related to classification of surgical wound? They give you the examples, and after that they ask what is this kind of wound. Clear? It is class 1, class 2, class 3, class 4, clean, clean contaminated, contaminated or dirty. Now see the class of wound, risk of infection, and whether in that class antibiotic prophylaxis is required or not. First, how much is the risk of infection in clean wound? In clean wound, the risk of infection is only 5%. Risk of infection is 5%. How much is the risk of infection in clean contaminated wound? Just double. How much? It is 10%. In clean contaminated wound, it is 10%. In contaminated wound, it is 20 to 30%. In dirty wound, it is 30 to 40%. 30 to 40%. Clear? So how to remember? It is 5, 10, 20, 40. Just keep doubling it. 5, 10, 20, 40. This is class 1. This is class 2. This is class 3. This is class 4. So this is class 1, 5%. Class 2, 10%, class 3, 20%, class 4, 40%. So class 1 is 5, class 2, 10, class 3, 20 to 30, class 4, 30 to 40. Clear? Next, antibiotic prophylaxis is required or not? You know that whenever we are taking any patient for surgery, if we have to go for antibiotic prophylaxis, IV antibiotics are given. And what is the best time to give IV antibiotic or antibiotic prophylaxis? It is at the time of induction or 1 hour before surgery. At the time of induction or 1 hour before surgery. So antibiotic prophylaxis, it is given at the time of induction. It is given at the time of induction or 1 hour prior to surgery. Now see, in clean wound, antibiotic prophylaxis, it is not required. So usually antibiotic prophylaxis, usually it is not required. In clean wound, it is not required. Usually. In clean contaminated wound, it is required. Usually required. Clean contaminated wound, it is usually required. And in contaminated wound, it's almost always required. So in contaminated wound, it's required. In contaminated wound, it is required. Clean contaminated, usually required. In contaminated wound, almost always required. And if it's dirty wound, here, antibiotic prophylaxis is not required here. Treatment is required. So it's treatment which is required in dirty wound. In dirty wound, it's the treatment which is required. So treatment is required, not the prophylaxis. Got it? So here treatment is required, not the prophylaxis. Now one of the best method to avoid the surgical site infection, one of the best method, it is what? Frequent hand washing. So frequent hand washing decreases the risk of surgical site infection. What is the definition of chronic wound? The wound that does not heal within 3 months. You have to remember 3 months. So wound that does not heal within 3 months. This duration you have to remember. Wound that does not heal within 3 months. And you know, delay in healing can occur in any phase of wound healing. What are the phases of wound healing? There is inflammatory phase, there is proliferative phase, there is remodeling phase. But delay in healing mainly occurs in inflammatory phase. So in chronic wound, delay can occur in any phase, but here delay mainly occurs in inflammatory phase. It mainly occurs in inflammatory phase. Clear? Inflammatory phase. Okay. Now you tell me one example of chronic wound. When the duration is more than 3 months, it is not going to heal within 3 months. So you have seen many cases of paraplegia or quadriplegia. These patients are immobilized in one particular position or one particular posture. And what happens? These patients are prone to develop pressure sore or pressure ulcer. So that is the classical example of chronic wound. What's the example? It includes pressure ulcer or pressure sore. Classical example, pressure ulcer or pressure sore. Clear? So pressure ulcer or pressure sore. So what you have to remember, chronic wound does not heal within 3 months and delay mainly occurs in which phase? In inflammatory phase. Now see this image. Here you can see that skin and subcutaneous fat. This is skin plus subcutaneous fat. So skin and subcutaneous fat, it is stripped by avulsion. What? It is stripped. Can you see here? It is stripped by avulsion from underlying fascia. That's why what's the name? This is also known as degloving injury, also known as avulsion injury. So what happens here? Here, the skin and subcutaneous fat, it is stripped. In this case, skin plus subcutaneous fat, it is stripped. This is stripped by avulsion from underlying fascia. And that's why after this avulsion, what happens? What you can see, that neuromuscular structures are exposed. Here you can see that the neuromuscular structures are exposed. In this image, you can see these are the neuromuscular structures. So neuromuscular structures are exposed. Clear? What you can see the bone which is exposed. You can see some tendons which are exposed. Clear? So after avulsion injury, the neuromuscular structures are exposed. So you can see bone and tendon which is exposed. This is avulsion injury. What is the other name? Degloving injury. This definition was asked in one of the latest exam. What is compartment syndrome? Pressure in any compartment whenever it is going to increase. If it is more than 30 mmHg, what happens? There is impaired perfusion, and because of that, what will happen? There is ischemia, and because of that, there is pain. So this is compartment syndrome. What is the problem here? There is increased pressure in the compartment. So what happens? If there is increased pressure in the compartment, there is increased pressure in the compartment, you have to remember how much? Whenever the pressure is more than 30 mmHg. Increased pressure in the compartment, it is going to cause impaired perfusion. So what is the problem here? There is impaired perfusion, and obviously after impaired perfusion, what will happen? There will be ischemia, and whenever there is ischemia, there is pain. So it leads to ischemia, and because of this ischemia, there is pain. This is pain. So this is the basic pathophysiology of compartment syndrome. What happens here? Typically, it is going to occur in closed lower limb injuries. It is seen in, typically it is seen in, or most commonly it is seen in closed lower limb injuries. So whenever there is closed lower limb injuries, what happens? There is collection of blood in one particular compartment, and because of that, there is increased pressure in the compartment. How much is the pressure? More than 30 mmHg. So here you are going to notice the signs and symptoms of ischemia, means pain. So what are the problems? Patient will be having severe pain, and it is out of proportion to apparent injury. Second problem, that these patients are having pain on passive movement or pain on stretching of affected compartment muscle. Here, pulselessness in compartment syndrome, pulselessness or absent of distal pulses, it's a late sign. And worse prognosis if patient is having paralysis. So paralysis is associated with worse prognosis. So in compartment syndrome, there is severe pain, and this severe pain is out of proportion to apparent injury. Patient is having pain on passive movement or pain on passive stretching of affected compartment muscle. Pain on passive stretching. And let me tell you, whenever this question is asked in exam, they give you closed lower limb injury, and then they give you that there is pain on passive stretching or passive movement of affected compartment muscle. Distal sensory disturbances are there. Which one is late sign? Absence of distal pulses, that is also known as pulselessness. So what? Pulselessness, it's a late sign. This question was asked in one of the latest exam. So pulselessness in compartment syndrome, it's a question, it's a late sign. It's the late sign. And paralysis, it is associated with worse prognosis. In patients of compartment syndrome, paralysis, it is associated with worse prognosis. Obviously, the name is compartment syndrome. So how we are going to make the diagnosis? We have to insert the catheter with pressure monitor, and we have to measure the compartment pressure. In compartment syndrome, how much should be the pressure? Here we discussed the pressure should be more than 30 mmHg. So in compartment syndrome, the pressure of the affected compartment should be more than 30 mmHg. Now coming to the treatment. Treatment is fasciotomy. But fasciotomy is not done in all patients. What are the indications for fasciotomy? In the management, what we are going to perform? In the management, we are going to perform fasciotomy. It's the fasciotomy which is done. But fasciotomy is not done in all patients. What are the indications of fasciotomy? First, either pressure is more than 30 mmHg. So if the compartment pressure is more than 30 mmHg, or patients are having signs and symptoms of compartment syndrome. If the patient is having signs and symptoms of compartment syndrome. How we do the fasciotomy? In this image, you can see we are giving two longitudinal incisions, one on the medial side. So two longitudinal incisions are given. You can see one on the medial side and one on the lateral side. Fasciotomy. So two longitudinal incisions, one on the medial side, one on the lateral side. The name is fasciotomy. So you have to incise the structures till fascia. So what are the structures which are incised here? Skin, subcutaneous fat and fascia. So structures which are incised, in this case, the structures which are incised, skin, subcutaneous fat and fascia. Skin, subcutaneous fat and fascia. These are the structures which are incised in fasciotomy. So this is fasciotomy and these are the structures which are incised. Clear? Clear? Whenever you are going to perform the fasciotomy, you are going to see that muscle should be bulging through the fascia. So in this image you can see here that the muscle is bulging through the fascia. So this is fasciotomy which is done for compartment syndrome patients. It's very easy to remember the stages of pressure ulcer. What is the stage 1? In stage 1, there is non-blanchable erythema of skin without any breach in epidermis. So whenever there is non-blanchable erythema of skin without any breach in epidermis, that is stage 1. What happens in stage 2? There is partial thickness loss. So there is partial thickness skin loss involving epidermis and dermis. What's the problem in stage 2? There is partial thickness skin loss. Clear? So there is partial thickness skin loss involving epidermis and dermis. What happens in stage 3? There is full thickness skin loss involving epidermis, dermis and subcutaneous tissue. Full thickness skin loss involving epidermis, dermis and subcutaneous tissue. And whenever apart from skin there is involvement of underlying structures like muscle and bone, it is stage 4. So whenever there is involvement of epidermis, dermis, subcutaneous tissue plus muscle and bone, this is stage 4. So this is the staging of pressure ulcer. And let me tell you, it is very similar to the degree of burns. Degree of burns. You remember first degree? First degree is epidermal burn. So whenever only epidermis is involved, it is first degree. In second degree, there is involvement of what? In second degree, there is involvement of epidermis plus dermis. In third degree, there is involvement of epidermis plus dermis plus subcutaneous fat, and in fourth degree there is involvement of skin plus underlying structures like muscle, bone or brain. Got it? So it's very similar to that. One by one we are going to discuss. First see the stage 1. So here you can see stage 1. Here there is non-blanchable erythema of skin. In stage 1 there is non-blanchable erythema of skin without any breach in epidermis. So it is stage 1. Here you can see there is non-blanchable erythema of skin without any breach in epidermis. What is the other term for stage 1? It is also known as early superficial ulcer. So what is the other name for stage 1? This is also known as early superficial ulcer. Clear? This is early superficial ulcer. Okay. After that, see the stage 2. In the stage 2, we discussed that there is partial thickness skin loss involving epidermis plus dermis. Clear? So there is partial thickness skin loss involving, you can see, epidermis plus dermis. Epidermis plus dermis. This is also known as, here you can see, partial thickness skin loss involving epidermis plus dermis. This is also known as late superficial ulcer. So what is the other name of stage 2? This is late superficial ulcer. Other name, it is late superficial ulcer. Here you can see stage 3. So there is involvement of what? There is involvement of epidermis, involvement of dermis, and you can see there is involvement of subcutaneous tissue. So whenever there is full thickness skin loss involving epidermis plus dermis plus subcutaneous tissue, this is stage 3. This is also known as early deep ulcer. So what is stage 3? Other name, this is early deep ulcer. You can see there is early deep ulcer. Clear? So there is involvement of epidermis plus dermis plus subcutaneous tissue. So this is early deep ulcer. You can see here, early deep ulcer. What happens in stage 4? In stage 4, there is full thickness skin loss. Apart from that, there is involvement of muscle and bone. So whenever there is involvement of underlying muscle and bone, this is stage 4. So any situation where you can see the muscle or bone, it is stage 4. And what is the other name? This is late deep ulcer. This is late deep ulcer. This is late deep ulcer. Now let me tell you the question which is asked. They give you the description of a quadriplegic or paraplegic patient who is immobilized for long duration and there is a pressure sore or ulcer at the sacrum. What you can see the exposed bone. So obviously what's the stage? It is stage 4. So most frequently the question which is asked in exam, in those cases the stage is 4 because you can see the underlying muscle or underlying bone. Now see, the pressure sore, it is preventable. Clear? So it is easy to prevent, it is difficult to treat. So how we can prevent? Any patient who is having quadriplegia, paraplegia, or any patient who is immobilized for long duration, in such patients we are going to use the special pressure dispersion cushions, or we have to use special pressure dispersion foams. What you can use? Water mattress. So you can use low air loss and air fluidized beds. Clear? Suppose patient is bed bound. Bed bound means immobilized in the bed, or patient is wheelchair bound. What are the specific instructions which are given to the patient as well as relative? Suppose the patient is bed bound. So we tell the relatives to turn the patient every 2 hourly. You have to remember, turn the patient every 2 hourly. If patient is bed bound, turn the patient. You have to remember, turn the patient every 2 hourly. Clear? So turn the patient every 2 hourly. Every 2 hourly. If patient is wheelchair bound, we ask the patient to lift off from the wheelchair. So patient has to lift off from the wheelchair for 10 seconds every 10 minutes. So what? Patient has to lift off. So lift off from the chair, lift off from the chair for 10 seconds every 10 minutes. Clear? So lift off from the chair for 10 seconds every 10 minutes. Every 10 minutes. Clear? Suppose we are going for surgical treatment. So at the site of that pressure sore or ulcer, we have to cover it with the help of a flap. Now what is the most commonly used flap for pressure sore? Since there is a defect, so we have to cover that defect. So we have to use extensor fascia lata flap with lateral cutaneous nerve of thigh. So most commonly used flap for pressure sore, this is extensor fascia lata flap. This is frequently asked question. Extensor fascia lata flap with lateral cutaneous nerve of thigh. Lateral cutaneous nerve of thigh. Clear? So extensor fascia lata flap with lateral cutaneous nerve of thigh. This is the most commonly used flap used for pressure sore. See this image here, you can notice that a seal dressing is being applied here. There is a seal dressing which is applied. Clear? Seal dressing is applied and here we are going to create the vacuum. So seal dressing is applied here and we are going to create the vacuum. Clear? Vacuum is created here. A vacuum is applied. So what is the name? This is known as vacuum assisted closure. Since we are using vacuum, that's why it is also known as negative pressure wound therapy. So question, why it is known as negative pressure wound therapy? Because we are applying vacuum or negative pressure. So question, how much negative pressure is being applied here? We are going to apply minus 125 mmHg of pressure. So how much negative pressure is being applied? It's a question. It's minus 125 mmHg. Negative pressure which is applied, that is minus 125 mmHg, and this pressure is applied 2 to 3 times per week. So it is applied 2 to 3 times per week. 2 to 3 times per week. Clear? It can be applied continuously or it can be applied intermittently. So what is the advantage of negative pressure wound therapy? That it is going to promote the wound healing. How it is going to promote the wound healing? First, it is going to draw excess fluid which is collected there. So it is going to draw out the fluid from the wound, and second, it increases the blood flow to the area. So because there is increased blood flow to the area, that's why there is faster healing. The questions which are asked, that is, what are the primary effects of negative pressure wound therapy? First, it is going to cause macro deformation. What is macro deformation? See, if you apply vacuum or negative pressure, it is going to draw the wound edges together. And if it is going to draw the wound edges together, what will happen? It helps in wound edge approximation. So macro deformation, what it is going to do? It helps in wound edge approximation. So wound edges approximation. It helps in wound edges approximation. Second, it is going to stabilize the wound environment. How it is going to stabilize the wound environment? First, it is going to provide warm and moist environment, and it is going to protect the wound from external organisms. Clear? So what happens? There is stabilization of wound environment because we discussed that. We apply a seal dressing. So there is warm and moist environment and it is going to protect the wound from outside microorganisms. Third is it is going to reduce edema. How? Because it is going to suck the excess fluid collected in the wound. And the fourth is micro deformation. What is that micro deformation? It is going to promote the cellular proliferation on wound surface. So what's the effect? It is going to promotes cellular proliferation. It promotes cellular proliferation on the wound surface. Cellular proliferation on the wound surface. Clear? So these are the primary effects of negative pressure wound therapy. But problem, what? Everywhere you cannot use negative pressure wound therapy. There are certain contraindications. So what are the contraindications of negative pressure wound therapy? First, if there is malignancy in the wound. Second, if patient is suffering from untreated osteomyelitis. Third, patient is having fistula. What kind of? Non-enteric and undrained fistula. And fourth, if there is presence of necrotic tissue with eschar. So how to remember? The mnemonic is Munna. You must be knowing Munna of Mirzapur. Clear? So Munna, M, that is malignancy in the wound. U, untreated osteomyelitis. N, non-enteric and undrained fistula. And N, necrotic tissue with eschar. These are the contraindications of negative pressure wound therapy. This is one of the frequently asked questions. And what they ask actually this image-based question. And there are questions related with negative pressure wound therapy. Now see the important questions related to scar formation. It's the maturation phase of wound healing which leads to formation of scar. So maturation phase of wound healing leads to formation of scar. Question is asked that how much is the maximum tensile strength of scar? So the maximum tensile strength of scar achieved, it is approximately 80% of uninjured skin. So what's the maximum tensile strength of scar? Maximum tensile strength. The maximum tensile strength of scar, it is, which is achieved, it is up to 80% of uninjured skin. Clear? And the second question which is asked frequently, that this maximum tensile strength of scar, it is achieved in how much duration? So it is achieved in 12 weeks or 3 months. So maximum tensile strength of scar is achieved in 12 weeks. It is achieved in 12 weeks or 3 months. So I'm repeating the questions. First question which is asked, that the maximum tensile strength of scar is how much? It's 80% of uninjured skin and it is achieved in 12 weeks or 3 months. So what are the types of scar? It can be atrophic scar, it can be hypertrophic scar, it can be keloid. Two questions which are asked frequently, mostly in the form of image-based question. What's the difference between hypertrophic scar and keloid? See these two images. What is the similarity? In these two images, you can see that there is presence of excessive scar tissue. In the first one, this excessive scar tissue, it doesn't extend beyond the boundary of original wound or incision. But here you can see, here the excessive scar tissue, it is going to extend beyond the boundary of original wound or incision. So obviously, this is what? This is hypertrophic scar. And what's the name? This is keloid. Hypertrophic scar and keloid. See, one difference which is already visible in the images. Obviously, keloid is seen in which races? So you can see it is more common in darkly pigmented races. Keloid, it is more common in, important point, it is more common in darkly pigmented races. You can see the color of skin. Darkly pigmented races. The third question which is asked, that what is the most common site of keloid? Can you see? The most common site is sternum. And actually speaking, it is seen in one triangular area. What's that triangular area? Can you see? It is seen in this triangular region which is bounded by shoulder tip and xiphisternum. So it is seen in this triangular region which is bounded by shoulder tips and xiphisternum. Overall, the most common site is sternum. So we are going to discuss the differences between hypertrophic scar and keloid. This is one of the frequently asked questions. So we discussed that in hypertrophic scar, there is excessive scar tissue. In keloid also there is excessive scar tissue. But in hypertrophic scar, it doesn't extend beyond the original wound or incision, but in keloid, it is going to extend beyond the original wound or incision. So in keloid also, there is presence of excessive scar tissue, but it extends. But this excessive scar tissue, it extends beyond original wound or incision. Extends beyond original wound or incision. It extends beyond original wound or incision. Beyond original wound or incision. Clear? Now, what is the cause of hypertrophic scar? It results from prolonged inflammatory phase and sometimes because of unfavorable scar siting. What do you mean by unfavorable scar siting? If you give incision against the tension lines. Clear? So it is because of prolonged inflammatory phase or unfavorable scar siting. What is the problem with keloid? In keloid, there is increased level of growth factors, and we discussed that this is associated with darkly pigmented skin or darkly pigmented races, and there is genetic predisposition also. Now see the histology. In hypertrophic scar, there is increased collagen and hypervascularity. Even in keloid, there is increased collagen. In keloid also, there is increased collagen and there is hypervascularity. So there is hypervascularity and there is increased collagen. But if you see hypertrophic scar here, there is well organized type 3 collagen. Well organized type 3 collagen. But what's the problem in keloid? There is disorganized type 1 and type 3 collagen. So here in keloid, there is disorganized. There is disorganized type 1 and type 3 collagen. Disorganized type 1 and type 3 collagen. Clear? So there is disorganized type 3, type 1 and type 3 collagen. If you see hypertrophic scar, it is going to improve spontaneously over the period of time. But what's the big problem with keloid? That it rarely regresses with time. Hypertrophic scar, it is going to improve with time, but keloid, it rarely regresses with time. And second problem with keloid, that it is often refractory to medical and surgical intervention. Now see how we are going to manage hypertrophic scar and keloid. Now see the treatment of hypertrophic scar. Suppose there is ongoing hypertrophy in the scar. So in the scar, we are going to inject intralesional triamcinolone. So it is intralesional injection of steroid. Which agent? Triamcinolone. So whenever in hypertrophic scar, there is ongoing hypertrophy. In hypertrophic scar, if there is ongoing hypertrophy, there is ongoing hypertrophy in the scar. If there is ongoing hypertrophy in the scar, so obviously we go for intralesional injection of steroids, and obviously which agent? We give triamcinolone. Clear? Suppose scar is going to persist after 1 year. If it is going to persist after 1 year, in those cases we go for surgical excision, and after that we go for primary closure. So if scar persists after 1 year, it persists after 1 year. Clear? So in that case, we go for surgical excision with primary closure. So it is surgical excision plus primary closure. It is surgical excision plus primary closure if the patient is having hypertrophic scar. Now see the management of keloid. We discussed that keloid, it is refractory to medical and surgical treatment. So by the way, what is the first line treatment in keloid? What is the first line treatment? The first line treatment in the keloid, it is silicone sheet plus intralesional injection of triamcinolone. So it's pressure therapy actually. It is use of silicone sheet, that is pressure therapy, silicone sheet plus intralesional injection of triamcinolone, intralesional injection of steroids, that is triamcinolone. Clear? And imagine if there is refractory keloid which is not responding to this treatment option. In those cases, we have to go for surgical excision and we give post-operative radiotherapy. So if it's refractory, patient is having refractory keloid. Clear? In refractory keloid, we go for surgical excision and after that we go for post-operative radiotherapy. So this is surgical excision plus post-operative radiotherapy. So post-op radiotherapy, what kind of radiotherapy is given? We can go for external beam radiotherapy, EBRT, or we can give brachytherapy. So external beam radiotherapy or brachytherapy. Clear? And we discussed that what is the most common site of keloid? It is sternum, and we discussed that mainly it is seen in the triangular region bounded by shoulder tip and xiphisternum. So these are the differences between hypertrophic scar and keloid. This is one of the frequently asked questions, and this is all about wound healing, tissue repair and scar. Now we are going to start arterial disorders, and first of all we are going to discuss the peripheral arterial occlusion. Peripheral arterial occlusion, it is characterized by 5 P's. What are those 5 P's? It is characterized by 5 P's. Out of these 5 P's, which one is most common? The most common is pain. So most common symptom of peripheral arterial occlusion, that is pain. Second is pallor. There is paresthesia, pulselessness and paralysis. So you can see it is associated with these 5 P's. In latest exam, the questions were asked that out of these 5 P's, which one is associated with worse prognosis, especially in the patients of compartment syndrome. So in patients of compartment syndrome, it's the paralysis which is associated with worse prognosis, which is associated with worse prognosis. And there was another question that in patients of compartment syndrome, which one is the late sign? In patients of compartment syndrome, which one is the late sign? So pulselessness, it's a late sign. Pulselessness, this is late sign. In patients of compartment syndrome, pulselessness, it's a late sign, and worse prognosis, paralysis is associated with worse prognosis. What is the problem in patients of peripheral arterial occlusion? Distal to occlusion, there is ischemia of muscles, and because of ischemia of muscles, what will happen? Because of ischemia of muscles, these patients will be having pain that is known as intermittent claudication. It's very easy to understand. You can see here, this is the aorta. Clear? So this is aorta, this is aortic bifurcation, right? So you can see here, this is internal iliac and this one is external iliac. Internal iliac and this one is external iliac. Now imagine the patient is having occlusion where aorto-iliac bifurcation. So if the patient is having occlusion here at aorto-iliac bifurcation, so the patients who are having aorto-iliac disease or the patients who are having aorto-iliac bifurcation obstruction, in those cases what will happen? Patient will be having claudication where? In the buttock. So these patients will be having claudication in the buttock. These patients will be having claudication in the thigh as well as in the calf. Clear? So if aorto-iliac bifurcation occlusion is there, here the patient will be having intermittent claudication in buttock, thigh and calf. This is also known as aorto-iliac disease. So you can see here in patients of aorto-iliac disease, what's the problem? The patients who are having aorto-iliac disease. This is one of the frequently asked questions. The patients who are having aorto-iliac disease, in these patients there is intermittent claudication. Intermittent claudication involving buttock, involving thigh, involving calf. So buttock, thigh, calf. Apart from that, if obstruction is at aorto-iliac bifurcation, obviously what will happen? The patient will be having erectile dysfunction. So impotence or erectile dysfunction, and this is known as what? Lehret's syndrome. So aorto-iliac disease or obstruction at aorto-iliac bifurcation, this leads to Lehret's syndrome. This is frequently asked. You have to remember this is Lehret's syndrome. So what is this Lehret's syndrome? This is erectile dysfunction because of occlusion at aorto-iliac bifurcation. So Lehret's syndrome, this is erectile dysfunction. This is impotence or erectile dysfunction. There is erectile dysfunction. Clear? Second, now imagine patient is having occlusion in common femoral. If occlusion is there in the common femoral artery, because of this patient will be having claudication where? In the thigh as well as in calf. So if occlusion is in common femoral, these patients will be having intermittent claudication in thigh as well as in calf. Third, imagine patient is having occlusion in the superficial femoral, occlusion in superficial femoral or popliteal or in the crural artery. Superficial femoral, popliteal or crural artery. So if occlusion is there in these vessels, obviously these patients are having intermittent claudication in calf muscle. So on the basis of location of intermittent claudication, you can easily assess that what is the location of peripheral arterial occlusion. So because of peripheral arterial occlusion, distal to occlusion, there is the ischemia of muscles which leads to intermittent claudication. Another important question, you tell me, what is the most common cause of peripheral arterial occlusion? So let me tell you, in this chapter, arterial disorders, most common cause of most of conditions related to arterial disorders, it is atherosclerosis. So first, what is the most common cause of peripheral arterial occlusion, atherosclerosis, most common degenerative disorder of vessel, atherosclerosis, most common cause of subclavian artery stenosis, atherosclerosis, and most common cause of extracranial aneurysm, atherosclerosis. So in majority of cases, you are going to notice that the most common cause is atherosclerosis. So for peripheral arterial occlusion also, the most common cause is atherosclerosis. One. Second, if patient is young male smoker means age less than 40. So young male smokers, here the cause is Burgess disease. So next condition is Burgess disease. What is the other name of Burgess disease? This is thromboangiitis obliterans. What is the problem here? This is segmental inflammatory disease. This is segmental inflammatory disease. And in this segmental inflammatory disease, there is involvement of which vessels? Here, there is involvement of medium and small sized vessels. So segmental inflammatory disease, important question. It is going to involve medium and small sized vessels. Medium and small sized vessels. Small sized vessels. Small sized vessels. How to differentiate it from atherosclerosis? In patients of atherosclerosis, there is involvement of large vessels mainly. Mainly there is involvement of large vessels. Here there is involvement of medium and small size vessels. So how to remember? What are those vessels which are involved? The mnemonic is TPR. The vessels which are involved, it is TPR. So full form, it is tibial, plantar and radial. So vessels involved, this is TPR, that is tibial. It is tibial, plantar, radial. Tibial, plantar, radial. We discussed that it is exclusively seen in young male smokers aged less than 40 years. Clear? Here, this is inflammatory disorder. So initially there is involvement of artery, but later there is involvement of vein as well as nerve. So ultimately there is involvement of all three structures. Ultimately, so there is involvement of artery plus vein plus nerve. So two important points which you have to remember related to Burgess disease. First, that what is the progression of disease? It progresses from distal to proximal direction. So what is the progression? Progression is from distal to proximal, and in this condition the patients are having skip lesions. So patients are having skip lesions and disease is going to progress from distal to proximal direction. Clear? Second, it is characterized by a triad, and how to remember? Mnemonic is RIM. The triad of Burgess disease, how to remember? It is RIM. So R, Raynaud's phenomena, patients are having intermittent claudication and patients are having migratory superficial thrombophlebitis. Raynaud's phenomena, intermittent claudication, migratory superficial thrombophlebitis, right? There is one question which is asked frequently in relation to intermittent claudication, and that's what? Grading of intermittent claudication, and it is known as what? Boyd's classification. The grading of intermittent claudication, and that's Boyd's classification. See the Boyd's classification? So according to Boyd's classification, that is the grading of intermittent claudication. What is grade 1? Here, pain appears at the beginning of walk or at the start of walk. But if patient continues to walk, pain disappears. Why? Because whatever the substance P which was collected because of ischemia, it is washed away. So what is grade 1? Pain appears at the beginning of walk. So pain appears at the beginning of walk, but disappears if patient continues to walk. Disappears if patient continues to walk. Disappears if patient continues to walk. Clear? After that, what is grade 2? Here, patient can walk with pain. So in this case, grade 2, patient can walk with pain. This patient can walk with pain. What happens in grade 3? This was asked in one of the latest exams. Here, pain compels the patient to take rest. So patient is going to walk for some duration, for some time, for some distance, then take rest, and then again walk for the distance and take rest. So here, pain compels the patient to take rest. Pain compels the patient to take rest. And what happens in grade 4? Obviously, these patients are having rest pain. So grade 4 here, rest pain. Next, Burgess disease is an inflammatory disorder of arteries mainly. So obviously, what is the investigation of choice for diagnosis? It is angiography. Here there is involvement of tibial, plantar, radial. Tibial, plantar and radial. It means upper limb as well as lower limb vessels both are involved. That's why what is the investigation of choice? Obviously, how to make the diagnosis? Here, investigation of choice for diagnosis. Investigation of choice for diagnosis, that is 4-limb angiography. It is forelimb angiography. We go for forelimb angiography. So it is angiography. Which one? Is the forelimb angiography. And there is one question which is asked. On forelimb angiography, there is typical collaterals which are seen. This is known as corkscrew collaterals. So on angiography, in patients of Burgess disease, what kind of collaterals are seen? These are corkscrew collaterals. So name of these collaterals? These are corkscrew collaterals. These are corkscrew collaterals. Another question which is asked frequently, that is ABPI or ABI. ABPI means ankle brachial pressure index. So what is this? It is the ratio of systolic blood pressure at ankle and second in the brachial artery, in the arm. So it is the ratio of systolic blood pressure at the ankle and in the arm, in the brachial artery. Obviously, it should be more than 1 usually, or at least 1. Why? Because of effect of gravity at ankle joint, the systolic blood pressure should be a bit more in comparison to systolic blood pressure in the brachial artery. But if it is less than 1, it is abnormal. Imagine the ankle brachial pressure index is 0.1 to 0.4. What does it mean? It means that patient is having critical limb ischemia. So if ankle brachial pressure index, it is 0.1 to 0.4, this is critical limb ischemia. This is critical. This is frequently asked question. Critical limb ischemia. And how examiners are going to ask this question? They give you this value. What? The ankle brachial pressure index less than 0.5. So they give you this value. Ankle brachial pressure index less than 0.5. So obviously it is 0.1 to 0.4. 0.5 to 0.9, it is suggestive of what? Intermittent claudication. So if it is 0.5 to 0.9, clear? It is suggestive of intermittent claudication. This is another question which is asked. Right? Which is normal if it is 1 to 1.2. So this is normal if it is 1 to 1.2. More than 1.2, again it's abnormal. It is suggestive of calcified vessels. So in which cases calcified vessels are seen? If value is more than 1.2, this was asked in the latest exam. What? It is suggestive of calcified vessels. Calcified vessels. So what are the conditions which leads to calcified vessels? One, obviously what? Diabetes mellitus. Diabetes mellitus. And the second is end stage renal disease. And you know, one of the most common cause of end stage renal disease, it is diabetes mellitus. So this is ankle brachial pressure index. Now see the treatment. First, most important aspect, abstinence from smoking, because it is going to delay the progression of disease. Second, we can give vasodilators, and vasodilators are given for symptomatic improvement. What are the vasodilators we give? One is xanthinol nicotinate and the second is pentoxifylline. The vasodilators are one, xanthinol nicotinate, and the second is pentoxifylline. It is pentoxifylline, right? What is the problem? Actually, the improvement is not too much because of these drugs. So there is only borderline improvement with the help of these vasodilators. Third option we have, that is lumbar sympathectomy. In which cases it is highly effective. Lumbar sympathectomy, it is not for intermittent claudication. You have to remember, lumbar sympathectomy is not done for intermittent claudication. It is done for the patients who are having rest pain. So lumbar sympathectomy, it is done for rest pain. Another option which we have, that is omental transposition. And if patient is having gangrene, the patients who are having gangrene, in those cases we go for amputation. For gangrene, we go for amputation. Now see one of the famous question. This question was asked many times in exam. See, there are two scenarios. First, a young male smoker. The patient is young male smoker, age less than 40 years. Patient, young male smoker, age less than 40 years. And patient, male smoker, age 60 to 70 years. Male smoker, age 60 to 70 years. In both of these cases, there is gangrene of one of the toe. If there is gangrene of one of the toe, tell me what is the most common cause. So obviously, if the age is less than 40 years, here it's Burgess disease. You have to remember, because atherosclerosis, it is seen in 6th to 7th decade. So this is Burgess disease. But if the age is 60 to 70 years, obviously what is the most common cause of peripheral arterial occlusion? This you have to remember, atherosclerosis. So whenever such questions are asked in exam, see the age of patient, because smoking is risk factor for both Burgess as well as atherosclerosis. So age less than 40, Burgess; age 60 to 70, male smoker, it is atherosclerosis. Lumbar sympathectomy. So what is done? On the affected side, we have to remove L1 to L4 ganglia. So what? We are going to remove L1 to L4 ganglia on affected side in lumbar sympathectomy. But suppose we are planning for bilateral lumbar sympathectomy, in that case at least L1 should be preserved on one side. Why? To prevent retrograde ejaculation. So if bilateral lumbar sympathectomy is planned, so in bilateral lumbar sympathectomy at least L1 should be preserved on one side. This you have to remember. This was asked many times. At least L1 should be preserved on one side. Why at least L1 should be preserved on one side to prevent retrograde ejaculation. Clear? To prevent retrograde ejaculation. Second, whenever we are removing the L1 to L4 ganglia, there are certain structures which appear similar, and sometimes during surgery those structures are accidentally removed. So the structures which are mistaken for lumbar sympathetic ganglia accidentally removed, that is GPL. It is Gujarat Premier League. These are accidentally removed. During lumbar sympathectomy, the structures which are accidentally removed. This was asked, and how to remember? It is GPL, that is Gujarat Premier League. So G, which nerve? Genitofemoral nerve. P, psoas sheath, psoas minor, and lymphatics. Clear? Now coming to the indications of lumbar sympathectomy, we discussed that intermittent claudication, it is because of muscle ischemia. That is not an indication for lumbar sympathectomy. So see the indications. So how to remember the indication? The mnemonic is Bara-Scheff. You can see here. The mnemonic is Bara-Scheff. B, that is Burgess disease. A, atherosclerosis. R, Raynaud's disease. A, acrocyanosis. C, Cossälgia. H, hyperhidrosis. E, erythrocyanosis, and F, frostbite. In Burgess disease, we discussed what? In Burgess disease, what is an indication for lumbar sympathectomy? It's not the intermittent claudication, it is the rest pain. The indication is rest pain. AV fistula can be congenital or acquired. Which one is the most common? Most commonly, it is congenital. So most commonly, AV fistulas are congenital. What is the most common cause of acquired AV fistula? So the most common cause of acquired AV fistula, it is penetrating trauma. The most common cause of acquired AV fistula, that is penetrating trauma. You have to remember both. It is penetrating trauma. This is penetrating trauma. Sometimes we create fistula that is iatrogenic for hemodialysis. And what is the name? This is Braccia seminofistula. And this fistula is created between radial artery and cephalic vein. You have to remember the name. What's the name? It is Braccia seminofistula. The name of this fistula? That is Braccia seminofistula. This is iatrogenic fistula created for hemodialysis. So this fistula, it is created for hemodialysis, and this is fistula between which artery, which vein? It is the fistula created between radial artery and cephalic vein. So it is fistula created between radial artery and cephalic vein. Clear? Fistula created between radial artery and cephalic vein. It's very easy to understand. Whenever we create the fistula, what are the physiological changes? You can see here. Whenever you create the fistula, the arterial blood starts going into the vein. And when arterial blood starts going into the vein, what happens? There is increased venous return to the heart. And because of increased venous return to the heart, there is increased cardiac output, increased heart rate, increased systolic blood pressure. So first important point, because of AV fistula, obviously, there is increased venous return to heart. And because of increased venous return, there is increased cardiac output. These patients are having increased heart rate, and there is increased systolic blood pressure. In comparison to systolic blood pressure, the diastolic blood pressure is not going to rise that much. That's why these patients will be having wide pulse pressure. So second problem, the patients will be having wide pulse pressure. Wide pulse pressure. Clear? Wide pulse pressure. After creation of the fistula, you can see that at the site of fistula, there is pulsatile mass. If you place your hand, you can feel the thrill. There is palpable thrill. So what happens? What else? Here. So at the site of fistula, there is pulsatile mass. So patients will be having pulsatile mass, and there will be palpable thrill. Palpable thrill. Clear? Palpable thrill. Right? What happens in chronic cases? In chronic cases, because the blood is going into the vein with high pressure. So there are changes in the vein that is known as arterialization of vein. So vein becomes dilated, tortuous and thickened. So this dilated, tortuous and thickened vein, this change is known as arterialization of vein. What's the problem? There is arterialization. Clear? So there is arterialization of vein. So vein becomes dilated, tortuous and thickened. Imagine I'm going to occlude the artery proximal to fistula. Imagine I'm going to occlude the artery here. So I'm occluding the artery proximal to fistula. If you occlude the artery proximal to fistula, there is decrease in the size of pulsatile mass. Thrill will disappear, and what will happen? The heart rate will be decreased. Relatively, it will be decreased. So there is normalization of heart rate. What's the name of this sign? This is Nicola-Doni, also known as Branham sign. Frequently asked question. So what is Nicola-Doni or Branham sign? On occlusion of artery proximal to the fistula, pulsatile mass size decreases. Pulsatile mass size decreases. Thrill, palpable thrill disappears. Palpable thrill, it disappears. And obviously heart rate, relatively it is decreased or it's normalized. Relatively it is decreased or normalized. So this is known as Nicola-Doni, also known as Branham sign. You can see here there is fistula. Since there is fistula, can you tell me which investigation is both diagnostic and therapeutic? Obviously angiography. Why it is diagnostic and therapeutic? Because with the help of embolization you can occlude the fistula. So what's the diagnosis? How to make the diagnosis? Diagnosis, investigation of choice for diagnosis. Investigation of choice for diagnosis, that is angiography. And you know, angiography, it is both diagnostic and therapeutic. So angiography, it is both diagnostic and therapeutic. If small fistula is there, we can go for embolization. So how to manage? If the patient is having small fistula, we go for angiography. And apart from that, what we perform? Apart from that, we go for embolization. And the patients who are having large fistula, in cases of large fistula, we have to go for surgical ligation. So for large fistula, surgical ligation is done. The question which is asked frequently related to this, they ask you Nicola-Doni Branham sign. Thoracic outlet compression syndrome, actually it's a misnomer. In this image, you can see this is the inlet here. This area, this is actually inlet. This is thoracic inlet. Clear? And this one is outlet. So you can see here, there is inlet, there is outlet. Actually, obstruction is at the thoracic inlet. So actual term should be thoracic inlet compression syndrome. Now what you can see here in this image, you can see that these are nerves. Nerves of brachial plexus. And what else you can see? This is subclavian artery and vein. So subclavian vessels. Subclavian vessels. So what happens in patients of thoracic outlet compression syndrome? There is compression of nerves of brachial plexus and subclavian vessels. Clear? It is seen in middle-aged females. And there are two forms. It is seen in middle-aged females. What are the forms? If there is compression of the nerve and manifestations are there, that is neurogenic form. And if there is compression of vessel, that is vascular form. So what are the forms? It is of two types or two forms. First, there is neurogenic form. Neurogenic form, and the second is vascular form. It's the neurogenic form and vascular form. You tell me which one is most common. So it's the neurogenic form which is the most common type. So most common type, it is the neurogenic form. Here there is compression of nerves of brachial plexus. Which root value? It is C8T1. And if the root value is C8T1, you tell me which nerve is compressed. Ulnar nerve. So root value which is compressed here, it is C8T1. So obviously which nerve? It is ulnar nerve. So the nerve is ulnar nerve. So what will be the manifestation? If there is compression of ulnar nerve, obviously patient will be having pain and paresthesia along the inner aspect of forearm and hand. Apart from pain and paresthesia along the inner aspect of forearm and hand, there is atrophy of this hypothenar muscles and interossei. So neurogenic form most commonly involved root value C8T1, nerve it's ulnar. There is pain and paresthesia along the inner aspect of forearm and hand. So what happens here? There is compression of root value C8T1, nerve is ulnar. So there is pain and paresthesia along the inner aspect of forearm and hand, atrophy of this hypothenar muscle and interossei. Suppose there is compression of vessel, arterial, subclavian artery. If it is compressed, obviously patient will be having pain, pallor, paresthesia. if there is compression of vein, because of compression of vein, what happens? There is collection of deoxygenated blood, and because of that, patient will be having cyanosis, edema, and patient will be having pain. So neurogenic form, vascular form, which one is most common? Neurogenic, root value CA-T1, and the most commonly affected nerve, ulnar. Another important point, the compression in thoracic outlet compression syndrome, it is dynamic, it is not static. So in majority of cases, if it is dynamic obstruction, it means it is most marked in one particular portion. So if it is dynamic obstruction, the obstruction is most marked in one particular portion. In majority of cases, it's dynamic obstruction until and unless patient is having what? Some kind of anatomical abnormality like cervical rib, fibrous band, patient is having some Pancoast tumor over this area. Otherwise, in majority of cases, what happens? There is dynamic obstruction. So this obstruction is most marked in one particular posture. And that's why here the diagnosis is mainly done by provocative test. If patient is having anatomical abnormality, we can detect this condition radiologically. But if it's dynamic obstruction, so it is diagnosed by provocative test. First is Addison test. What is the other name of Addison test? It is also known as Scaleni test. Addison test. This is also known as Scaleni test. Scaleni test. Second is costoclavicular test. This is also known as military position or Halsted test. So costoclavicular test, also known as military position test or Halsted test. This is Halsted test. There is hyperabduction test, and what is the other name? It is also known as Wright test. Hyperabduction test, also known as Wright test, and Roos test. This is known as arm claudication test. There was one video based question related to this. Arm claudication test. It is arm claudication test. So this was a video based test. This is arm claudication test or Roos test. In this case, there is numbness and pain in hands with exercise. So there is numbness and pain in the hands with exercise. This is Roos test, also known as arm claudication test. This was asked in the latest exam in the form of video based question. Now, how to manage? Majority of cases are having neurogenic form and the obstruction is dynamic. That's why most patients are managed conservatively. Clear? So what's the management of thoracic outlet compression syndrome? Management: more than 90% patients are having neurogenic form. More than 90% patients are having neurogenic form, and these patients are managed conservatively. Neurogenic form, clear? And these patients are managed conservatively, so we go for conservative management. Clear? What are the indications of surgical intervention? First, imagine there is no improvement after conservative management. So there is failure of conservative management, or there is progression of sensory or motor symptoms. We are going to follow the conservative management, but there is progression of sensory or motor symptoms. It means what happens? There is significant nerve compression, or there is excessively prolonged ulnar or median nerve conduction velocity. Again, it's an indirect evidence of significant nerve compression. Suppose patient is having vascular forms. In vascular forms, obviously, we have to go for surgical intervention. Vascular form means if there is narrowing or occlusion of subclavian artery, or the patients who are having thrombosis of axillary or subclavian vein. So in these cases, these are vascular form, types of vascular form, and in these cases, we have to go for surgery. Or patient is having anatomical abnormality like cervical rib, fibrous band is there, we have to go for the excision of rib or fibrous band. And if there is Pancoast tumor, we have to go for excision of tumor. So these are the indications of surgical intervention in thoracic outlet compression syndrome. What is the most common cause of acute mesenteric ischemia? It is embolic occlusion. So embolic occlusion of superior mesenteric artery or inferior mesenteric artery, it can cause acute mesenteric ischemia. So this is the question. What is the most common cause? The most common cause of acute mesenteric ischemia, it's a question, it is embolic occlusion. What happens? There is embolic occlusion. Embolic occlusion. So one simple principle is there. If there is ischemia, obviously there is pain. So where is the pain? There is abdominal pain. And what kind of pain? Patients are having severe abdominal pain, and this abdominal pain, it is out of proportion to physical examination findings. So most common symptom it is severe abdominal pain, and this is out of proportion to physical examination findings. Apart from that, what happens? Patients are having persistent vomiting, there is diarrhea, there is hematochezia and melena. In what percentage of patients there is hematochezia and melena? So melena and hematochezia, it is seen in 15% patients. In 15% patients, there is hematochezia and melena. What is the problem in late stages? Initially, there is ischemia. If there is delayed presentation or late presentation, in that case, what will happen? There is gangrene, and because of that, there is sepsis. So in late stages, patient will be having hypovolemia and shock. So what is the problem? In late stages, patient is having sepsis, and because of sepsis, there is hypovolemia and shock. So in late stages, patient is having sepsis and shock. In this case, what happens? The most important aspect is early diagnosis and aggressive resuscitation. So sometimes we are going to perform the resuscitation inside the OT. How you are going to make the diagnosis? Since there is embolic occlusion in the superior mesenteric artery or inferior mesenteric artery, so obviously we are going for mesenteric arteriography. So how to make the diagnosis? In acute mesenteric ischemia, diagnosis, the investigation of choice for diagnosis, that is mesenteric arteriography. It is mesenteric arteriography. This you have to remember. Mesenteric ischemia because of artery, so arterial occlusion, so it is mesenteric arteriography. Mesenteric arteriography. So most important aspect is early diagnosis and aggressive resuscitation, and aggressive resuscitation is done inside OT. So it's the early diagnosis, aggressive resuscitation, and aggressive resuscitation is done inside OT. We give IV fluids. Since these patients are prone to sepsis, so we have to give IV antibiotics. So it is IV fluids and IV antibiotics. Clear? So IV fluids and IV antibiotics. Imagine a patient who is having late presentation, and what happens at the time of presentation, patient is having peritonitis. What is the cause of peritonitis? It can be because of gangrene of the bowel, or it can be because of perforation. So if there is peritonitis because of gangrenous bowel or perforation, in those cases we go for exploratory laparotomy and resection of necrotic bowel. So in which patients? The patients who are having peritonitis. The patients who are having peritonitis. Clear? So this is acute mesenteric ischemia. There is similar presentation in patients who are having mesenteric venous thrombosis. So imagine a patient is having mesenteric venous thrombosis. Patient is having mesenteric venous thrombosis. First question, in mesenteric venous thrombosis, obviously there is venous thrombosis. So which vein? There is venous thrombosis of superior mesenteric vein. Important point, inferior mesenteric vein is spared. So in mesenteric venous thrombosis, there is involvement of superior mesenteric vein. What? The inferior mesenteric vein, this is spared. So there is thrombosis of superior mesenteric vein, inferior mesenteric vein is spared. Here also, what is the most common symptom? In this case also, the most common symptom is same. What? Severe abdominal pain. So the most common symptom is same, that is severe abdominal pain. These patients are also having persistent vomiting, diarrhea, there is hematochezia or melena. Clear? And in late stages, obviously, there can be gangrene. Because of that, there can be sepsis and shock. Right? But here, how you are going to make the diagnosis? Since there is mesenteric venous thrombosis, so there is congestion in the mesentery. Here, investigation of choice for diagnosis, it is CCT. So you have to remember, in patients of mesenteric venous thrombosis, investigation of choice for diagnosis, it is CCT. Clear? The investigation of choice for diagnosis, it is CCT. Second, if there is venous thrombosis anywhere in the body, you have to stop the thrombotic process. And to stop the thrombotic process, what you have to start? Anticoagulants. So in the management of mesenteric venous thrombosis, what we have to start? We have to start anticoagulants. Here, we have to start anticoagulants. Clear? And imagine patient is having peritonitis. If the patient is having peritonitis, in that case, we have to perform exploratory laparotomy with resection of necrotic bowel. Got it? So this is acute mesenteric ischemia and mesenteric venous thrombosis. Now, subclavian artery stenosis. We discussed that in majority of arterial disorders, the most common cause is atherosclerosis. So here also, what is the most common cause? In subclavian artery stenosis, it is atherosclerosis. Here also, it is atherosclerosis. First question, the most common cause of subclavian artery stenosis, atherosclerosis. Now you can see here, where is the stenosis in this image? You can see this is the left subclavian artery, and here is the stenosis. Clear? So there is involvement of which artery? Left subclavian artery, and the most common site, Which part? First part. So most commonly involved vessel, it is the left subclavian artery. This is left subclavian artery, and the most common site, it is the first part. So this is first part of left subclavian artery. First part of left subclavian artery. Now see the problem. During rest there is no problem, but what happens during work or exercise? Imagine patient is doing work or exercise by this left upper limb. During work or exercise by left upper limb, there is increased demand of blood. So what should happen? There should be increased blood flow to supply this working or exercising arm. But what is the problem here? You can notice that since there is stenosis, because of this stenosis, the blood flow is not adequate, which is going to supply the working or exercising arm. So what is the problem in these patients? In these patients, there will be reversal of blood flow. So you can see here, this is vertebral artery. So in the vertebral artery, during work or exercise, what will happen? There is reversal of blood flow, and this reversal is why to supply the working arm or exercising arm. So whenever there is reversal of blood flow during work or exercise in ipsilateral vertebral artery to supply the working arm or exercising arm, what is the problem? There is ischemia of posterior circulation. Why? Because you know that left and right vertebral artery, it is going to form what? Basilar artery. So this is what? It is going to form basilar artery, and you know that this basilar artery, it is going to supply the posterior circulation, means it is going to supply the cerebellum and occipital cortex. So during work or exercise, these patients might develop transient vertebrobasilar ischemia. So what is the problem here? Blood is being stolen from posterior circulation of brain to supply or feed the working arm or exercising arm. That's why this is known as what? Subclavian steal syndrome. So another question which is asked, it is known as subclavian, what's the name? This is known as subclavian steal syndrome. What's the name? This is subclavian steal syndrome. So what happens in subclavian steal syndrome? During work or exercise, there is reversal of blood flow, and this question was asked in latest exam. Reversal of blood flow in ipsilateral vertebral artery. So in subclavian steal syndrome, there is reversal of blood flow. There is reversal of blood flow. Blood flow. Where exactly? You have to remember, in ipsilateral vertebral artery. Clear? So there is reversal of blood flow in ipsilateral vertebral artery, and because of that, what happens? Patients are having transient vertebrobasilar ischemia. So these patients are going to develop what? Transient vertebrobasilar ischemia. Got it? So two questions are related. First, subclavian artery stenosis, and the second, subclavian steal syndrome. Aneurysm is very important topic. Lots of one-liner questions are asked in relation to aneurysm. First question, what is the most common vessel involved in aneurysm? It is circle of Willis. So most common vessel involved in aneurysm, it is circle of Willis. This is circle of Willis. Clear? Second, what is the most common location of extracranial? Important point. The most common location of what? Extracranial aneurysm, and that is what? Aorta. In aorta, what is the most common location? Infrarenal aorta. So most common location of extracranial aneurysm, obviously it is aorta, it is infrarenal aorta, followed by which artery? Followed by iliac artery, followed by popliteal artery, followed by femoral artery, popliteal followed by femoral artery. Clear? So how to remember? It's very easy. Mnemonic is AIPF. The mnemonic is AIPF. So full form, it is All India Police Force. So now you will not forget. It is aorta, followed by iliac artery, followed by popliteal artery, followed by femoral artery. Clear? Now, the most common site of peripheral arterial aneurysm. So choose among aorta, iliac artery, popliteal and femoral. Peripheral. So it starts with P. P here also it's P, popliteal. P peripheral, P popliteal. So P peripheral, P popliteal. So most common site of peripheral arterial aneurysm, it is popliteal artery. Next, most common site of visceral arterial aneurysm, that is also known as splanchnic. Visceral arterial aneurysm, also known as splanchnic arterial aneurysm. S splanchnic, S splenic artery. So splanchnic arterial aneurysm or visceral arterial aneurysm, it is splenic artery. This is which one? This is splenic artery. Clear? Most common site of mycotic aneurysm. What happens? This is the vessel which is used by cardiologist, radiologist and sometimes by interns also. for taking blood sample. Which is the vessel? It is femoral artery. So what happens? Mycotic aneurysm, it is infectious aneurysm. Clear? And the most commonly involved vessel, this is femoral artery followed by aorta. So most common site of mycotic aneurysm, it is femoral. This is femoral artery followed by aorta. And imagine a question is asked that what is the most common organism responsible for mycotic aneurysm? Obviously, which organism you are going to introduce from the skin into aorta or into femoral artery? From the skin, obviously Staph aureus. So the most common organism responsible, it is Staph aureus. It is Staph followed by Salmonella. So Staph aureus followed by Salmonella. Clear? So most common organism, Staph aureus followed by Salmonella, and the vessel involved, it is femoral artery followed by aorta. Next, what is the most common cause of abdominal aortic aneurysm? Atherosclerosis. Now see the similarity. The most common site of abdominal aneurysm, it is infrarenal aorta, and the most common site of atherosclerosis, it is also infrarenal aorta. It means what? There must be some connection. What's the connection? That the most common cause of abdominal aortic aneurysm, this is atherosclerosis. What? This is atherosclerosis. It is atherosclerosis. Clear? Now see this aneurysm. You can see the typical location infrarenal aorta. In this aneurysm, this is the width or diameter of aneurysm. So what is this? This is width or diameter. It's the width or diameter. So question is asked, what is the most important predictor of rupture? Aortic aneurysm rupture, most important predictor, it is width and diameter. So what is the most common and most lethal complication of aortic aneurysm? It is rupture. So important questions which are asked frequently, that what is the most common and most lethal complication of aortic aneurysm? It is rupture. It is rupture. Clear? And the risk of rupture, it is directly proportional to width or diameter. So most important predictor for rupture, it is width or diameter. This is width or diameter. Width or diameter. Clear? Another question, you can see the relationship of aorta and vena cava. This is aorta. What is the relation of IVC? This is inferior vena cava. Right? So inferior vena cava is on the right side of aorta. So obviously this aneurysm is going to rupture on which side? The most common site of rupture. Obviously where? On the right side or left side. So free rupture occurs on the left side. It is intraperitoneal or retroperitoneal. So obviously it is the retroperitoneal. So what is the most common site of rupture? It is left retroperitoneal. This question was also asked. It is left retroperitoneal. So most common site of rupture, left retroperitoneal. And one question which is asked frequently, that how much is the mortality with ruptured aortic aneurysm? So aortic aneurysm rupture, how much is the mortality? It's very high, more than 50%. The mortality risk, how much is the mortality? It's very high, it is more than 50%. So mortality, it is more than 50%. Clear? So what you saw here, that the risk of rupture is directly proportional to width or diameter. That's why there are cutoff diameters for aortic aneurysms or types of aneurysms where the cutoff diameters are there. Before that diameter, we should perform the surgery. So what is cutoff diameter for surgery in cases of aneurysm? So this is one of the most famous questions which is asked almost every year. Cutoff diameters for surgery. In descending thoracic aorta, it should be more than equal to 6.5 centimeter. That's the maximum. Descending thoracic aorta more than equal to 6.5 centimeter. In patients of abdominal aorta and ascending aorta, it should be more than equal to 5.5 centimeter. And this is the question which is asked most frequently. In cases of abdominal aorta and ascending aorta, cutoff diameter, which is an indication for surgery, more than equal to 5.5 centimeter. In cases of iliac artery, it is more than equal to 3.5 centimeter. And in cases of femoral artery and popliteal artery, it is more than equal to 2 centimeter. Femoral and popliteal, it is more than equal to 2 centimeter. Clear? So these are frequently asked question. Which one is asked most frequently? In abdominal aorta and ascending aorta, how much is the cutoff diameter? More than equal to 5.5 centimeter. Another topic which is asked almost every year, that is vascular graft. So it is of two types, bioprosthetic and synthetic. In bioprosthetic, first autograft. Autograft means the patient's own tissues are used. It is autograft. Autograft, when the patient's own tissues are used. After that, homograft, which is also known as allograft. So homograft, homograft. It is also known as allograft. Homograft, allograft. Clear? So if you know the Punjabi, suppose mother gives her kidney to the son or daughter and mother says allograft. So it becomes allograft. Got it? So homograft or allograft, it means here the graft is being taken from same species. Here the graft is being taken from same species. Same species. Clear? So that is homograft or allograft. Second, if the graft is being taken from a different species, this is xenograft. What is the other name? It is also known as heterograft. So if it is being taken from different species, that is known as xenograft. This is known as xenograft. It is also known as heterograft. So xenograft, heterograft. You must be knowing another definition. What is isograft? Isograft, it means the graft is being taken from identical twins. Isograft, if it is taken from identical twins. Xenograft or heterograft, here the graft is taken from different species. The graft is being taken from different species. Clear? So it is being taken from different species. And next, it is tissue engineered, means prepared in laboratory. When the vascular graft is prepared in laboratory, this is tissue engineered. If it is prepared in laboratory, this is tissue engineered. Tissue engineered. Clear? Now coming to the synthetic graft, it is further divided into two types, textile and non-textile. First, see the textile graft. Textile graft. Synthetic graft. First, textile. In textile graft, we include Dacron. So textile graft, what's the graft? It is Dacron. And you know that Dacron is the most commonly used synthetic graft. After that, the non-textile grafts. So see the non-textile grafts. Non-textile. Okay. In non-textile grafts, we use first ePTFE. What's the name? It is E. E means expanded. PTFE means polytetrafluoroethylene. Expanded polytetrafluoroethylene. And the second is polyurethane. Expanded polytetrafluoroethylene and the second is polyurethane. Clear? So these are the grafts which are used. Okay. Bioprosthetic and synthetic. Now see the one-liner questions in relation to vascular graft. First, what is the best natural vascular graft? It is reverse Long-Saphenous vein. So best natural vascular graft, that is reversed Long-Saphenous vein. It is reversed Long-Saphenous vein. And we discussed what is the best synthetic vascular graft, that is Dacron. Best synthetic vascular graft, that is Dacron. Second, we have to go for suprainguinal bypass or infrainguinal bypass. Imagine we are going for infrainguinal bypass. So infrainguinal region, it contains medium and small size vessels. So what is the preferred graft here? Here the preferred graft is Long-Saphenous vein. And preferred graft for suprainguinal bypass, where there are large vessels like aorta, like iliac artery. So obviously we go for what? Dacron. So for infrainguinal bypass, it is Long-Saphenous vein. For suprainguinal bypass, we go for what? Dacron. It's Dacron. Now see this image. This is coronary artery bypass grafting. For CABG, what is the most preferred graft? Obviously, arterial grafts are preferred over venous graft. Why? Because arterial grafts are having longer patency rate. So arterial grafts are preferred. So most preferred, it is this one. It is what? It is Lima. So most preferred, it is this one. This is what? Left internal mammary artery. But what, there is only one left internal mammary artery. And usually when we perform CABG or we perform coronary artery bypass grafting, we are going to bypass more than two vessels. So what is most commonly used graft? The most commonly used, it is Long-Saphenous vein. Why? Because Long-Saphenous vein, it's very long. Clear? So two important questions. First, what is the most commonly used graft for CABG? And the most commonly used graft for CABG, it is Long-Saphenous vein. Most commonly used, that is Long-Saphenous vein. But most preferred, we discussed that arterial grafts are having longer patency rate. So most preferred graft, that is Lima. Most preferred, it is Lima. Most commonly used, it is Long-Saphenous vein. Apart from Long-Saphenous vein and Lima, there is another graft which can be used for CABG, radial artery. So radial artery can also be used. Radial artery can also be used for CABG. Now see this image. In this image, you can see that this patient is having bilateral iliac artery obstruction. And in this case, you can see here that we are going for aortofemoral bypass. You can see here, this is aorta, this aorta, this is the femoral artery. Clear? So we are going for aortofemoral bypass. So we perform aortofemoral bypass. And what is the preferred graft here? Obviously it's Dacron. So for bilateral iliac artery obstruction, we go for aortofemoral bypass. We go for aortofemoral bypass. Clear? So this is aortofemoral bypass, right? And what is the preferred graft here? The preferred graft is Dacron. So preferred graft is Dacron. So this is all about vascular graft and this is all about arterial disorders. Now we're going to start lymphatic system. In lymphatic system, the most important topic is lymphedema, and the lymphedema is further divided into primary lymphedema and secondary lymphedema. Primary lymphedema, it is mainly because of congenital malformation. What's the problem? Primary lymphedema, it is mainly because of congenital malformations. Congenital malformations, right? What about secondary lymphedema? Secondary lymphedema, it is caused by lymphatic obstruction or lymphatic disruption. So if you are going to compare primary and secondary, overall, which one is most common? So overall, it's the secondary lymphedema which is most common. There are two causes. One, it can occur because of lymphatic obstruction. It can occur because of lymphatic obstruction. And the second cause, lymphatic disruption. Clear? So it can occur because of lymphatic obstruction, and second, it can occur because of lymphatic disruption. Lymphatic disruption. Clear? Now, what is the most common cause overall? So it is lymphatic obstruction, and it is caused by what? Filariasis. So overall, most common cause of lymphedema, it is filariasis. Overall, the most common cause, that is filariasis. That's the most common cause, and you know it is caused by organism. Which organism? Wuchereria bancrofti. So the name of organism responsible, that is Wuchereria bancrofti. It is Wuchereria bancrofti. Next, lymphatic disruption. You know that in patients of carcinoma breast, we perform axillary lymph node dissection. So you perform axillary lymph node dissection, so you disrupt the lymphatics. In patients of carcinoma penis, we perform inguinal lymph node dissection, so we disrupt the lymphatics. So lymphatic disruption, what are the causes? Either we are going for lymph node dissection. What? Axillary lymph node dissection. It can be axillary lymph node dissection. Clear? Or it can be inguinal lymph node dissection. Axillary lymph node dissection or inguinal lymph node dissection. So overall, secondary is most common. Most common cause is filariasis, and the most common cause of filariasis, that is Wuchereria bancrofti. So this is secondary lymphedema. Now have a look of primary lymphedema. Primary lymphedema is further divided into congenital lymphedema, lymphedema precox, and lymphedema tarda. Congenital. So obviously, what is the age here? It is seen in children age less than 1 year of age. Usually it is congenital, means it is present at birth. It is present at birth. And you have seen edema in which areas? You have seen edema in the lower limb, you have seen edema in the face and in the genitalia. So here the patient is having edema where? In the lower limb. There is edema in the genitalia and edema of face. So lower limb, genitalia and face, these are involved. There is edema. And what happens here? Multiple limbs are involved, and this condition is bilateral and multiple limbs are involved. It is bilateral and multiple limbs are involved. There is involvement of multiple limbs. There is one question which is asked frequently, and what is the question? That familial version of congenital lymphedema is known as. This is the only question which is asked frequently, and this is Milroy's disease. What is Milroy's disease? This is familial version of congenital lymphedema. So familial version of congenital lymphedema is known as Milroy's disease. Next is lymphedema precox. Lymphedema precox, it is the most common type of primary lymphedema. This is most common type of primary lymphedema. And in which particular age group it is seen? It is seen in age group 1 to 35 years. Age group is 1 to 35 years. This is more common in females. Usually it is unilateral. More common in females, this is unilateral. And here there is involvement of calf and foot. So this is unilateral. There is involvement of calf and foot. So usually unilateral, there is involvement of calf and foot. Here also the same question, that familial version of lymphedema precox is known as Meeks disease. What's the name? Familial version of lymphedema precox is known as Meeks disease. Be careful, it is not Meek syndrome. What is Meek syndrome? Ovarian tumor, ascites, right-sided pleural effusion. That is Meek syndrome. This is Meek's disease, familial version of lymphedema precox. And what is lymphedema tarda? It is seen in which particular age group? Seen in age group more than 35 years. So age group is more than 35 years and this condition is rare. This condition is rare. I'm repeating, these are the two questions which are asked frequently. What is Milroy's disease? Familial version of congenital lymphedema. What is Meek's disease? Familial version of lymphedema precox. Now coming to the clinical features and complications. What's the problem? Because of this kind of swelling, patient is having discomfort and pain. Second, can you see these are the skin folds? So apart from discomfort and pain, these are the skin folds. In the skin folds, there is increased risk of bacterial and fungal infection. So there is cellulitis, there is lymphangitis. Because of that, there is skin discoloration and thickening. So problem, patient is having discomfort and pain, increased risk of bacterial and fungal infection. There is cellulitis and lymphangitis. There is one complication which is asked frequently, especially this we discussed in breast also, that if patient is having lymphedema for long duration. Suppose we are going to perform MRM, modified radical mastectomy, and after that patient is having upper lymphedema. Suppose radiotherapy was also given. After 10.5 to 11 years, there is lymphangiosarcoma or angiosarcoma. What is the name of this complication? This is known as Stewart-Treif syndrome. So especially this complication is important. Stewart-Treif syndrome. Clear? So especially this complication is important in relation to what? Carcinoma breast. Whenever we are going to perform MRM and we give radiotherapy, MRM plus radiotherapy is given, and usually after 10.5 years, patient is going to develop angiosarcoma. And this is known as what? Stewart-Treif syndrome. Clear? So these are the complications which are asked in exam. After that, there are certain signs which are asked in the form of image-based questions. See these signs. In this image, you can see that there is swelling over the dorsum of foot. This is known as what? Buffalo hump. So swelling over the dorsum of foot, this is known as buffalo hump. And if you see, because of prolonged confinement of foot into footwear, what is the shape of toes? These are square shaped. So squaring of toes, what is the cause? Because of prolonged confinement of foot into footwear. So there is buffalo hump, there is squaring of toes. In this image, you can see the left foot here. The skin or the toes can be pinched. So skin overlying the toes can be pinched, but if you see the right toes here, the skin overlying the toes cannot be pinched. What's the name? Stemmer sign. So skin overlying the toes cannot be pinched, that is stemmer sign. So three signs which are asked in exam: buffalo hump, squaring of toes, and stemmer sign. These are the signs which are seen in the patients of lymphedema, lower limb lymphedema. Now how to make the diagnosis of lymphedema? For diagnosis of lymphedema, in majority of cases, what? History and examination is sufficient. So how to make the diagnosis? For diagnosis of lymphedema, in majority of cases, only history and examination. History plus examination, that is sufficient. In typical cases, history and examination, it is sufficient for diagnosis. Clear? But investigations are required if patient is having atypical presentation or patient is having severe lymphedema or there are multifactorial swellings. In those cases, we go for investigation. And which investigation is done? Lymphangiography. Usually, we are not going for investigation. So, investigation required, that is lympangiography. In which cases we go for lympangiography? If there is atypical presentation, patient is having severe lymphedema with complications, or there are multifactorial swellings. Coming to the management of lymphedema, most of the patients are managed conservatively. So, conservative management is preferred. Okay, what are the components of conservative management? We ask the patient to use compression stockings. In the night when patient is sleeping, we advise limb elevation. And if there is any kind of infection like cellulitis, we have to give antibiotics. So what are the components of conservative management? Use of compression stockings. So what we are going to advise? Use of compression stockings. Second option, we go for limb elevation. So compression stockings, we go for limb elevation. Clear? And third, if patient is having infection like cellulitis, we have to give antibiotics. So why conservative management is preferred? Because if you go for surgery is having poor efficacy and there is increased risk of complications. That's why conservative management, this is preferred. For patients of lymphedema, conservative management is preferred. So what are the options for surgical management? We can go for reconstructive operation or we can go for excisional operation. See the options. Suppose we are going for reconstructive operation. So you can see this is a vein. This is the vein. And what is the direction of valve in the vein? This is the direction of valve in the vein. Clear? And you can see this is the lymphatics. Clear? Lymphatics. What is the direction of valve? Again, this is the direction of valve. Means what is the direction from periphery towards heart? Imagine in the lymphatics there is obstruction. So what we are going to do? We are going to divide the lymphatics. So you are going to divide the lymphatics, and after dividing the lymphatics, what you are going to do? You are going to suture this lymphatics to the vein. So what kind of anastomosis is this? This is lymphovenous anastomosis. So ultimately what? The lymph is entering into venous system. So you reconstructed the venous drainage. This is lymphovenous anastomosis. So this is a reconstructive operation. Now see this operation here. There is presence of unhealthy tissue. What? In this image you can see there is presence of unhealthy tissue between skin and muscle. So what you do, whatever unhealthy tissue is there between skin and muscle, you are going to excise that. And after excising that, you are going for skin grafting. You can see here, we are going for split thickness skin grafting. So you have excised the unhealthy tissue. This is known as what? Excisional operation. So reconstructive operation, excisional operation. See what are the reconstructive and excisional operations used for management of lymphedema. We discussed that lymphovenous anastomosis, that is known as Nebulowitz operation. So what is done in Nebulowitz operation? We go for lymphovenous anastomosis. So lymphovenous anastomosis, that is what? Nebulowitz operation. There is Gillies operation. Here we are using skin bridge for reconstruction. So in Gillies operation, we are using skin bridge. So here skin bridge is used for reconstruction, skin bridge. And Kinmonth, here we are using ileal mucosal patch. So in Kinmonth, we are using ileal mucosal patch. So it is ileal mucosal patch which is used for reconstructive operation, right? After that, see the excisional operations. First is cyst-trunk procedure. This is not the cyst-trunk operation, this is cyst-trunk procedure. Cyst-trunk operation, you know, it is done for thyroglossal cyst. This is cyst-trunk procedure. Second is Condoleon's, also known as Homans procedure. Charles procedure, Thompson procedure. So in these cases, we are going to excise the unhealthy tissue, and usually after that we perform the split thickness skin grafting. Clear? So this is reconstructive operation, this is excisional operation. We already discussed that in patients of lymphedema, in the management, conservative management is preferred over surgical management. Why? Because in surgical management, there is poor efficacy and increased risk of complications. So this is all about lymphedema. Now we are going to start venous disorders. First of all, we are going to discuss the DVT. For deep venous thrombosis, there is a triad which is positive. And what are the components of triad? Endothelial injury, stasis and hypercoagulable state. So endothelial injury, stasis and hypercoagulable state, this is virtuous triad, and you know it is going to increase the risk of DVT. So this is going to increase the risk of deep venous thrombosis. There are certain surgeries which are associated with high risk of DVT. So what are the surgeries in which there is high risk of DVT? Any surgery which is going to affect the mobility, in which there is prolonged immobilization, like if the patient is having extensive abdominal or pelvic surgeries, the patients who are having orthopedic surgeries or lower limb surgeries, or patient is having urological surgery, especially if the age of patient is more than 40 years. So in all these cases, since there is high risk of DVT, we go for DVT prophylaxis. So in these cases, we consider what? We consider DVT prophylaxis. Clear? There are two types of DVT prophylaxis. One is mechanical and the second is pharmacological. See the components of mechanical DVT prophylaxis. The simplest method is early ambulation. So we encourage the patient for early ambulation. That is the simplest method. So simplest method, that is early ambulation. Clear? So we encourage the patient for early ambulation. Clear? Suppose it's not possible to mobilize the patient, especially the bariatric surgery patient. So any patient who cannot be mobilized, in those cases we are using pneumatic compression devices, that is also known as sequential compression devices. So second is pneumatic compression devices. Pneumatic compression devices, which is also known as compression devices, which is also known as sequential compression devices. Clear? If you see early ambulation, this is the simplest method. Early ambulation, this is the simplest method, simplest. And what is most commonly used method? The most commonly used method, that is pneumatic compression devices or use of sequential compression devices. This is most commonly used method. This was an image based question in one of the latest exam. So in this image, you can see we are using these pneumatic compression devices, which is also known as sequential compression devices, and it is mainly going to cover which area? You can see this is the calf and this is thigh, calf and thigh. Clear? So you know that what is the most common site of DVT? It is calf vein or soleal vein, and the most common site of DVT leading to pulmonary embolism, thigh or femoropopliteal vein. So this area is covered and this is going to contract. Clear? So any patient who cannot be mobilized, in those cases we are using pneumatic compression devices. This is one option. What are the options for pharmacological methods? We can use unfractionated heparin. First option we have, for pharmacological method, we can use unfractionated heparin. And the second option we have, that is low molecular weight heparin. Now you tell me, out of unfractionated heparin and low molecular weight heparin, which one is preferred? So obviously it is the low molecular weight heparin which is preferred. Why? Because here monitoring is not required. Now see the important points related to DVT. First we discussed that what is the most common site of DVT? It is calf vein. It is also known as soleal vein. So most common site, it is calf vein, which is also known as what? Soleal vein. So it is calf vein or soleal vein. Next, most common site of DVT leading to pulmonary embolism. This is thigh vein. This is thigh vein or femoropopliteal vein. So it is thigh vein or femoropopliteal vein. Now see, what is the most common symptom? So any patient who is having DVT, that patient is having pain and swelling in the calf region. And what is the most common sign? There is calf tenderness. So most common symptom here, there is pain and swelling in calf region. There is pain and swelling. So these patients are having pain and swelling in calf region. In calf region. Clear? And what is the most common sign? That is calf tenderness. The most common sign, that is calf tenderness. Right? Another important point, DVT is bilateral in 30% cases. Means mostly it is unilateral, but bilateral DVT is also common. So bilateral DVT, it is seen in 30% patients. Bilateral DVT, this is one question. It is seen in 30% cases. It means it is common. And you know that this DVT can cause pulmonary embolism. So suppose patient is having low grade fever. It is typical of recurrent pulmonary embolism. What are the signs of DVT we discussed? The most common sign is calf tenderness. Apart from that, apart from calf tenderness, what are the other problems? Apart from calf tenderness, these patients will be having edema, and initially this edema is pitting followed by non-pitting, and the patient will be having tenderness along the course of deep vein. So apart from calf tenderness, the patient is having edema. What kind of edema patients are having? The edema, initially it is pitting. So these patients are having pitting edema initially, followed by it becomes non-pitting. Because of extensive collection of fluid, it becomes non-pitting, and there is tenderness along the course of deep vein. What happens? The patient is having calf tenderness. Apart from that, there is tenderness along the course of deep vein. There are important signs which are asked in exam. Signs of DVT. First one, there is increased resistance to passive dorsiflexion of foot. And this increased resistance to passive dorsiflexion of foot, what is the name of this sign? This is known as Homan sign. So increased resistance to passive dorsiflexion of foot, that is known as what? Homan sign. Second problem, application of pressure over the calf region, and this is known as Moses sign. What is the other name? This is also known as Bancroft sign. So application of what? Pressure leads to pain, and that is known as what? Moses sign. Moses sign, also known as Bancroft sign. This is known as Moses sign, also known as Bancroft sign. And whenever we are going to squeeze the calf, squeezing of calf leads to pain. This is known as Pratt sign. So squeezing of calf leads to pain. That is known as Pratt sign. There are two terms which are asked in exam. One is phlegmasia alba dolens and the second is phlegmasia caeruleia dolens. You can see this image. Alba means white. So what is the name? Phlegmasia alba dolens. This is painful white leg, and this is caeruleia. Caeruleia means blue. It is blue. That is phlegmasia caeruleia dolens means it is painful blue leg. So this one, it is painful white leg. What's the name? Phlegmasia alba dolens. That is painful white leg. It is white leg, and here you can see the color. This is painful blue leg. What's the name? This is painful blue leg. right? Now the problem, both of these patients are having DVT. In one patient there is patent collaterals, and in the second patient there is obstructed collaterals. You know, in Alba dolens, these patients are having DVT with patent collaterals. Why? Because via patent collaterals, yes, the deoxygenated blood goes to the heart. But what happens, since there is obstructed collaterals in Cerulean dolens, here patient is having DVT with obstructed collaterals, and that's why there is collection of deoxygenated blood. That's why it is blue. Clear? So phlegmasia alba dolens, painful white leg, there is patent collaterals. Phlegmasia caerulea dolens, that is painful blue leg, here there are obstructed collaterals. What is the investigation of choice for diagnosis of DVT? For DVT also and for varicose vein also, investigation of choice for diagnosis, that is duplex scan. So what is the investigation of choice for diagnosis? For both DVT as well as varicose vein, it is duplex. Now coming to the management, anywhere in the body, if patient is having thrombotic process or thrombosis is going to start, obviously we have to start the anticoagulants. Here, what is the drug of choice? Here we start IV heparin. So the drug of choice is heparin. So how we are going to manage DVT? See the management. Management, you know that the drug of choice, it is IV heparin. So we have to give IV heparin, and for how many days we give IV heparin? IV heparin is given for 5 days. Second drug which we are going to start, that is warfarin. You know that minimum time required for warfarin to act, it is 72 hours. So what? We start warfarin, and we have to perform the dose adjustment. Why? It takes minimum 72 hours. It means the dose adjustment should be done on third day onwards. So for warfarin, we perform dose adjustment. Clear? And this dose adjustment is done. Dose adjustment, it is done on third day onwards. Clear? So dose adjustment, it's done on third day onwards. For monitoring of heparin, we use investigation, that is APTT, and for warfarin, we use INR. So important questions which are asked in exam. For heparin monitoring, we use APTT. So the investigation is APTT. And what should be the reference range of APTT for heparin? Yes, the reference range is 1.5 to 2.5. The reference range is 1.5 to 2.5. And second, for warfarin, you know which investigation we use. For warfarin, we use INR. So for warfarin, we use INR. And here, what should be the reference range? For INR, the reference range should be 2 to 3. The reference range should be 2 to 3. Clear? So both of these questions are asked, what investigation is used for monitoring and what should be the reference range. Now see the varicose vein. This is dilated, elongated, tortuous vein, and the diameter should be more than equal to 3 mm. So dilated, elongated, tortuous vein, important point, you have to remember the diameter. Dilated, elongated, tortuous vein, diameter more than 3 mm, more than equal to 3 mm. Varicose vein is further divided into the system involvement, whether long saphenous vein is involved, whether short saphenous vein is involved. So you can see this image here. In this case, you can see the presence of varicose vein over anteromedial aspect. So this is, in this image, there is involvement of long saphenous vein, and if it is located over posterolateral aspect, so here there is involvement of short saphenous vein. So first, whether long saphenous vein is involved or short saphenous vein is involved, it is further divided into primary varicose vein and secondary varicose vein. What is primary? Primary means there is congenital predisposition with occupational reinforcement. What do you mean by congenital predisposition? It means these patients are already having decreased number of valves or defective valves. Occupational reinforcement means these patients are having occupations in which there is prolonged standing. So occupations in which there is prolonged standing, like surgeons, teachers, bus conductors, traffic policemen. So this is primary varicose vein. Clear? Secondary means this varicose vein, it is secondary to something. Secondary to what? Secondary to obstruction in vein. And what is the most common cause of secondary varicose vein? It is DVT. What is the most common cause of secondary varicose vein, and that is deep venous thrombosis because there is obstruction in deep veins. Now coming to the clinical features, imagine any patient who is having varicose vein. Initially patient will be having dull aching pain in the evening hours. Simultaneously patient will be having pedal edema also, and if you ask the patient that if you perform the limb elevation or take rest for 2 to 3 hours, the pain as well as edema disappears. So initially what's the presentation? These patients are having dull aching pain. Clear? So initially patients are having dull aching pain and there is edema, pedal edema, and usually these symptoms are more prominent in evening hours and it subsides completely after taking rest. There is one condition which leads to complication in the varicose vein, that is known as chronic ambulatory venous hypertension. So what is the factor which is responsible for complications in the varicose vein? It is chronic ambulatory venous hypertension. So this is what? This is chronic ambulatory venous hypertension. Clear? So chronic ambulatory venous hypertension, this is responsible for complications in the varicose vein. Now the problem, there is hyperpigmentation. Why there is hyperpigmentation? Because there is deposition of hemosiderin. So hyperpigmentation, it is because of deposition of hemosiderin. Apart from hyperpigmentation, there is lipodermatosclerosis, eczema, and whenever there is loss of epithelium, what will happen? Patient will develop venous ulcer. So these are the complications. Now how we are going to make the diagnosis? We already discussed that here also investigation of choice for diagnosis. Here also the investigation of choice for diagnosis, that is duplex scan. It is duplex scan. Clear? Coming to the management, right? Initially, the treatment of choice was surgery, that was Trendelenburg operation. But nowadays, what is the gold standard treatment? The gold standard treatment, it is endothermal ablation. So what? This is important question asked frequently. What's the gold standard treatment? Nowadays, the gold standard treatment for varicose vein, this is endothermal ablation. What we do? Endothermal ablation. And in endothermal ablation, what are the techniques which are performed? In endothermal ablation, we have two options. First, we can go for radiofrequency ablation, and the second option, there is endovenous laser ablation. Radiofrequency ablation, endovenous laser ablation. Previously, stripping was done. What was the name of that surgery? It was Trendelenburg operation. Previously, venous stripping was done and it was Trendelenburg. So the name of operation was Trendelenburg operation. Nowadays, this is not done commonly. The gold standard treatment, it is endothermal ablation. Why endothermal ablation is gold standard? Because it can be performed on daycare basis. In the morning, you admit the patient, you perform the procedure, you can discharge the patient, and there are lesser complication rate. That's why endothermal ablation, this is the gold standard treatment. Now see what's done in radiofrequency ablation. First, we are going to insert the catheter. You can see here. The catheter is inserted into the vein first. After that, controlled heat is applied, and after that you can see what? The vein is going to collapse. So when controlled heat is applied, the vein is going to collapse, and ultimately what happens? The vein is closed, it will be converted into a cord-like structure, and catheter is withdrawn, closing the vein. This is radiofrequency ablation. The second technique is endovenous laser ablation. So what is done here? You can see in the varicose vein, laser fiber is inserted. So you can see here that laser fiber is inserted in the varicose vein. And what happens? Slowly fiber is removed. And whenever we are going to remove this laser fiber after activation, what happens? The vein is going to collapse. It is going to close. So it will be converted into cord-like structure. So because of lesser complication, this endothermal ablation is preferred. So here you can see, this is the Trendelenburg operation. What is done here? We are going to strip the vein. And when the vein is being stripped, what happens? There are complications also. What? There can be hematoma. There can be injury of nerves. So what happens? The stripping should be done just below the knee joint. Because if you're going to extend the stripping beyond knee joint, what happens? There is injury of one nerve. Which one? Saphenous nerve. So if stripping is done beyond this, beyond knee joint, here there is injury of saphenous nerve. So whenever we are stripping the long saphenous vein, there can be injury of saphenous nerve. And similarly, if you are going to strip the short saphenous vein and the stripping is done beyond ankle joint, there is injury of sural nerve. So these are the questions which are asked frequently, that what is the most commonly injured nerve during stripping of varicose vein. So if stripping is done beyond knee joint, stripping of long saphenous vein, it leads to injury of saphenous nerve. It leads to injury of saphenous nerve. And whenever stripping of short saphenous vein is done beyond ankle joint, there is injury of sural nerve. And whenever these nerves are injured, what is the effect? These nerve injury leads to sensory abnormalities in the leg and foot. So because of injury of these nerve, there is sensory abnormalities in the leg and foot. Second option, in which type of varicosities we are using sclerotherapy. So whenever the varicose vein diameter is less than 3 mm. So whenever the vein diameter, this is a question, whenever the diameter of vein, it is less than 3 mm, in this case, we go for sclerotherapy. Certain definitions are asked that what is spider vein, what is reticular vein, what is varicose vein. So question, whenever the diameter of vein is less than 1 mm, this is spider vein, you can see. These are the spider veins. These are spider veins. Whenever the diameter is 1 to less than 3 mm, this is what? Reticular veins, you can see. Whenever diameter is more than equal to 3 mm, this is what? This is varicose vein. So these definitions are asked: spider vein less than 1 mm, reticular vein 1 to less than 3 mm, and varicose vein more than equal to 3 mm. Now see the complications of varicose vein surgery. Recurrence can occur, and recurrence can occur in up to 10% patients. In up to 10% patients, recurrence can occur, and this is the most common complication. Recurrence can occur in up to 10% patient. This is the most common complication. During stripping of varicose vein, there can be ecchymosis or hematoma. And whenever we are stripping long saphenous vein, there is injury to saphenous nerve. And if we are stripping short saphenous vein, there is injury to sural nerve. So there is sensory nerve injury. And because of this, what will happen? There is sensory abnormalities in leg and foot. CEAP classification is for chronic lower extremity venous disease. It's one of the most frequently asked classification nowadays. So what is the meaning of C? C means clinical. Clinical means clinical manifestation, whether patient is asymptomatic or patient is having symptomatic manifestations. After that E. E means etiological classification. So whether it is congenital, it's primary or secondary. What kind of disease? It is congenital. So it's congenital, or it is primary, or it is secondary. A means anatomical distribution. It means there is involvement of only superficial system, only deep system, only perforators, or there is involvement in combination. So there is involvement of only superficial system, only deep system, only perforators, or there is involvement of this combination. After that P means pathophysiological dysfunction. So what kind of pathophysiological dysfunction? There is only reflux or obstruction or both. So only reflux is there. There is only reflux or obstruction or both are there. Clear? So what is CEAP classification? C, clinical manifestation. E, etiological classification. A, anatomical distribution. And P, pathophysiological dysfunction. Nowadays, lots of questions are asked about clinical manifestation. So what is C0? Here you can see C0. C0 means there are no visible or palpable sign. So if there are no visible or palpable sign, it is C0. C1, if these patients are having telangiectasia or patients are having reticular vein, then it's C1. Officially, varicose vein is seen when it is C2. So C2 means patient is having varicose vein. After that, when patient is having edema, edema means patient is having C3. C3 means edema. In C4, patient is going to develop the complications. C4 is further divided into C4A, C4B. You can see in C4A, patient is having what? Pigmentation. So in C4A, patient is having what? Pigmentation. C4A, the patient is having pigmentation or eczema. And in C4B, these patients are having lipodermatosclerosis or there is white atrophy. In exam, mostly they are asking C4A, C4B. C4A, there is hyperpigmentation or pigmentation and or eczema, and in C4B there is lipodermatosclerosis. Here you can see C5 means there is healed wound and C6 means open wound. Clear? So in exam, mostly they are asking C2, C3, C4A, C4B. C0, no visible or palpable sign. C1, there is telangiectasia or reticular vein. C2, patient is having varicose vein. C3, edema. C4, complications. So C4A, you saw pigmentation and or eczema. And in C4B, this is most commonly asked, C4B, that is lipodermatosclerosis. This is what? Lipodermatosclerosis and or white atrophy. C5, healed wound, and C6, open wound. The patients who are having varicose vein, you can see there is a typical shape of the lower limb. You can see what is the shape of this lower limb. It is looking like what? Inverted champagne bottle appearance. Clear? So there is inverted champagne bottle appearance. So what is the typical appearance? These patients are having appearance of lower limb. There is inverted champagne bottle appearance. Inverted champagne bottle appearance. Clear? So patients are having inverted, you can see here, champagne bottle appearance. There is inverted champagne bottle appearance. This is one question which is asked. Second question is asked related to venous ulcers. So we discussed that for venous ulcer or for varicose ulcer, which theory is responsible? It is because of chronic ambulatory venous hypertension. So this is because of chronic ambulatory venous hypertension. Chronic ambulatory venous hypertension. Clear? This is because of chronic ambulatory venous hypertension. Now what is the typical location of this ulcer? You can see. If you see the typical location of venous ulcer, it is located between this medial malleolus and calf muscle. What is the name of this region? This is known as Gator's region. So venous ulcer or varicose ulcer, you can see it is located in Gator's region. What is the location? It is located in Gator's region. So located just above medial malleolus, in between medial malleolus and calf muscle, that is known as Gator's region. If you see the characteristic features of this venous ulcer, you can see that what kind of edges are there. These patients are having sloping edges. What kind of edges are there? There are sloping edges, and you can see in the floor there is pink granulation tissue, and what you can see that there is hyperpigmentation around the ulcer. There is hyperpigmentation of skin around the ulcer. So sometimes questions are asked related to venous ulcer and arterial ulcers. How you can differentiate venous ulcer from arterial ulcer? Have a look. If you see arterial ulcers and ischemic ulcer, these are having punched out appearance. What kind of edges are there? These are having punched out edges. So it is punched out. Can you see the thin shiny skin? Why? Because of ischemia there is loss of subcutaneous fat. That's why there is thin shiny skin. Because of ischemia you can notice that there is absence of hair, and you can see that there is brittle nails. Can you see brittle nails? And you can notice that there is loss of one toe also. Part of one toe. Clear? So what happens? These are the signs of ischemia. So this is arterial ulcer or ischemic ulcer. What are the characteristic features? Punched out edges. There is thin shiny skin. Why? Because there is loss of subcutaneous fat, and there are signs of ischemia like there is absence of hair and brittle nails. So this is how we can differentiate easily arterial ulcer from venous ulcer. And you can see the location also. It is located over shin of tibia. How we manage the patients who are having venous ulcer or varicose ulcer? It is managed by Bisgard's regime. So for the management of varicose ulcer, we follow the Bisgard's regime. What are the components of Bisgard's regime? First, limb elevation. Second, massage and use of compression stockings. So for varicose ulcer, we follow this Bisgard's regime, in which we include limb elevation, massage and compression stockings. There are two syndromes which are asked frequently in relation to AV malformation. The first is Klippel-Trenaunay syndrome. What is the problem in Klippel-Trenaunay syndrome? There is congenital AV fistula, and because of that, what happens? There is hypertrophy of involved extremity, or patient is having local gigantism. So because of congenital AV fistula, what you are going to notice that patient is having local gigantism. There is local gigantism. Clear? Local gigantism means there is hypertrophy of involved extremity. So now compare these two limbs. If you compare what? The patient is having cutaneous hemangioma. Can you notice? Yes. Apart from that, if you see, the patient is having varicosity also. Clear? So you can see this varicosity. So apart from cutaneous hemangioma, patient is having varicosity. The main problem of this patient is absence of deep venous system. So there is varicosity and there is absence of deep venous system. So we cannot strip the varicosity because this is the only channel for the venous drainage. So how you manage these patients? These patients are managed conservatively with help of elastic compression stockings. So I'm repeating, it is characterized by congenital AV fistula leading to local gigantism. These patients are having cutaneous hemangioma. You can notice there is varicosity or varicose vein and absence of deep venous system. Because there is absence of deep venous system, that's why what is contraindicated? Since there is absence of deep venous system, stripping of varicose vein is contraindicated. So stripping of varicose vein, it is contraindicated. So what's the management? Most of these patients are managed conservatively. So it's the conservative management, and how we manage these patients with the help of elastic compression stockings. So these patients are managed with the help of elastic compression stockings, right? So managed with elastic compression stockings. The second condition is Casa-Bach-Merit syndrome. Here you can notice that these patients are having hemangioma or AV malformation. Because of that, what's the problem? These patients are having microangiopathic hemolytic anemia, and there is consumptive coagulopathy. There is platelet trapping. Because of that, patients are having thrombocytopenia. These patients are having thrombocytopenia. Clear? Now, how to manage? Since patient is having AV malformation, so you can manage these patients with the help of embolization. Patient is having AV malformation, so we can manage these patients with the help of embolization. Clear? And the second option we have that we can use elastic compression bandage. So what's the management? In the management, we can use embolization because patient is having AV malformation. So one option we have embolization, and the second option we can go for external compression bandage. So second option we can go for external compression bandage. External compression bandage. Clear? So these are two conditions which are asked frequently. One is Klippel-Trenaunay syndrome and the second is Casa-Bach-Merit syndrome. What is the most common cause of superficial thrombophlebitis? So in internship you have seen it is because of IV infusion. So most common cause, it is because of IV infusion. You have inserted cannula, there is IV infusion. So that's the most common cause of superficial thrombophlebitis. Other causes are trauma. There is Burgess disease. You know what are the components of triad of Burgess disease? Mnemonic is RIM. The triad is RIM. R means Raynaud's phenomena, I means intermittent claudication, M means migratory superficial thrombophlebitis. So even in Burgess disease, there is migratory superficial thrombophlebitis. Malignancies can also cause migratory superficial thrombophlebitis. And what is the most common malignancy responsible for superficial thrombophlebitis? You know, it is carcinoma pancreas. So the malignancy which is most commonly responsible, that is carcinoma pancreas. So if there is migratory superficial thrombophlebitis in malignancy, what is the name of this syndrome? This is known as Troisiu syndrome. There are three questions which are asked frequently. First, migratory superficial thrombophlebitis in malignancies, that is known as Troisiu syndrome. What is the name? This is known as Troisiu syndrome. Troisiu syndrome. Second, patient is having carpopedal spasm in hypocalcemia, and this is known as Troisiu sign. Carpopedal spasm in hypocalcemia. What is the name? This is known as Troisiu sign. This is Troisiu sign. And third, patient is having palpable left supraclavicular lymphadenopathy. And what is the name of this condition? This is known as Troisier sign. The name is Troisier sign. And you know what is the name of this lymph node? The name of this lymph node, this is known as Virchow's node or signal node. So lymph node is known as Virchow's node. Lymph node, that's known as Virchow's node or signal node, and the name of this sign is Troisier sign. So these are frequently asked in exam, and this is all about venous disorders. Now we are going to start thorax and mediastinum. First of all, we are going to discuss the mediastinal masses. So what is the most common anterior mediastinal mass? Anterior mediastinal mass, it is thymoma. So most common anterior mediastinal mass, this is thymoma. It is thymoma. After that, the most common middle mediastinal mass is the cyst. And what kind of cyst? It is pericardial cyst. So most common middle mediastinal mass, that is cyst. It is the cyst. And what kind of cyst? It is pericardial cyst. Clear? So it is cyst. What kind of cyst? This is pericardial cyst. Okay. After that, most common posterior mediastinal mass, this is neurogenic tumor. So most common posterior mediastinal mass, this is neurogenic tumor. Okay. This is neurogenic tumor. Right. Sometimes the question is asked that overall most common type of mediastinal mass. So overall most common mediastinal mass, it is neurogenic tumor. So overall most common mediastinal mass, that is what? That's neurogenic tumor. That's what? That's neurogenic tumor. Neurogenic tumor. Okay. Now coming to the investigations. What is the investigation of choice for diagnosis of mediastinal masses? So for mediastinum, we go for CT. Which kind of CCT? So investigation of choice for diagnosis of mediastinal masses, that is CCT. But there is one exception. What? Neurogenic tumor. Obviously for neurogenic tumor means for posterior mediastinal masses, we go for MRI. So exception is neurogenic tumor. Investigation of choice for diagnosis of posterior mediastinal masses, this is MRI. This is MRI. So these are one-liner questions which are asked frequently related to mediastinal masses. there are certain mediastinal masses which are seen in all three compartments. So what are the mediastinal masses which are seen in all three compartments? It is lymphoma, mesenchymal tumors and bronchogenic cyst. Lymphoma, mesenchymal tumors and bronchogenic cyst. How to remember? Mnemonic is LYM. What's the mnemonic? How to remember? It is LYM. LYM. So LY, that is lymphoma, M, mesenchymal tumors, and B, that is bronchogenic cyst. Now we are going to discuss the hemothorax. Most of the trauma-related topics related to thorax are discussed in the chapter trauma. So hemothorax. So here what's the problem? Blood is collected in the pleural space secondary to the trauma of chest wall or lung laceration. So blood is accumulated in the pleural space secondary to the trauma of chest wall or lung laceration. So you tell me, what is the most common cause of hemothorax? Trauma. So first question, what's the most common cause? Hemothorax. Most common cause of hemothorax, it is trauma. Apart from trauma, what are the other causes? It can occur because of tuberculosis. It can occur because of tumors. So TB, tumors. Clear? 3T. So most common cause overall, it is trauma. Suppose patient is having trauma. What kind of trauma? Blunt trauma. So question is asked, what is the most common cause of massive hemothorax in patients of blunt trauma to the chest? It is rib fracture, and because of rib fracture, what's the problem? There is torn intercostal vessels. So trauma, what kind of trauma? Imagine a patient is having blunt trauma. The patients who are having blunt trauma to the chest. So because of this blunt trauma to the chest, what's the problem? Sometimes there is rib fracture. And because of this rib fracture, there is torn intercostal vessels. So rib fracture, it leads to torn intercostal vessels. And these torn intercostal vessels are responsible for massive hemothorax. This was the question in exam, that what is the cause of massive hemothorax in the patients who are having blunt trauma to the chest? Blunt trauma to the chest. So blunt trauma to the chest leads to rib fracture. It leads to torn intercostal vessels, and that can cause massive hemothorax. Now see this patient. In this case, you can see here that there is accumulation of blood in the pleural space. So blood is collected in the pleural space and there is collapse of ipsilateral lung. So what is the problem? Since blood is collected, so there is blood loss. And because of this blood loss, patient will be having hypovolemic shock. And if patient is having hypovolemic shock, you will notice that there are flat neck veins. Second, there is unilateral absence of breath sound. Means on the affected side, there will be absent breath sounds. And if you do the percussion, since fluid is collected, what? There is dullness. So you are going to see dullness on percussion. So what are the problems? In patients who are having hemothorax, first, patients will be having manifestations of hypovolemic shock, signs and symptoms of hypovolemic shock because there is blood loss, hypovolemic shock. And if patient is having hypovolemic shock, you will notice that there is flat neck veins. Flat neck veins. How you differentiate hemothorax from tension pneumothorax? In tension pneumothorax, there is distended neck veins. Why? Because in tension pneumothorax, there is compression of superior vena cava as well as inferior vena cava. But in hemothorax, there is flat neck veins. Apart from that, there is absent of breath sound on affected side. So absent breath sounds, unilateral absent breath sounds. Clear? In tension pneumothorax also, there is absent breath sounds. But in tension pneumothorax, there is hyperresonance on percussion. Here, there is dullness on percussion. There is dullness on percussion. Dullness on percussion. Now, how we are going to make the diagnosis is very easy. Just you have to insert a needle. So, what you have to do? Insert a needle and perform the aspiration. So, needle aspiration of pleural fluid. If you are going to perform the needle aspiration, you can find the blood. So, this is going to make the diagnosis. So, how we make the diagnosis? It's easy. Diagnosis of hemothorax, it's made by needle aspiration of pleural fluid. So, diagnosis is made by needle aspiration. Needle aspiration of pleural fluid. Clear? You can make the diagnosis by needle aspiration, but you won't be able to assess the extent. And to assess the extent and presence of hemothorax, we go for chest X-ray. So, what is the role of chest X-ray? Chest X-ray is done to assess the extent of hemothorax, obviously, and presence. So, extent and presence of hemothorax. This question is asked frequently. They give image-based questions, so see how it looks like on chest X-ray. So, in this image, you can see this is the pleural cavity. Clear? and here there is collection of blood. Clear? And you can see the ipsilateral lung is collapsed. So this patient is having hemothorax. Obviously, how we are going to treat it? ICD insertion or tube thoracostomy. So how you treat it? What's the treatment of choice? Treatment of choice of hemothorax. It's ICD insertion or tube thoracostomy. ICD means intercostal drain. So it is intercostal drain insertion or tube thoracostomy. Tube thoracostomy. Clear? Tube thoracostomy. So almost every year you will find one question related to either tension pneumothorax or hemothorax. Next is pulmonary embolism. What is the most important risk factor? You already know it's DVT, deep venous thrombosis. So most important risk factor for pulmonary embolism, DVT. Next, what is the most common site of DVT? You know, calf or soleal vein. And most common site of DVT leading to pulmonary embolism, it is thigh or femoropopliteal vein. So most common site of DVT, it is calf or soleal vein. So calf or soleal vein. And the most common site of DVT leading to pulmonary embolism, it is thigh vein. Thigh vein. So it is thigh vein or femoropopliteal vein. Clear? So it is thigh vein or femoropopliteal vein. Clear? So thigh vein or femoropopliteal vein. What is the problem in the patients of pulmonary embolism? That 60 to 80% cases are silent, clinically silent. So these patients are not coming to us. What is the most common symptom? The most common symptom is dyspnea, and the most common sign, that is tachypnea. So most common symptom of pulmonary embolism, it is dyspnea. Most common symptom, that is dyspnea, and the most common sign, it is tachypnea. That's tachypnea. Clear? Apart from dyspnea and tachypnea, some of the patients are having chest pain, there is hemoptysis, there is cough. Since the risk factor is DVT, so there might be evidence of DVT that these patients are having unilateral leg swelling, some patients are having fever, some patients are having wheeze or pleural friction rub. So apart from DVT signs and symptoms like unilateral limb swelling, the patients are having fever, patients are having wheeze, pleural friction rub. So there is a criteria known as modified Wells criteria, which is used for predicting pulmonary embolism. You have to remember the name. What's the name? It is modified Wells criteria. This is asked frequently. So this is modified Wells criteria. This is used for predicting pulmonary embolism. So this is used for predicting. Clear? So this is used for predicting pulmonary embolism. Second, D-dimer. D-dimer is excellent screening test. What is the good thing about D-dimer? That it is having high negative predictive value. So second is D-dimer, modified Wells criteria. It is used for predicting pulmonary embolism, and D-dimer. D-dimer is excellent screening test. It is having high negative predictive value. It is having high negative predictive value. Investigations are asked frequently in relation to pulmonary embolism. So tell me, what is the investigation of choice for diagnosis? It is multi-detector CT, MDCT. That is multi-detector CT. Okay. What is the gold standard investigation? That is pulmonary angiography. Gold standard, that is pulmonary angiography. It's pulmonary angiography. That's the gold standard investigation. Now comes the question, what are the ECG findings in pulmonary embolism patient? What is the most common finding? These patients are having sinus tachycardia. And you know that sinus tachycardia is a non-specific finding. So what is the most specific finding? Two questions. ECG findings in pulmonary embolism. First, most common finding. What is the most common ECG finding? So obviously, patients are having sinus tachycardia. Sinus tachycardia, but you know that sinus tachycardia, it's non-specific. So question is asked that what is the most specific ECG finding in patients of pulmonary embolism? Most specific finding. Clear? So what is the most specific ECG finding? And this is S1 Q3 T3 pattern, frequently asked in question. This is S1 Q3 T3 pattern. So you will find S1 Q3 T3 pattern, and this is not seen in all patients. It is seen only in less than 12% patients. So S1 Q3 T3 pattern, it is seen in less than 12% patients. Seen in less than 12% patients. Now coming to the management, in most of the patients what we have to go for? Anticoagulation and observation. So for most of the patients, anticoagulants and observation is sufficient. So it's the anticoagulants and observation. Anticoagulants and observation, right? Imagine the patient is having severe right heart strain, or patients who are having shortness of breath. Severe right heart strain or shortness of breath. In these cases, we have to go for fibrinolytic treatment, or we go for radio-guided catheter embolectomy. So, the patients with severe right heart strain or shortness of breath, we have options here. We can go for fibrinolytic treatment, fibrinolytic treatment, or second option, we go for radio-guided catheter embolectomy, or radio-guided catheter embolectomy. So radio-guided catheter embolectomy. Clear? So it's the radio-guided catheter embolectomy. Second, prophylaxis for patients of pulmonary embolism. Imagine patient is high risk for pulmonary embolism, but patient is having contraindication to anticoagulants. So if patient is having contraindications to anticoagulants, simultaneously patient is high risk case also. In these cases, we go for IVC filters. So what is the role of IVC filters? IVC filters are used for the patients who are high risk for pulmonary embolism, but the patient is having contraindications for use of anticoagulants. Now we are going to discuss the lung tumors. You tell me what is the most common benign tumor of lung, that is pulmonary hematoma. Important question. Pulmonary hematoma, this is most common benign tumor of lung. This is most common benign tumor. Most common benign tumor of lung, that is pulmonary hematoma. It is most commonly going to manifest as overgrowth of cartilage. So most commonly manifested as overgrowth of cartilage, more common in males, and in which particular age group? 40 to 60 years. Now what is the problem? If you go for chest x-ray, you can see here, on chest x-ray, this kind of calcification is there. This is popcorn calcification. On CT also, you will find popcorn calcification. Apart from popcorn calcification on CT, there is coin-like lesion. So on CT, apart from popcorn calcification, there is coin-like lesion. So important question, on chest x-ray, you can see here, on chest x-ray, these patients are having popcorn calcification. On CT, popcorn calcification, apart from that, there is coin-like lesion. And what is the definitive treatment? Obviously, the definitive treatment is excision. So what's the treatment here? Definitive treatment, we go for excision. So definitive treatment of pulmonary hematoma, we go for excision. Next is bronchial adenoma. So the term is bronchial. So if it is bronchial, first question, what is the most common site? It is the main bronchi. So bronchial adenoma. So first question, what is the most common site? Most common site of bronchial adenoma is the main bronchi. Main bronchi. Bronchial adenoma, main bronchi. That's the most common site. Second, it is adenoma. See, adenoma is a misnomer. Why? Because this bronchial adenoma, it is going to include all neoplasms of tracheobronchial tree. All neoplasms of tracheobronchial tree are included in this. So it is going to include carcinoid tumors, it is going to include adenocystic tumors, it is going to include mucoepidermoid tumors. So out of carcinoid, adenocystic tumors, mucoepidermoid tumors, tell me which one is most common. In 80% cases, it is the carcinoid tumor which is responsible. So most common type of bronchial adenoma, this is what? Carcinoid tumor. Okay. And we discuss what is the most common site? Bronchial. So most common site is main bronchi. If the tumor is arising from main bronchi, so what kind of growth is there? Endobronchial growth. Second problem, these tumors are highly vascular. And if the tumor is highly vascular, obviously what is the symptom? The most common symptom is recurrent hemoptysis. So it's easy to understand the symptom. It is highly vascular. Because of that, what happens? The most common symptom is recurrent hemoptysis. It is going to bleed. So what is the most common symptom? It is going to bleed. So there is recurrent hemoptysis. Most common symptom is recurrent hemoptysis. It was asked many times. The most common symptom, that is recurrent hemoptysis. Endobronchial growth. First, see what is the meaning of endobronchial growth. So here you can see this is the growth. This kind of growth, it is arising from main bronchi. So this is endobronchial growth. So obviously what happens, it is going to obstruct the bronchi. Because of that, these patients are having chronic cough. There is intermittent hemoptysis. Atelectasis can occur. there is pneumonia because of obstruction. There can be atelectasis, pneumonia, or it can cause lung abscess. So there is endobronchial growth. What are the manifestations? So because of endobronchial growth, the patients can develop cough. There is chronic cough, atelectasis, pneumonia, and lung abscess. Now, how we are going to make the diagnosis? Again, we have to do the biopsy. How we have to do the biopsy? We have to perform bronchoscopy. Tumor is arising from main bronchi. So perform bronchoscopy and do the biopsy. So how we are going to make the diagnosis? It's easy. Investigation of choice for diagnosis. Investigation of choice for diagnosis. We perform bronchoscopy and biopsy. Here we perform bronchoscopy. So it's the bronchoscopy and biopsy. And what's the treatment? We perform surgical resection. So surgical resection, that's the treatment. Treatment of bronchial adenoma is the surgical resection. Clear? Surgical resection. The question which is asked frequently, they ask the symptom. What is the most common symptom of bronchial adenoma? Recurrent hemoptysis. And what is the most common type of bronchial adenoma? It is the carcinoid tumor. Malignant mesothelioma is the most common tumor of pleura, and it is more common in males. In which particular age group it is seen? 40 years. So more common in males, age 40 years is the most common tumor of pleura. What is the risk factor? One of the important risk factor is asbestos exposure and radiation exposure. So asbestos exposure, especially straight amphibole fibers, and which variety is most dangerous? It is the crocidolite variety. So most dangerous type or most dangerous variety, it is the crocidolite. It's the crocidolite variety which is the most dangerous, right? Radiation exposure also increases the risk of malignant mesothelioma. But let me tell you, smoking is not a risk factor for malignant mesothelioma. An important point, smoking and asbestos exposure, smoking and chronic asbestos exposure, these are having synergistic effect for carcinoma lung, but it's not having effect, it's not a risk factor for what? Malignant mesothelioma. So if in the question both are mentioned that patient is a smoker and there is chronic asbestos exposure, obviously it leads to carcinoma lung. Smoking is not a risk factor for malignant mesothelioma, you have to remember. So what? Smoking is a risk factor for carcinoma lung, but smoking is not a risk factor. It's not a risk factor for malignant mesothelioma. What is the most common type of malignant mesothelioma? It is epithelioid variety. So this is the most common type which is having favorable prognosis, epithelioid. The second is sarcomatoid and third is biphasic. Epithelioid, sarcomatoid, biphasic. Epithelioid is most common type having favorable prognosis. Now see how it looks like. You can notice here that these patients are having fibrocalcific plaque. So you can notice here that there is presence of this fibrocalcific plaque on the pleural surface. So there is presence of this, you can see here, fibrocalcific plaque on the pleural surface. What is the main problem? In more than 90% patients, there is pleural effusion. And if patient will be having pleural effusion, more than 90% patients are having pleural effusion. So because of pleural effusion, these patients are having dyspnea, there is chest pain, there is chronic cough. And since it's a malignancy, it leads to weight loss. So in the patients of malignant mesothelioma, pleural effusion, it is present in more than 90% patients. And this pleural effusion, it is responsible for what? It is responsible for dyspnea, chest pain, chronic cough. Since it's a malignancy, that's why there is weight loss. Suppose we go for chest x-ray, what we are going to find? Obviously, we are going to find the pleural effusion. There is generalized pleural thickening and shrunken hemithorax. So on chest x-ray, pleural effusion, generalized pleural thickening and shrunken hemithorax. Obviously, what is the investigation of choice for diagnosis? We go for biopsy. And what kind of biopsy? Either we can go for thoracoscopic biopsy or we can go for open pleural biopsy. So what is the investigation of choice for diagnosis? In malignant mesothelioma, investigation of choice for diagnosis, it is biopsy. And what kind of biopsy? It can be performed due via thoracoscopy. So it is thoracoscopic biopsy. It is thoracoscopic biopsy, or we can go for open pleural biopsy. We can go for open pleural biopsy, thoracoscopic biopsy, or we can go for open pleural biopsy. Now coming to the treatment, let me tell you, there is no effective treatment for malignant mesothelioma. No effective treatment. So there is no effective treatment for malignant mesothelioma. One question is asked in relation to staging for malignant mesothelioma, and the name of staging is Bouchard staging. So what? Bouchard staging. Clear? So Bouchard staging, it is used for malignant mesothelioma. This is used for malignant mesothelioma. There is no effective treatment. Now, the very important topic is carcinoma lung or bronchogenic carcinoma. The term is bronchogenic. So, what is the origin? It arises from respiratory epithelium of bronchi, bronchioles, alveoli. So, mainly from which area it is going to arise? Mainly it arises from lung hilum. Carcinoma lung, mainly it arises from lung hilum. Clear? Important questions which are asked in relation to carcinoma lung, that this is the most common type of lung neoplasm. Most common type of lung neoplasm is the most common visceral malignancy worldwide and is the most common malignancy responsible for death. It is one of the most fulminant malignancy. So it's the most common type of lung neoplasm, most common visceral malignancy worldwide, and most common malignancy responsible for death. Now see, what are the risk factors? Obviously smoking, both active as well as passive smoking. So it's both active and passive smoking which is going to increase the risk. Air pollution, especially which component? Radon. Air pollution, especially which component? Radon. If there is exposure of uranium, nickel, asbestos, again it is going to increase the risk. And we discussed that what? Chronic asbestos exposure and smoking, these are having synergistic effect. So smoking and chronic asbestos exposure, it is having synergistic effect. It is having synergistic effect. Clear? Old infarct and lung scar. Old infarct and lung scar, it is going to increase the risk of which type of carcinoma lung? Adenocarcinoma. Since it is arising from lung scar, it is also known as scar cancer. So old infarct and lung scar is the risk factor for which type? Adenocarcinoma. Risk factor for which type? Adenocarcinoma lung. And you know, even ionizing radiation exposure is going to increase the risk of carcinoma lung. Carcinoma lung is further divided into central tumors and peripheral tumors. What are the tumors or malignancies which are included in central tumors? Divided into central and peripheral tumors. Clear? So which are central tumors? It is going to include small cell lung cancer and squamous cell carcinoma. So small cell lung cancer and squamous cell carcinoma, these are central, and which are peripheral? It is adenocarcinoma and large cell cancer. So it is adenocarcinoma in peripheral, adenocarcinoma and large cell carcinoma lung and large cell. Clear? So small cell lung cancer, squamous cell carcinoma, these are central. Peripheral are adenocarcinoma and large cell carcinoma lung. Right? Important point. The central tumors, for central tumors, smoking is a risk factor. For peripheral tumors, smoking is not a risk factor. So for central tumors, this you have to remember. For central tumors, smoking is a risk factor. So smoking increases the risk, and smoking is not a risk factor for peripheral tumors. So smoking is not a risk factor for peripheral tumor. Now coming to the clinical features. What is the most common symptom? So obviously you know that the most common symptom of carcinoma lung, it is chronic cough. Apart from cough, the patients are having dyspnea, there is chest pain, there is hemoptysis. So this question is asked frequently. What is the most common symptom? There is chronic cough. So it's chronic cough. Clear? Chronic cough followed by dyspnea, chest pain and hemoptysis. Dyspnea, chest pain, hemoptysis. So followed by dyspnea, chest pain, hemoptysis. Dyspnea, chest pain, hemoptysis. Obviously you will not forget the chronic cough. So you will not forget the chronic cough. How will you remember the rest three? It is DCH. So obviously it is chronic cough followed by DCH. Dyspnea, chest pain and hemoptysis. The question which is asked, that what is the cause of hemoptysis? Yes, which arteries are responsible for bleeding? So it's the bleeding from bronchial artery which is responsible for hemoptysis. So in carcinoma lung, the bleeding occurs from bronchial arteries. Hemoptysis, what is the source? Bleeding occurs from bronchial arteries. Bleeding occurs from bronchial arteries. And we discussed one more question. What? In patients of hemothorax, blunt trauma to the chest, it leads to rib fracture. And because of rib fracture, there is torn intercostal vessels. So torn intercostal vessels were responsible for massive hemothorax. Here, hemoptysis is the bronchial arteries, bleeding from bronchial arteries, which are responsible for hemoptysis in patients of carcinoma lung. Next, in one of the exam, question was asked that what is the definition of massive hemoptysis? So whenever there is expectoration of more than 600 ml of blood in 24 hours. So massive hemoptysis, you have to remember the definition. What's the definition of massive? Definition of massive hemoptysis. Definition of massive hemoptysis. So here there is expectoration of how much blood? More than 600 ml in 24 hours. Expectoration of more than 600 ml of blood in 24 hours. Now see the manifestations or clinical features of carcinoma lung because of endobronchial growth, the symptoms because of peripheral tumors, and the symptoms which are going to occur because of regional spread. So you already know that whenever the tumor is having endobronchial growth, because of that there is obstruction of bronchi, and these patients are having cough, stridor, there is wheeze, there is dyspnea, hemoptysis. Because of endobronchial growth, there is cough, these patients are having stridor, there is wheeze, dyspnea and hemoptysis. If there is peripheral tumor, so these peripheral tumors are going to involve the chest and pleura, and because of involvement of chest and pleura there is pain. So peripheral tumors are going to involve chest and pleura. So there is involvement of chest and pleura, involvement of chest and pleura, and because of involvement of chest and pleura, these patients are having pain. So there is pain in patients who are having peripheral tumors. Next is regional spread. So symptoms because of regional spread. If there is tracheal obstruction, patient will be having dyspnea, compression of esophagus, dysphagia, and if there is involvement of recurrent laryngeal nerve, there will be hoarseness of voice. So because of tracheal obstruction, obviously patient will be having dyspnea. Because of esophageal compression, dysphagia, and if recurrent laryngeal nerve paralysis is there, obviously patient will be having hoarseness of voice. There is Pancoast syndrome. What is Pancoast syndrome? Here, there is involvement of root value C8 and T1. Because of this, patient will be having pain in ipsilateral shoulder and arm. So in Pancoast syndrome, what's the problem? Which root value is involved? There is involvement of root value C8 and T1. And because of this, there is pain in ipsilateral shoulder and arm. And you know that which malignancy is responsible for this Pancoast syndrome? Mainly it is squamous cell carcinoma. Horner syndrome. So if there is involvement of cervical sympathetic trunk, there is Horner syndrome. What happens? Especially small cell lung cancer, it is going to cause compression of superior vena cava. And if there is compression of superior vena cava, this is known as what? Superior vena cava syndrome. It is mainly because of small cell lung cancer. And patient will be having malignant pleural effusion. Got it? So these are the manifestations because of regional spread of carcinoma lung. Now see the main problem with carcinoma lung, it is metastasis. Carcinoma lung, it is one of the most fulminant malignancy. What is the most common site of metastasis? It is brain. This is asked frequently. It is not adrenal, it is brain. Brain followed by bone. It is followed by bone, followed by liver, liver, followed by adrenal, followed by contralateral lung. It goes to contralateral lung. So liver, adrenal, lung. Okay. So the most common site of metastasis, it is brain. Right? How to remember? The mnemonic is, you can see here, BB Lal. It is BB Lal. So mnemonic is BB Lal. BB Lal. Got it? So brain, bone, liver, adrenal, lung. Second problem, apart from metastasis to these sites, carcinoma lung is the most common primary for metastasis to 6 organs. So how to remember? Carcinoma lung is the most common primary for metastasis to key paps. Key paps. The mnemonic is, it is key paps. Key paps. Clear? So K, that is kidney, E, esophagus, P, pancreas, A, adrenal, B, brain, S, skin. And out of these, we already discussed that what is the most common site of metastasis? It is the brain. So the most common site of metastasis in patients of carcinoma lung, it is brain. What is the investigation of choice for diagnosis? Obviously, we go for biopsy. So what kind of biopsy is done? We go for bronchial or endobronchial biopsy. So investigation of choice for diagnosis, biopsy. What kind of biopsy? Either we can go for bronchial biopsy. It is bronchial biopsy or endobronchial biopsy. So bronchial or endobronchial biopsy, and it is done via or done by fiber optic bronchoscopy. So bronchial biopsy or endobronchial biopsy, it is done by fiber optic bronchoscopy. Next question, what is the best imaging modality for diagnosis as well as staging? Best imaging modality for both diagnosis and staging, and obviously it is PET-CT. It is PET-CT, best imaging modality for diagnosis and staging, PET-CT. See the WHO classification of carcinoma lung. There is adenocarcinoma, squamous cell carcinoma, small cell carcinoma, large cell carcinoma, right? First, most common type worldwide, the most common type it is adenocarcinoma lung. So worldwide, most common type, it is adenocarcinoma lung. And which one is the most common type in India? Most common type in India. So most common type in India, squamous cell carcinoma. So squamous cell carcinoma, that is the most common type in India, right? You know that adenocarcinoma and large cell carcinoma, these are peripheral tumors, and squamous cell carcinoma and small cell carcinoma, these are central tumors. These are central. Adenocarcinoma and large cell carcinoma, these are peripheral tumors, and we discussed that peripheral tumors here, it is not associated with smoking, and central tumors here, these are associated with smoking. So these are associated with smoking, central tumors. Peripheral tumors are not associated with smoking. One by one we are going to discuss. First, we are going to discuss the most common type, that is adenocarcinoma lung. So see the important questions. The most common type is adenocarcinoma. It is peripheral. That's why it is not associated with smoking. It is not associated with smoking. If you see a typical patient of carcinoma lung, typically carcinoma lung is seen in elderly males who are smokers. Typically, it is seen in elderly males who are smokers. But if you see adenocarcinoma lung, it is seen in young females who are non-smokers. So more common in young females. It is more common in young females who are non-smokers. This you have to remember. Young females who are non-smokers. The tumor is having slow growth. But what is the big problem? These tumors are having aerogenous spread. And because of aerogenous spread, what is the problem? It is having propensity to metastasize to opposite lung. So because of aerogenous spread, it is having propensity to metastasize to contralateral lung. So it can metastasize to contralateral lung. There is a classification which is used for adenocarcinoma lung, and what is the name? Noguchi classification. The name of classification. The name of classification which is used for adenocarcinoma lung, it is Noguchi classification. This is what? This is Noguchi classification, right? Adenocarcinoma, it is associated with clubbing. You will find acanthosis, there is thrombophlebitis, and there is scar or infarct. Since it arises from scar or infarct, it is also known as scar cancer. Arises from old scar or infarct, so it is also known as scar cancer. How to remember? The mnemonic is adenocats. Yes, it's easy to remember. It is adenocats. Means adenocarcinoma lung, it is associated with cats. So adenocats, C means clubbing, A means acanthosis, T means thrombophlebitis, S means scar, oblique infarct. Now see this tumor and tell me what is this type. First see the location. If you see the location, it is located centrally. This tumor is located centrally. So central tumors are squamous cell carcinoma and small cell lung cancer. Squamous cell carcinoma and small cell lung cancer. So first, since it is located centrally, it can be squamous cell carcinoma or small cell lung cancer. But can you see the second feature? Here you can see that there is necrosis. And because of this necrosis, what? There is cavitation. Can you see the cavity? So there is necrosis and cavitation. Question, which tumor is having necrosis and cavitation? Necrosis and cavitation, it is typically seen in squamous cell carcinoma lung. So what is the diagnosis here? This is a typical case of squamous cell carcinoma lung. Squamous cell carcinoma lung, which is central tumor and it is having necrosis and cavitation. So squamous cell carcinoma lung, it is central. That's why it is associated with smoking. It's a central tumor. So it is associated with smoking, and we already discussed that this is the most common type in India. It is having central necrosis and there is cavitation. Squamous cell carcinoma lung, it is associated with increased PTHRP. PTHRP means parathyroid hormone related peptide. And because of this, this tumor is associated with hypercalcemia. It is associated with hypercalcemia. Which tumor is associated with hypocalcemia? Small cell lung cancer. Small cell lung cancer, it is going to secrete calcitonin. Because of that, there is hypocalcemia in small cell lung cancer. Squamous cell carcinoma, it is going to increase PTHRP. That's why these patients are having hypercalcemia. It is having best prognosis. Next, if you see Pancoast tumor is histologically squamous cell carcinoma, followed by adenocarcinoma, followed by large cell carcinoma. So if you see Pancoast tumor, histologically, if you see Pancoast tumor, histologically, it is squamous cell carcinoma, followed by adenocarcinoma, followed by large cell carcinoma. Large cell carcinoma, right? You know that Pancoast tumor, these are peripheral. So squamous cell carcinoma, usually it is central. It's the peripheral squamous cell carcinoma which is responsible for Pancoast tumor, right? How to remember? Mnemonic is Pancoast Sala. It is Pancoast Sala. Means S means squamous cell carcinoma, A means adenocarcinoma, LA means large cell carcinoma. And again, I'm going to discuss that what squamous cell carcinoma lung, it is having best prognosis. Now see this tumor is having hilar mass. You can see here, hilar mass, and there is mediastinal lymphadenopathy. Clear? So this tumor is having hilar mass, 2 important points. There is, obviously it's central, there is hilar mass, there is mediastinal lymphadenopathy. So if there is hilar mass and there is mediastinal lymphadenopathy, clear? And you see biopsy findings here, you can see the small cells. The cells are small with little cytoplasm. This is also known as oat cell. Clear? So this is obviously small cell carcinoma. There is hilar mass, mediastinal lymphadenopathy. So what is the problem? It is going to compress superior vena cava. And because of compression of superior vena cava, the manifestations are known as superior vena cava syndrome. So indirectly this question is asked that which type is most commonly responsible for superior vena cava syndrome? It is the small cell lung cancer. So first clue, the cell is small. The cell is small and it is having very little cytoplasm. That's why it is also known as oat cell. This is also known as what? Oat cell. So the cell is small with little cytoplasm. So this is also known as oat cell. This is the most malignant type of carcinoma lung. And you know the location, it is central. Since it is located centrally, that's why it is associated with smoking. Question is asked, which type is strongly associated with smoking? So it is the small cell carcinoma lung. It is strongly associated with smoking. Strongly associated with smoking. Strongly associated with smoking. Clear? So it is strongly associated with smoking. It is most responsive to chemotherapy. Which agents we give? We give cisplatin and etoposide. So strongly associated with smoking, most responsive to chemotherapy. The agents given are cisplatin. We give which agents? Cisplatin and etoposide. So agents we give, that is cisplatin and etoposide. We discussed that there is massive hilar or mediastinal lymphadenopathy. There is mediastinal invasion and there is perihilar mass you saw here. Yes, because of this, there is compression of superior vena cava. So this is associated with superior vena cava syndrome. So most common type which is associated with superior vena cava syndrome, it is small cell lung cancer. So apart from responsiveness to chemotherapy, it also shows the response to radiotherapy. This is one aspect. The questions which are asked frequently, that what are the hormones produced by small cell lung cancer? So there is increased production of ACTH, and because of this ACTH, it can cause Cushing syndrome. Because of increased production of ACTH, it can lead to Cushing syndrome. There is release of gastrin-releasing peptide. There is release of calcitonin. So it is going to secrete calcitonin. And because of calcitonin, obviously, patient will be having hypocalcemia. We discussed that squamous cell carcinoma, it is going to secrete PTHRP. And because of that, there is hypercalcemia. In small cell lung cancer, release of calcitonin. Because of that, there is hypocalcemia. There is secretion of arginine vasopressin. And because of increased secretion of arginine vasopressin, it is going to cause SIADH, syndrome of inappropriate ADH secretion. And ANF, that is atrial natriuretic factor. So these are the substances which are being secreted. And how to remember? Mnemonic is aa gaya CAA. CAA, aa gaya. So you can see aa gaya CAA. Clear? So aa gaya CAA. Right? So A is ACTH, G, that is gastrin-releasing peptide, C, calcitonin, A, arginine vasopressin, and atrial natriuretic factor. Next is large cell carcinoma lung. So it is peripheral, obviously, not associated with smoking. It is highly undifferentiated. And since it is highly undifferentiated, that's why In large cell carcinoma, there is early metastasis. There is early metastasis. And since there is early metastasis, what's the big problem? There is poor prognosis. So early metastasis, and because of that, there is poor prognosis. So these patients are having poor prognosis. So peripheral, highly undifferentiated, early metastasis, poor prognosis. What's the name? Large cell. So what's the problem? In males, there are large breasts. So which tumor is associated with gynecomastia? Large cell carcinoma. How to remember? Large cell carcinoma lung leads to large breast in males. So what is the problem here actually? There is increased secretion of estrogen. So there is increased secretion of estrogen, and because of that, patients are having gynecomastia. It leads to gynecomastia. This is very, very important. Almost every year, you will find one question directly or indirectly from carcinoma lung. Now see the one-liner questions which are asked in relation to cardiac tumors. First, you tell me what's the most common primary cardiac tumor, and you know it is myxoma. Most common primary cardiac tumor, that is myxoma. Clear? Second, what is the most common malignant tumor of heart? Heart is also a vascular channel. So most common malignant tumor of heart or vascular channels in adults. Obviously, it is angiosarcoma. So most common malignant tumor of heart or vascular channel in adults, that is angiosarcoma. It is angiosarcoma. Next, what is the most common benign tumor of heart in children? In children, it is rhabdomyoma. In children, it is rhabdomyoma. Now make this rhabdomyoma malignant. So see the question, most common malignant tumor of heart in children. So obviously it is rhabdomyosarcoma. What's the name? This is rhabdomyosarcoma. Clear? Next, what is the most common tumor of cardiac valves? In cardiac valves, there is papillary fibroelastoma. Most common tumor of cardiac valves, papillary fibroelastoma. It is papillary. So this is papillary fibroelastoma. This is fibroelastoma. Okay. So papillary fibroelastoma. Next, what is the most common site of involvement in cardiac metastasis? If there is metastasis to heart, what is the most common site of involvement? There is pericardium. There is involvement of what? Pericardium. In cardiac metastasis, there is involvement of pericardium, and you already know what is the most common primary for metastasis to heart. In males, it is carcinoma lung, and in females, it is CA breast. So most common primary for metastasis to heart in males, in females. In males, it is carcinoma lung. In males, it is carcinoma lung, and in females, it is carcinoma breast. Clear? So in females, it is carcinoma breast. Now see the chest wall tumors. What is the most common chest wall tumor? It is metastasis. Most common chest wall tumor, that is metastasis. This is metastasis, right? Next, what is the most common primary chest wall malignancy? Chest wall malignancy, it is chondrosarcoma. Primary chest wall malignancy, this was asked recently, it is chondrosarcoma. This is chondrosarcoma, okay? And what is the most common benign primary chest wall tumor? It's benign, so it is osteochondroma. Most common benign primary chest wall tumor, this is osteochondroma. Osteochondroma, clear? So this is osteochondroma, clear? So this is all about thorax and mediastinum.